Can you hear me? Hello?
Session. If you would like to ask a question, please press star, then 1, and record your name clearly when prompted. Please be advised that today's conference is being recorded. If you have any objections, you may disconnect at this time. Now I would like to turn the meeting over to David Dela Cruz. Thank you. You may begin.
Thank you, operator. So welcome, everybody. This is David Dela Cruz. I am the designated federal official for the Secretary's Advisory Committee on Infant Mortality. It's my honor to open up this meeting and get us started over the next 2 days. This is going to be a fully remote webinar-based meeting, so I ask your patience and your cooperation to make sure that we're all as fully engaged as possible. So without further ado, let me pass it over to Morgan, who is going to be giving you some housekeeping information.
Sure. So my name is Morgan. I'm the logistics coordinator. Some of you might have heard from me regarding getting your presentation, so thank you everyone for doing that. So the general thing is, if you're next on the agenda to present, the operator will promote you to presenter so that your line will be open, and the Adobe Connect folks will promote you to presenter so that you'll be able to advance your own slides. If you don't want to advance your own slides for whatever reason, just let me know, and I can advance them for you. You can just say next slide. And then for everyone else that is not presenting, during discussion portions of the meeting, the operator will open everyone's line. But otherwise, your line will be muted while other people are presenting. But still, just be mindful, if you are on a phone, you can mute yourself, but this is kind of up to you. So yeah, that is it.
Okay, great. Thank you, Morgan. So without further ado, let me pass it over to our chairperson, Dr. Ed Ellinger. Sir?
David, thank you. Good morning, everyone, and welcome to this virtual meeting. I am in Rockville because I didn't want to kind of coordinate any of this from my kitchen table in Minneapolis. Particularly, I wanted to get out of Minneapolis because I wanted to avoid the March Madness, which has spilled over into April in Minneapolis. And I'm really glad that I'm here because, as we noted, we're starting a little late, and I noticed that on my agenda it says all times are EST. I assume that meant Eastern Standard Times, but I think it means estimated. So we will try to keep as much on schedule as we can. But thank you for being on this call. I'm particularly noted that we're at a fortuitous time to have this meeting. This is Black Maternal Health Week, and so we're going to be having a presentation tomorrow about maternal mortality, which is good on this day. And it's also the anniversary of the death of Marian Anderson. And she was a contralto, and she was the first African-American to sing in the Metropolitan Opera. And she was also denied access to Constitution Hall for a concert. So the Roosevelts, Eleanor and Franklin, invited her to sing in front of the Lincoln Memorial. And she did that on April 9th, 1939. She has a couple of quotations that I think are relevant to what we're going to be doing over the next couple of days. She says, one, there are many persons ready to do what is right because in their hearts they know it is right, but they hesitate, waiting for the other fellow to make the first move. And he, in turn, waits for you. We want to be a little more gender inclusive, but people wait. And I think people are waiting for us to actually do something. We've dealt with this issue of infant mortality for a long time, and we've not made the progress that we want. And you'll hear that over the course of the next 2 days. We're not making satisfactory progress, both in terms of the numbers of deaths prevented, our infant mortality rate, and the disparities that are there. So, people want to do what's right, but they're waiting for somebody to act. I think it's attendant upon us to be sort of the precipitator of some of that action. Anderson also said leadership should be born out of understanding of the needs of those who would be affected by it. So we want to be science-based, but we also want to listen to the voices of the people who are being affected by infant deaths and really mothers and families and fathers and families and communities and families. We want to hear what's going on. And then I particularly like this quotation of hers where she was talking about discrimination, and we'll be talking about equity sometimes during our meeting. She said, sometimes discrimination is like a hair across your cheek. You can't see it, you can't find it with your fingers, but it keeps brushing at it because the feel of it is irritating. I mean, it is one of those things that it's hard to really identify exactly, but you know it's there. And so we're going to be talking about equity over the course of the next couple of days, and that's going to be part of our charge. So it's good that we're all together. This is important work that we're going to be doing. Babies are dying every single day, and I was just talking with Michael Warren, and he talked about the infant mortality rate. But when you look at the rate, it really translates into 22,000 deaths per year of babies dying, and which I don't know how many 747s that would be, but that would be a lot. And yet we don't have a sense of urgency in dealing with this, and particularly as compared to other countries, we're not doing as well as we could. And so there's a sense of urgency. So we need to figure out over the course of the next 2 days how we want to organize our work so that when we get together again in the fall or next December, whenever our in-person meeting is, we're ready to actually start to make some recommendations. And so today we're going to be, over the next couple of days, we're going to be setting some frames on how to do that. And you've got the objectives that we have for this meeting. One, we want to make sure that we get the right membership on this committee, and Belinda is going to lead us in some conversations about that. We want to look at what are some of the immediate opportunities that we have. What can we take advantage of in the short term while we're setting the stage for the long term? And then we really want to clarify our commitment to improving equity in our country and reducing the disparities. So we've got a lot of work ahead of us. We've got a full agenda. I also realized sort of a rookie mistake when I took on this chairpersonship back in December and setting up this meeting. Didn't know how much flexibility we have. We probably should have had 2 one-day meetings, virtual meetings, as opposed to a 2-day meeting, but we've got what we've got, so we're going to make the best of it. And I am going to, I've talked to David and I've talked to Michael, and we're going to see if we can't, over the course of the next little bit, see if we can't get another in-person meeting. I'll agitate for that because I think this work is so important that we really need to get together a little bit more often personally than once a year. But no promises, but that's something that I will be working on as the chair. So with that, I want to go around and find out who's here, and I want you to introduce yourselves. And I think we will, I'm going to get the list of members here so that I can, probably go in alphabetical order to introduce ourselves. And I asked you to prepare for this meeting to really reach out to the people that we're accountable to, the people that we work with, the people that we're partners with, and really inform them about SACIM, and then find out from them what would be helpful in their work. So I know that many of you have done a lot of things over the last 4 or 5 months, but I want you to just do 1 or 2 things that you've done since the first meeting to make stakeholders and constituents aware of the work that we've done and make the work of SACIM, and then what have you learned from them about how SACIM might be able to be helpful in their work. So let's start with Jean Conroy.
So operator, can you open up the lines, please?
Yes, 1 moment, please.
Hi, this is Jean Connery. Can you hear me?
Yes, very good. Good morning, Jean.
Okay. Good morning. I'm actually calling from Paris, so having it virtual actually works very well for me. I am past president of the American College of Obstetricians and Gynecologists, so I bring a distinctly maternal flavor to the discussion, and I think that's my liaison work with ACOG is probably the strongest. I am also president-elect for the International Federation of Gynecology and Obstetrics, working on global women's health and global maternal mortality. I have worked with ACOG in 2 respects. We have a Council on Patient Safety, so I've shared the work of SACIM with the leader of that, Dr. Barb Levy, and then I chair the Women's Preventive Services Initiative. That is a HRSA-supported, HHS-funded program to look at well women health care so that women are healthy before they conceive and during pregnancy, providing guidance around the country on what we need to do to optimize the health of women. So I would say my focus is always going to be the maternal aspect, and so I look forward to tomorrow. I've summarized the work that's going on, although ACOG is in a real transition right now, and we're not going to have a CEO for another month, and at that point then I can apprise the CEO of what we're doing. Thank you.
Thank you, Jean. I probably should have said and good afternoon, because it's early afternoon there, isn't it, in Paris?
Yeah, it's 4 p.m., yeah.
Oh, so you're going to be working late into the night.
You know what? It works out great for me to do it that way. So actually the timing is always great. Thank you.
Good. Well, and I appreciate the people in California who are starting this meeting at 7 in the morning, which is, you know, David wanted to start an hour earlier, and I said, no, we can't get people started at 6 o'clock in the morning. That would not be humane. All right, let's go on to Vijaya Hogan.
Can you hear me?
I can, Vijaya.
Okay, great. Hi, everybody. I'm Vijaya Hogan. I was formerly a program officer with the Kellogg Foundation and now working as an independent consultant. I have to admit, since our last meeting, I've been really busy in transition, so I haven't done a whole lot in terms of sort of disseminating the renewed work of SACIM. But while I was still at the foundation, Kellogg has organized program officers across all of the places where they work into specialty chapters. So there's a health chapter. And so before I left, we started to work on figuring out how to get all of the program officers across the country up to speed on maternal and child health work and what are some of the most important issues. And so I strongly suggested that they participate in SACIM, listen in on the meeting and participate to the extent possible, and hopefully also bring along some of the place-based constituents that they work with. So there you have it. I think that I'm not sure if you wanted us to talk about our particular interests, but I'm really glad that the committee is going to be focusing on equity because that's my passion and that's what my work focuses on. So I'm really excited to move that forward.
Right. Thanks, Vijaya. Good to hear your voice.
Thank you.
Paul Jarris.
Hello, Dr. Ellinger, can you hear me?
I can hear you, Paul.
Very good. Hello. So it's a pleasure to join you all again right now. Over the last couple of months, I've taken a new position with the MITRE Corporation, M-I-T-R-E, that comes from MIT Research Laboratories. This is where the organization was founded. MITRE is a nonprofit, and it's called a federally funded research and development corporation. So it hires scientists and engineers and software engineers, things like that. And we work exclusively back with the federal government. So we have what's called the Health FFRDC with HHS. And the idea is we're supposed to work on big, hairy problems on behalf of the government side by side. So much of the work we're involved, which can be cool. With that, I've been working on a rural maternal health project with CMS. Again, we do this in the background, but I've been very interested, engaged, in really learning about the environment, the disparities that exist there with people of color as well as with people who are impoverished. Also working on different research initiatives. So one of the things MITRE does is, on behalf of the federal government, is takes on research projects. One is to develop a database and analyzing multiple data sources to try to build a model for how different policy and programmatic interventions can affect maternal mortality in states. Another is just being proposed now, which is to look at optical character recognition to extract chart information from multiple sources to support the maternal mortality review committees. Because a number of them, particularly the big five, just don't have the capacity to really extract from all charts. So I think it's a pretty cool project. And if we are able to do that, we try to use machine learning and artificial intelligence to create connections across the states to learn more about maternal mortality. And then finally, I gave a lecture to every year to the first years at Georgetown Medical School, and with that used maternal mortality and infant mortality, particularly the historic disparities, as an example to talk to them about population health and public health. I'm done, Ed.
Good. All right. Thank you, Paul. I look forward to your contributions in your new role, and I hope you bring that brings a whole lot of additional information to our SACIM committee. Colleen Malloy. Colleen, are you there? Okay. Unmute your phone or your computer. I'm not hearing Colleen, so we'll skip over Colleen for right now, and let's go to Janelle Palacio.
I hear her.
Can you hear me?
Janelle.
I can't really hear you. I can't hear anything. I think I'm unmuted, but I can't hear a thing.
We can hear you.
Is this Colleen? Janelle? Colleen?
Try again. Can you hear me now?
I can hear you.
So weird. Okay, I think I can't hear you while I'm talking, but maybe I'll just whip through. So I'm a neonatologist at Northwestern. I'm involved in a number of committees that are devoted to neonatal and maternal health. For example, there's an ongoing maternal and neonatal opioid project that we're working on in Illinois to help mothers battling with opioid addiction and the babies that are born addicted to opioids. It's a really good project that's working on keeping the families intact and not just putting the babies into foster care, for example, but kind of working through to help support the mothers and the babies and the family unit kind of stay together as both patients are treated. I also been working on a paper that was just published that focuses on many prenatal and perinatal diagnoses that maybe 10 or 15 years ago would have been thought to be untreatable, but now there's a number of different things we can offer in neonatology, all the way up to including fetal surgery for a number of different conditions that in the past there was really nothing we could do. And then I was interested to hear Paul talk about his approach to extension into rural health, because I'm also getting my master's in health informatics, and a big focus, I think, on the ability of telemedicine to bring medical care to people who are kind of out of reach for that, including in urban settings as well as rural settings. And just in general, when you talk about like the stakeholders, I think involving like working with families and mothers and babies and fathers every day, and kind of trying to hear from them what's most important to them for the survival and best outcomes for their babies.
Good. Thank you, Colleen. That'll be a good perspective to share with the committee as we have our conversations. All right, Janelle, are you there now?
It's stressful. Oh, this is so hard.
Janelle Palacio? Logged in? Yeah.
Mm-hmm. She's connected.
Yeah, we can hear some talking there. Now I'm really glad I'm here in Rockville and not at home wondering what in the world do I do next.
All right, Janelle is typing.
No. No.
No?
No, she just typed in, can you hear me? The answer is no, we can't. Colleen, we heard you though. Thank you. Try again, Janelle. Our microphone's on now. We skip and come back.
Yeah. All right, while we try to work on Janelle's conversation, let's go to Magda Peck.
Okay, is that working and can you hear me?
Yes.
I am speaking. Can you hear me?
Yes, I can hear you. We just turned up the volume a little bit.
Perfect. Good morning, everyone. The technology is always imperfect. It's a good reminder to us all metaphorically. This is Magda Peck, and I am working as an independent consultant with MP3 Health Group, particularly addressing systems change, equity, and women and children's health. I also am faculty member at the University of Nebraska Medical Center in the Department of Pediatrics and in Public Health, and former CEO, founder, and ongoing senior advisor to CityMatch, which is at the University of Nebraska Medical Center. I'm delighted to have a chance to participate, albeit virtually. It has been a fairly busy season for me with SACIM, which we'll come to later, reaching out to one set of constituents, which is prior SACIM members and other organizational stakeholders, as I have worked by charge of this committee to gather history about SACIM, about infant mortality reduction in the last 100 plus years, and the larger trajectory of systems of oppression in this country. So there is the feedback from folks who have been previously engaged. The general sentiment is, thank you for doing the work. It is important work to be doing, and a general enthusiasm that SACIM is having its third generation of a persistent set of health issues and inequities in this country. I have worked directly with the CityMatch organization as a member ex officio of its board, and trying to bring in the voices of local and particularly urban public health. And so mostly and working as well at the AMSHIP meeting and with others in practice. Most folks don't know what SACIM is. They don't understand that it has been around. There is a general sense of opportunity here and enthusiasm when people learn about this advisory committee. But we have a new generation of practitioners in maternal and child health since the 30 years of founding this advisory body. And so it's a fresh opportunity for folks to become aware of this entity and the opportunities that SACIM presents overall. Finally, I continue to work with schools and programs of public health as the founding dean of the University of Wisconsin School of Public Health and the founder of the School of Public Health in Nebraska. And I think that the MCH training programs in particular, which are funded by Title V, among others, are very interested in understanding a secretary-level impact potentially on healthy mothers, healthy babies, families, and fathers. So more to report on later. Thank you for the opportunity to serve.
Thank you, Magda, and appreciate all your work over the last 4 months on SACIM stuff. Let's go back to Janelle, see if we can get Janelle's voice heard among this august body, or this April body. Can you try again, Janelle? Not hearing anything, so let's go to Belinda Pettiford.
This is Janelle. Can anyone hear me?
Good morning, everyone. This is Belinda. I am head of the Women's Health Branch in the North Carolina Division of Public Health, which is part of State Title V. We are also the home of a federal Healthy Start site, so we're excited to continue that effort as well. We have a lot going on in our state. More recently, I've spent time with our perinatal health strategic plan team and sharing some of the vision of SACIM and trying to think through how it connects to our work. And with our perinatal health strategic plan, our focus is on equity as well as determinants of health. We actually use the framework that was developed by Vijaya Hogan and others on the 12-point plan. So we're looking at improving health care for women, and we added men to ours, as well as strengthening families and communities and addressing social and economic inequities. And we've got a team of about 40 folks that get together every other month to kind of provide updates and share what we're doing in this area and how we can strengthen the work that's going on in our state. You know, we're one of those states, like the rest of the country, that has really struggled with infant mortality and specifically our disparity ratio with numerous efforts. So we truly see the connection with the work of SACIM and as it connects to the work we're trying to do in North Carolina with our own perinatal health strategic plan. Our governor also earlier, a couple of months ago, released an executive order to focus on early childhood and really try to strengthen the work around improving early childhood health and education. And as a member of that team, we've had conversations and have made our work around improving birth outcomes a priority as being focused on equity. So we realize that we cannot continue to see improvements in our overall data in our state if we don't address the equity gap, if we don't address this whole disparity gap. So our team here in North Carolina is really excited about the work. There are things that they think they can contribute to based on our experiences here in North Carolina, but they're most excited to know that there's a group, a national group that's actually looking at it from the same perspective that we hope that it all can kind of come together. So I am also on the board of AMCHIPS. I've shared briefly with AMCHIP leadership what we're doing through this effort, and we'll share more details in the near future, as well as on the board for the National Healthy Start Association and sharing with them. So I think there's opportunities there that we can all work together.
Great. Thanks, Belinda. Let's go to Paul Wise.
Hi, this is Paul. Can you hear me?
Yes, I can.
Hi, everybody. I'm Paul Wise, a professor of pediatrics, health policy, and international relations at Stanford University. My work has long been focused on the impact of technical and clinical innovation on social disparities in perinatal, maternal, and child health outcomes. I'm also co-director of the Stanford Marcher Dimes Prematurity Research Center and participate in the national network of Marcher Dimes research centers and have raised the important work of SACIM within this context. Marcher Dimes is primarily focused on research activities, both applied as well as basic. But also at Stanford, we are heavily involved with the California Perinatal Quality Collaborative, as well as the Maternal Quality Collaborative, and are moving forward with focused equity initiatives using these two very large networks of practitioners and institutions. I also work globally. We have a emerging network on maternal, perinatal, and child health outcomes in migrant communities coming through government intention on the southern U.S. border, as well as a global consortium of global child health programs focused on improving perinatal and maternal outcomes. I just returned from meetings with Doctors Without Borders, MSF, which is starting a new initiative on improving maternal and perinatal outcomes in humanitarian settings, and that is related to a new initiative that I'm co-leading with the American Academy of Arts and Sciences, the London School of Hygiene, Tropical Medicine, and Chatham House in England on rethinking the humanitarian health response to violent conflict with a strong focus on maternal, perinatal, and child health outcomes. So I'll stop there.
Good. Thank you, Paul. Your portfolio will be very helpful to us as we have conversations about where SACIM goes. Let's go back to Janelle. Try again.
Okay. Can everyone hear me now?
Feel badly here. I know she's logged in, but
I enabled her microphone, so she should be able to talk if she's just on her computer.
either way. Yeah. All right.
Janelle, we can't hear you.
Yeah.
So can you try unmuting your own phone?
Yes, let me try that. Let's see. Can everyone hear me now? Okay, can people hear me now?
Oh, someone can hear her.
All right.
I think we just can't.
All right. Well, we'll skip over Janelle for right now. I'm going to go through the ex officio members just to see who's on the phone. I don't want them to give an introduction because everybody has their titles and things. But I want to know who's on the phone. Ron Ashford. Wanda Barfield.
Can you hear me?
Yes.
Hi, good afternoon, everyone. This is Wanda Barfield. I'm the ex officio for the SACIM committee and also an assistant surgeon general in the U.S. Public Health Service. I direct the Division of Reproductive Health at the Centers for Disease Control and Prevention in Atlanta. Ed, did you want me to talk a little bit about these things that we've done since December?
No, because because we want to move ahead a little bit.
Yes.
I'm hoping you can. We'll have some time when we get a chance a little bit later on.
Yes, thank you.
Okay. Wendy DeCourcy.
Hello. Hello.
Wendy, are you there?
Yeah, I'm here.
Good. Just introduce yourself.
Okay. Wendy DeCourcy from the Administration for Children and Families in the Health and Human Services. Our office is the Office of Planning, Research, and Evaluation, so we're sort of the research arm of ACF. And for those, we're sort of a subtle organization there, so we cover things like TANF, Head Start, Office of Child Care, Office of Refugee Resettlement, supports for families at risk or under pressure. All right.
Great. Thank you. Paul Kessner. Paul, are you there? All right. Felicia Collins from the Office of Minority Health.
Hi, this is Diane Rosinski. Captain Collins, I do not believe, is on the line right now, and I am staffing the meeting for her. I serve as the officer in the Office of Minority Health. The Office of Minority Health is in the Office of the Assistant Secretary, and our role is to provide expert guidance on minority health. We have a couple of programs through our planning initiative that concern reducing infant mortality and maternal mortality.
Great. Thank you. Dorothy Fink from the Office of Women's Health. All right, Karen Matsuko from Center for Medicare and Medicaid Services. Or Kristen Zickerman.
Janelle Palacio, J8.
All right, Iris Mabry Hernandez from Senior Advisor for Obesity Initiative, Center for Primary Care Prevention and Clinical Partnerships. All right, Danielle Ely.
Midwife.
From Vital Statistics. We know Danielle is logged on. Can't hear her voice. Maybe she's in the same car with Janelle.
She said she's here in the chat.
Okay. Cheryl Broussard, Vision, Congenital and Developmental Disorders. Elizabeth Schumacher, Employee Benefits Security Administration. Diana Bianchi, Institute for Child Health and Human Development.
Hi, this is Caroline Senior sitting in for Dr. Bianchi at the Eunice Kennedy Shriver National Institute of Child Health and Human Development.
Okay. Good. Take good notes. Suzanne Eglund, Great Plains Women's Health Service. Right. Brandon Lips, Food and Nutrition Service, USDA.
Wow.
All right, anybody else on the phone that's an ex officio that I didn't call? I think I got everybody who's officially an ex officio. Let's try one more time with Janelle, if we can. Janelle Palacio.
The previous time other people would hear her.
Okay, can you hear me
Okay,
now?
can you hear me now?
Perfect.
Oh, excellent, excellent, good.
Okay.
Okay.
Yeah, it was a little confusing.
Yeah, it was a little confusing.
I am Janelle Palacios. I am a nurse, midwife, and researcher for the Kaiser Permanente Medical Group in the Bay Area in California. I am a past co-chair of the Native Research Network, the largest group of Native American, Alaskan Native, and First Nation researchers, medical health researchers in the United States. And I've reached out to the NRN, and hopefully we will have someone join us at some point during this conference call. I'm also a member of the American College of Nurse Midwives, and again, maybe someone from ACNM will join our discussion or our meeting sometime these past 2 days. I have worked in the past with urban and rural communities, Native American communities, addressing teen parenting, most specifically teen pregnancy, and then also young parenthood, young fatherhood. And the work that I have done with both urban and rural communities on this issue is embedded in disparities, and especially when you look at historical experiences of a whole group of people, nations of communities together. NRN and ACNM are both interested in addressing health equity. And I've also connected to the University of California School of Nursing. Group that has a preterm birth initiative grant, and they address largely African American communities and looking at preterm birth. And so Linda Frank hopefully will join us at some point as well.
Very good. Good. Well, I'm glad you're with us, and I'm glad everybody is here. I skipped myself as I was having people introduce themselves. I'm Ed Ellinger, and I'm the acting chair of this committee. I'm a former state health official in Minnesota and worked for many years in urban maternal and child health with the Minneapolis Health Department. Since our last meeting, I've basically been talking up SACIM wherever I go in the work that I do in a variety of areas. And just a couple of examples are very specific. I've been working with teams in the Mississippi Delta with their breastfeeding coalition, and been working with a healthy Louisville team, I got to learn how to pronounce it, Louisville, on their child health initiative. And they had specific requests of SACIM. The Delta Breastfeeding Coalition said, whatever you can do to get hospitals to be baby friendly, that would really be helpful, because they're struggling with their hospitals to make the hospitals baby friendly to support breastfeeding. And Healthy Children Louisville had a very specific request. Can we get Medicaid to pay for doula services throughout the country, and other insurances to pay for doula services? And as I look at some of the data that they're bringing forward in terms of doulas, they do have an impact in improving infant health and also reducing disparities. So it's really good that they're paying attention to what we're doing and have some specific requests of us. All right, let us now move on to the second part of our agenda, or the next part of our agenda, reprove the minutes from the December 2018 meeting. I know it was hard to go through all of those pages and pages. I assume people went through very specific aspects of it that were relevant to them. Do I hear a motion to approve the minutes from the December 2018 meeting? All right, I got a motion to approve the minutes. Any corrections or additions to the minutes that anybody has? Not hearing any. I'll take. I move approval. Everybody say aye. Those who oppose say nay.
Aye.
All right. Very comprehensive minutes. Thanks for all of that information. It's good history of what we do. You have the agenda before you. It's a packed agenda. I got input from a whole variety of folks on this agenda, and we'll try to stick to it as best we can. Now, Michael Warren was supposed to be here at 10:45, but he has a meeting with the HRSA administrator, and so he will be coming in as soon as he can, and I'm hoping it's relatively soon. But given that, I do want to then follow back on to Dr. Barfield, from the Division of Reproductive Health, and want to find out a little bit about what she's been doing since our last meeting related to SACIM activities. Dr. Barfield, are you still there?
Yes, can you hear me okay?
Yes, I can hear you very well.
Thank you, thank you. So I just wanted to share what we've been doing since the December 2018 meeting. As you may recall, you heard from Dr. Lee Warner, who is the chief of the Women's Health and Fertility Branch, who provided an update on the Pregnancy Risk Assessment Monitoring System and how we're now increasing the availability of data as well as the timeliness of the data. 2017 data is out, and we're anticipating having 2018 data within the year. And he also shared some of the new work on perinatal issues in the opioid epidemic, and talked a bit about some of the work supported by CDC's Opioid Response Coordinating Unit that's focusing on supplemental questions and PRAMs, focused on maternal mortality due to opioid overdose, as well as state-initiated work to try to address opioid use disorder and the challenges of neonatal abstinence syndrome. We're also doing work with quality improvement collaboratives to try to address the opioid epidemic as well through state PQCs. You also heard a little bit from Lieutenant Commander Sharon Parks Brown, who talked a bit about sudden unexpected infant death syndrome and is continuing to do work in that area as well. We're trying to focus a lot over the more recent months on recent funding that we received as appropriation to try to address maternal mortality through funding of states for maternal mortality review committees, and this work is being done in collaboration with the Maternal Health Bureau, and as we're all collectively and other federal agencies as well are trying to address this important issue. So I'm hoping that I'll be able to talk with you a bit more about that tomorrow. And one of the challenges that Dr. Ellinger had raised was what are the issues around maternal health, and how can this committee think about maternal health in the context of infant mortality and morbidity. Thank you.
Good. Thank you, Dr. Barfield. Oh, and just as we speak, Dr. Warren has walked into the room. So we don't have to get too far off of our schedule. So I'm going to let Michael get set up here. It's good to see most federal officials are very busy doing the people's work. So Michael, welcome. Yep, go ahead.
Good morning. Thank you all for the opportunity to join and give a few updates from the Maternal and Child Health Bureau. As Dr. Ellinger mentioned, it has been a busy morning already. We're in the middle of budget planning session, and so I've been out working on that, but happy to join you all for the rest of the meeting and share some updates. Just a few program announcements to start with. I want to share some information about new MCHB leadership, an update on Healthy Start, and then briefly some updates on both maternal mortality and Title V, and then share some thoughts with you. So we are excited to announce a number of new division directors. Some of these are new to HRSA and MCHB. Some of them have been here in an acting role, and we're happy to announce them as permanent. But in our Division of Child, Adolescent, and Family Health, Dr. Sarah Kinsman, who comes to us most recently from Philadelphia, the City Health Department there. She's an adolescent medicine trained pediatrician. Dr. Tiffany Mcnair joins us as the Division Director for Healthy Start and Perinatal Services. Dr. Mcnair is OBGYN trained and most recently joins us from CMS, and so we are excited to have her on board. Cindy Phillips is the new Division Director for Home Visiting and Early Childhood Services. Cindy has been with HRSA and was the acting director of this division and has been around as McVie, the home visiting program, was being launched and implemented. And so we are excited to have her in that role permanently. And then Joan Scott, who has been in her role as Division Director for the Division of Services for Children with Special Health Care Needs for a while now, but we have not introduced her to the SACIM group, so we wanted to make folks aware. So these four folks are new division and office directors within the Bureau. An update on Healthy Start. The new project period started April 1st. We have 100 project sites that were announced on March 21st across the country. Those awards that went out totaled $107 million and are reaching 34 states, DC, and Puerto Rico. And importantly, these projects include $12 million in funding for maternal mortality. This is new money that we got in FY19, specifically to fund advanced clinical providers at Healthy Start sites. So thinking about how we look at that spectrum of care before, during, and between pregnancies, recognizing the link that we know so well between maternal and infant health, and being able to provide some resources for that. So we are excited about that and excited to see those projects get underway. A number of those sites, 82 or 83, I think, were existing grantees, and then 17 or so that are new in Healthy Start. This just gives you an idea of the geographic spread of those that I just mentioned. You can see those spread across the country there. And then in maternal mortality, folks know we've been talking about this topic at HRSA and the Bureau for a while now. There was money in the budget in FY19 for the first time specifically for maternal mortality. Prior to that, we had been investing in things like AIM, but there was new money in FY19, and HRSA actually hosted a summit in summer of calendar year 18 to look at this. And at that summit, we reflected on a number of the points that are here. We know that the rate of both maternal mortality and severe maternal morbidity are higher in the United States than in other Western countries. We know that common conditions leading to maternal death include those listed here, like hemorrhage or hypertension or thromboembolism, and that many of these conditions and causes are entirely preventable. There's also conversation ongoing about emerging causes, specifically thinking about opioid use and how that contributes to maternal morbidity. And we know, just like for infant mortality, that risk is not spread uniformly across the population. So there are certainly subpopulations that are at higher risk, and so we want to be thinking about how we can address those disparities. So I mentioned the summit that was last summer. It was an international summit hosted here at HRSA headquarters. There were representatives from the United States and then 6 other countries across the world, some of whom are doing better than us in the space of maternal mortality and morbidity, some who are doing not as well, but who have actually made some important improvements. And so there was the opportunity to share lessons learned and think collectively about what we might be able to do. Before the summit and before this last budget year, MCHB had been supporting the AIM initiative, so the Alliance for Innovation in Maternal Health. If you're not familiar with that, this involves providing funding for the implementation and deployment of safety bundles. These are collections of best practices. Think of these like toolkits deployed in birthing hospitals and other facilities that provide care to pregnant women or women who are delivering. And already we reach about half the births in the country, about 2 million births. There was funding in the new budget cycle to expand that to all 50 states, so we'll be able to cover nearly all the births in the country. So that leads us to this next slide. In the FY19 budget year we're currently in, there was $38 million in new funding, which is always exciting for maternal mortality. I mentioned already the $12 million that's going to Healthy Start, so that was included in the funding announcement that folks applied for and were recently awarded. The remainder of that money, the $26 million, part of that is going to expand AIM to all the states, as I just talked about, and then the remainder will be used to support state maternal health innovation awards. So we'll be releasing a funding opportunity later this fiscal year, so that means in the next few months, for states to apply to think about how they can innovate in this space to decrease both maternal morbidity and maternal mortality, and there'll be more information forthcoming in the very near future about those funding opportunities. Also want to briefly talk about the block grant. Folks who have been involved with this committee for a while are familiar with the block grant. It represents the oldest federal-state partnership. It was established formally back in 1935 with the Social Security Act and Title V, but even before that with the Shepherd-Towner Act, there were state and federal partnerships that were funded out of the Bureau. And this has grown to be the public health system for women and children in the United States. So if we look at the reach of the block grant, we reach about 56 million individuals. And to give you an idea of how that relates back to this committee specifically, through the block grant, states reach 86% of all pregnant women in this country and 99% of all infants. So really an opportunity to have a massive public health impact. The states are going to be doing their needs assessments over the course of the next year. So every 5 years, states have to do an updated needs assessment that's comprehensive and looks across MCH stakeholders to identify needs and priorities of that state. Those are due in July 2020, so there'll be an opportunity for stakeholders in various states to provide input on what those states should focus on. And then as part of that reporting, states will identify how they want to report on various national performance measures that roll up into our reporting framework that ultimately influences our national level outcome measures. And so a great opportunity for folks to connect with states and be able to influence those state action plans over the course of the next 5 years. There are a number of the national outcome measures that are related to the work of this committee, and so I just highlighted them here. There are about 36 different outcome measures, but as you can see, many of them relate to both women's or infants' health. And then there's a series of national performance measures as well, 15 of those, and as you can see, about a third of them relate to the work of this committee. Those measures are important from an accountability standpoint for us. They let us know, are we moving the needle on population health issues? And the outcome measures are what we're ultimately trying to impact, so things like infant mortality, for example. But as you all know well, by the time those measures are reported, the event has already happened. And so we want to think about how can we move upstream and see if the work that we're doing is going to move us in the direction we want to go in rather than waiting for the event to happen. So the analogy I frequently use is it's like going on a trip and you want to know if you're getting to your destination. Well, you want to know that before you realize that you're there or you're not there. You want to know, are you headed in the right direction? Do you need to change your course? Do you need to go faster or slower? And the performance measures allow us to be able to do that at a national level and let us know if we're moving in the right direction. So again, you can see the ones here related to the work of this committee. I want to wrap up by sharing some thoughts that we've been thinking about at the Bureau here. We've shared this now with a number of audiences, including AMCHIP and the AAP. And Dr. Ellinger was asking me earlier today about sort of what we're thinking about at the Bureau and the ways that we can work with SACIM on this. So just wanted to share some thoughts about how we improve maternal and child health. Here at the Bureau, our mission is to improve the health of America's mothers, children, and families. We are the only federal agency specifically designated with that purpose, and we take that seriously. And our vision is an America where all children and families are healthy and thriving and have a fair shot at reaching their fullest potential. The Bureau has been around a long time, as you all know, since 1912 as the Children's Bureau, and a lot of progress has been made since then, and yet we recognize despite all that progress, there's still a lot of work to be done. So if we look across the life course, despite the work that's been done, for example, we know that many adolescents don't get a well-child visit every year. We know that despite back-to-sleep campaigns that started in the early 90s, we've got many families who still choose to put their babies to sleep in unsafe positions. We have talked a lot about, particularly in the last few years, about high rates of both maternal morbidity and mortality. We know that despite decades of work on supporting the implementation of medical homes, that less than half of children who have special health care needs report receiving care in a medical home. And then back to infant mortality for this committee in particular, despite really great progress in reducing infant mortality since the founding of the Bureau, there's still much, much work to be done. When the Bureau was founded back in 1912, the infant mortality rate was far higher. We lost about 400,000 babies a year in this country at the time of that founding. And if you look more recently, in the last 30 years, we've cut the infant mortality rate in half. And so while we celebrate that, we know that there's much work to be done. So if we think about how to do that, we've been gelling around these ideas of accelerate upstream together, and I want to walk you through those briefly as I close today. So if we think about that first word, accelerate, that sort of conjures up images of get a move on or hurry up the work that we're doing. And so I'd like to go back to the example of infant mortality and talk about that. I mentioned just a moment ago in the last 30 years, we've cut the infant mortality rate in half in this country. So we've gone from roughly 11.8 to about 5.9. And while we want to celebrate that, and while that's a good thing, it's important to think about what does that mean. And we often in public health talk about rates, and I think it's easy to get complacent when we talk about rates and say 5.9, it's great, it's half of what it was 30 years ago. But what does that mean practically? And so I want to give you the example of a 747 airplane. Those hold about 400 people. Think about if there's a plane crash and 400 people die. What happens? What kind of investigations happen? What kind of uproar there is? How that changes the way we do business. Now think for a moment if there are 55 of those plane crashes in a year. That's roughly one a week. What would happen then? There'd be all kinds of task forces, investigations into why this was happening. We'd probably completely change the way we approach air travel in this country if 22,000 people died on airplanes. And yet, remember that's the number I just said of babies that die before reaching their first birthday every year. So thinking about how we elevate that conversation around what does a rate of 5.9 mean, 22,000 deaths a year, we can't be complacent there. How do we accelerate our pace of change? We want to acknowledge the work that's been done, but we also want to say we have a lot of work left to do and we need to quicken that pace. I think it's also important to think about while improvements have been made across the population, those have not been equally shared across the population. And so we know, and this committee has talked about before, the marked disparities between infant mortality rates, particularly among Black and white populations in this country. And so while the overall infant mortality rates have improved for both populations, as you can see on this slide, marked disparities still persist. So I want to give a shout out here to a friend of this committee and colleague, Dr. Arthur James, who has helped us think about this in a slightly different way. Rather than just saying, as we often do, the infant mortality rate is 2 to 3 times greater for one population than another, he introduced at the last SACIM meeting a different way to think about this. And so We can think about this, for example, in 2017, the infant mortality rate for black infants achieved the same rate as for white infants in this country. The problem was it was the same rate as white infants in 1980, so that's 37 years later, a 37-year gap. And so as we think about accelerating the pace of change, none of us can be satisfied with it taking 37 years to achieve equity in infant mortality rates. And so we have to accelerate the pace of our work there. Our epidemiologists here at the Bureau actually forecast this out. And so if we take the recent rates of change as a guide and we use the 2017 white infant mortality rate as a benchmark, if everything else remains constant, we could expect the black infant mortality rate to catch up to the 2017 white infant mortality rate either in 2069 or 2093. So anywhere from 50 to 70 years in the future. Again, not acceptable. And so we have to think about how we accelerate that pace of change to close that gap and eliminate those disparities in infant mortality, but that's emblematic of the other disparities that we need to be tackling as well. So accelerate is the first part of this charge of accelerate upstream together. The next is upstream. So some of you have probably heard the public health fable about the person who's walking along the riverbank, and they're walking along enjoying this beautiful day, and they hear splashing, and they look out and they see there's someone in the river that's crying out for help. And so they jump in and they swim out to the middle of the river. They grab this person and they bring them to the riverbank. And as they're helping them up onto the shore, they hear more splashing and they hear more cries for help. And so they turn around and look, and there's another person who's drowning in the river. And so they swim back out to the middle of the river. They grab this person who needs help and they start to bring them into the shore. And as they get to the shore and they're climbing up, you probably guessed it, they hear someone else crying. And so they turn around and lo and behold, there's someone else who's struggling in the river. Well, about this time, they see someone else walking along the riverbank. And so they call out to them and they say, hey, can you help me help save these people? And the person just keeps walking by and they say, hey, didn't you hear me? I need your help saving these people. Where are you going? And the other person says, I'm going upstream to see why these people are falling into the river in the first place. And so we have to think upstream about preventing these bad outcomes before they ever happen. You know, whether that's preterm birth. We're really fortunate. We've got great NICUs in this country that can take care of our tiniest and sickest infants. But if we could prevent preterm birth to begin with and think about how we make it more likely that babies go to term or at least go longer, we would be better off. So thinking upstream wherever we can. This is not new to public health. We talk a lot about prevention, but it's important to know that all prevention is not the same. And so how do we shift toward primary prevention where possible, preventing disease before it ever happens, recognizing that secondary and tertiary prevention is absolutely essential. We need it. We need to be able to screen for and detect disease early. We need to be able to treat disease once it's identified to prevent it from getting worse. But if we're going to move the needle on population health, if we're going to think about addressing some of the things that this committee is charged with addressing, like infant mortality, we have to move upstream and think more about primary prevention. In MCH, we think a lot about the various elements of primary, secondary, and tertiary prevention. And primary prevention, things like vaccination, breastfeeding, promoting a healthy built environment. And again, that's where we should focus, but it's not going to be sufficient to just focus there. We know that some individuals are going to fall through, if we think of this as a safety net, fall through that net and are going to need those secondary prevention services. In fact, sometimes the whole population may need them, like newborn screening or lead screening, but certain families may need additional resources like home visiting. And so how do we make sure those resources are there for folks who fall through that first net? And then we also have the need for tertiary prevention, so things like care coordination, early intervention, specialty care for children and youth with special health care needs, or high-risk care for certain moms and babies. Again, the whole population doesn't need those, but we need to make sure there's access to those so that those individuals who are in need of those can receive those as we think about improving population health. Another way to think about this is the life course model, and this is well known to this committee. We know that we all have an optimal health trajectory and that there are risk factors that can cause that trajectory to be dampened, or health promotion factors that can help elevate that trajectory. But if we think about how upstream works there, one of the important components of life course is thinking about the intergenerational influences. And so as we think about our own lives or our children's lives, thinking upstream about the impact of our own mother or father's life and their health and well-being, how that's translated to their offspring, and how that's in turn transmitted to the next generation. And so if we think about infant mortality, we can't look at the care of the infant in a silo. We have to think about the health and the well-being of the mother, and we have to think upstream even to the time before she's ever pregnant. So we have to think about preconception health. Now, we talk a lot about health, and a number of folks on the committee or those of us who work here are involved in clinical care. But what we know is that health care, clinical care, only accounts for about 10 to 20% of our overall health. And this has been borne out through a number of studies. So factors like social and economic factors or health behaviors or the community and the environment can play a much larger role in determining health. So not only do we have to think upstream about primary prevention, but we have to think about those other determinants and influencers of health, including social determinants of health, if we're going to make an impact on infant mortality. I share frequently when I talk to pediatricians the clinical example of obesity, and I show them a growth chart of a child's weight status who isn't improving, and I ask the question, why isn't the weight status improving? And is it that the pediatrician didn't bring them in often enough for office visits, for example, or did the pediatrician not counsel them on eating healthier foods or being more active? But then you look at the communities where patients might live. And so if the community, for example, looks like this, you might think about when you ask the question, why isn't this patient's weight status improving? What are those determinants of health? Is there a challenge accessing safe places for the child and family to be physically active? Are there resources at the school for physical education or for preparation of healthy meals? We have to factor in all those determinants and influencers when we're thinking about making a difference in child health. So I talked about accelerate, I talked about upstream. I want to mention this notion of together. We recognize in the Bureau that we don't do this work alone, and so we rely on our partners in the field, like those of you who are on this advisory committee. We rely on our state public health partners, we rely on our academic partners, our non-governmental partners, all these folks working together to help us improve maternal and child health in this country. And in the Bureau for many, many years, we've had a focus on the deliberate inclusion and engagement of families, and not just families sort of being present at meetings, but families as full partners. They are the reason why we do this work, and so we want to think about how we include them and their voice as we move forward. We also want to make sure that we are listening appropriately, and so I mentioned the needs assessment earlier. The states will be doing those next year. We'll have the opportunity to hear broadly from the field across the country about the needs and priorities of the MCH population, but we also appreciate opportunities like this advisory committee where we can hear from you and think about how we should be thinking about and designing and implementing our various programs that are aimed at improving maternal and child health. I want to just end to you with a quote. Some of you have heard me say over the last few months I've become a real fan of the history of the Bureau. It's remarkable to think about the 107 years that have preceded us and the trailblazers who have gone before us. And this is a quote from Grace Abbott, who was the second director of the Children's Bureau back in the 1921 to 1934 period. And Ms. Abbott had this quote: "Sometimes when I get home at night in Washington, I feel as though I'd been in a great traffic jam, moving toward the hill where Congress sits in judgment on all the administrative agencies of the government. In that traffic jam, there are all kinds of vehicles, the kinds of conveyances, for example, that the Army can put into the street: tanks, gun carriages, trucks, the dancing horses of officers. There are other kinds of vehicles in this traffic jam, great numbers of them: hayricks and the binders and the plows of the Department of Agriculture, the handsome limousines of the Department of Commerce, the carriages in which the Department of Justice officials sometimes appear. I stand on the sidewalk watching it become more congested and more difficult. And then, because the responsibility is mine, and I must, I take a very firm hold on the handles of the baby carriage and I wheel it into the traffic." And so as we think about the work of this advisory committee, as we think about the work of the Bureau, we are anchored in this notion of accelerate upstream together. We welcome our charge to move into the traffic, and we appreciate this opportunity to have this ongoing dialogue with you. So with that, I'll turn it back over to Dr. Ellinger. Pleased to be here. If we can be a resource to you at any time, please reach out.
Good. All right, everybody, put your helmet on and step out into the traffic. Anybody have questions or comments to Dr. Warren before we move on? I'm assuming the mics are open. The lines are open. Any questions, comments? While you're thinking, I do have one, and I've been in this field a long time, and you talked about the history, particularly Title V. Title V changed dramatically in 1981. I've worked with Title V before and after 1981, and our work was completely different. Has anybody really looked back on, was that block granting of Title V a good thing, a bad thing? Good things in some ways, bad things in other ways. Is it the model that we should still use for Title V?
So it's a great question. Folks have written a lot about the transition and the process. I have not seen, it doesn't mean that it doesn't exist, but I haven't seen sort of a before and after comparison. There may be other folks on the line. I know Kay Johnson is on, who is well versed in this, and so she may be familiar if there are things written. I'm not aware. I'd love to see if there are.
Yeah. All right.
We have one question.
All right.
This is Jean Connery. I have a comment.
Yes, please.
Well, first of all, I want to say thank you so much, because I believe part of working upstream is looking at maternal health, because if we don't have a healthy mom and we don't have a mom who survived labor, we aren't going to be able to even talk about infant mortality. So I appreciate all the work that Maternal Child Health Bureau has done with the AIM work. I think that is really going to change the course of the nation, and the Women's Preventive Services Initiative. I would also like to say, though, there are a couple other things that are truly important to keep our perspective. Contraception access and family planning are absolutely critical. We also know that environmental toxicants, like exposure to air pollution with prematurity, the impact of mercury, lead, and other toxics, or we heard you comment about obesity, and yet we need to be looking at obesogens. So when we're talking about these, we need to keep an environmental perspective at the same time.
I'm not talking about it this morning. Okay. I mean, but you're okay.
All right.
This is Magda Peck. Do you hear me?
Yes, we can. Go ahead, Magda.
Thank you. Dr. Warren, thank you so much for the update. I wanted to go to the beginning of your presentation, in which you announced new leadership as part of your team, and I'm just thrilled to see Dr. Kinsman, former member of the City Match Board, and Tiffany Mcnair and others. Thank you so much for filling in great leadership. Can you comment, Dr. Warren, about other reorganization that's being proposed at the Secretary's level? I love hearing what's happening within the Bureau. This advisory committee reports directly to the Secretary. And so this morning, the Association of Schools and Programs of Public Health reported on a proposed reorganization to move family planning and teen pregnancy prevention into the Office of the Assistant Secretary for Health. And I'm just wondering, can you give us any update about how the related programs beyond your Bureau are being potentially reconfigured, and does that have any impact on our working with ex officios, or does that have any impact on the Secretary's Advisory Committee?
Thanks, Dr. Peck, for that question. So I have not seen that report or those plans, so can't comment specifically on that. I would say generally the Bureau has tried to have a strong working relationship with our other federal partners. Clearly, there is a lot of work that happens that influences both children and mothers and families that is outside the direct scope of the Bureau, but perhaps somewhere within our influence. And so we work really closely, whether those are other federal collaborators within HRSA or within HHS or even in other departments. And so those collaborations are important to us, and we will continue to explore those. But without seeing that, I can't comment or speculate on that reorganization. I'm not seeing that plan.
Well, thanks so much. I appreciate that. And I just know I want to echo and underscore the importance of Dr. Conroy's remarks about intendedness of pregnancy and continuing to address the access to reproductive health services and their broadest continuum as an essential evidence-based approach to having best birth outcomes. So reorganization matters. Perhaps you could get back to us. Thank you so much.
Great. Any other questions of Dr. Warren? Paul Jarris? Paul?
And a lot of it, one of the things I just wanted to call out that I like so much is you're highlighting the intergenerational issues, because I think we clearly have to look at that if we're looking at a structural and structural factors leading to disparities. A couple other things I noted. You said that the Title V is going to be states going through an assessment, and I wondered about other substances in addition to the ones that they're looking at, such as opioids, methamphetamine, and marijuana, the use of all of which are increasing in women of reproductive age and during pregnancy. And then the last thing I'd say in terms of, you had a category of persistent challenges. I think vaccine hesitancy is becoming a very significant challenge for us in this country for maternal-child health, and I'm curious what the MCHP might be doing in regard to that.
Great questions. And I think the first part of your statement got cut off, so if I don't answer all your questions, happy to do those. I'll start at the end, the vaccine hesitancy issue. Clearly, the Bureau for a long time has supported vaccination efforts. I frequently refer to the block grant as the public health system for children and families in this country, and many states actually use those funds to provide core public health services, sometimes including supporting administration of vaccines, for example, in local health departments. And so the Bureau has long supported that. We were just at the AMCHIP meeting a few weeks ago and did a series of listening sessions with all the states and territories, and this notion of vaccine hesitancy came up. And so we are interested to learn more from the states as they go through their needs assessment in the coming year. The needs assessment provides an opportunity for them to look at emerging issues, and this was certainly one that they were talking about. And so as we hear from them or from other partners about ways that we may have a role, we certainly would be open to exploring that. Certainly if you think about vaccines as a larger issue, there are multiple players in the federal system, a large one being CDC that has a role in this as well, and so we work closely with them, but we'll be on the lookout for where we've got opportunities within MCHB. And then for your question that preceded that about the needs assessment and other substances, that's exactly why the states do these needs assessments every 5 years. We recognize that needs and priorities change in a given state over time, and new issues may emerge. And so folks have been talking about opioids for a while. We started to see those creep into the last needs assessment 5 years ago, but that was even for many states sort of on the cutting edge as they were starting to see more neonatal abstinence syndrome, for example, or more substance use disorder during pregnancy. So I would anticipate, and again, based on what we heard at AMCHIP, almost every one of the listening sessions states talked about substance use disorder, but a number of states mentioned other substances, so you mentioned marijuana, and states mentioned that as well. So I anticipate we will see some of that. The other thing that we've been talking about in the Bureau is it's important not to lose sight of the fact that right now folks are talking a lot about opioids. That's what's right in front of us. But there's going to be another substance after that. If we look at the history of substance use disorder in this country, we go through waves of substances. So there will be something else. But importantly, we also have to think about what are those antecedents of all of these various substance use disorders. And so how do we think upstream there? How do we think, for example, about trauma and the impact of that on individuals and later correlates? And so hopefully as states are thinking about ways that they can address this and they can use our block grant funds to address this or ways that they would like the Bureau to support it, folks will not only focus on what's in front of them, whether that's opioids or marijuana or whatever it is they bring to the table, but also those root causes that really, if we're going to move a needle, we have to make some progress in addressing.
Okay, just one follow-up thing. Thanks for your very thoughtful answer. I think one of the places MCHB can focus is on that pregnancy and early childhood in particular. For example, I went to an HHS-sponsored meeting at the press club on influenza vaccine, and I was very surprised and concerned that none of the federal officials that spoke talked about pregnancy and flu vaccines. they avoided the topic, and there was some sidebar conversation on it. So, I mean, that's an area where I think you can really helpfully push to make sure that women are getting the vaccines when they need it at those very critical times.
Great. Thank you. And certainly if there are opportunities, we will sometimes hear about things not before they happen, but we hear about them after the fact, or folks will say, why weren't you there? Why? So if you hear about those kinds of opportunities, certainly let us know. We always want to hear from all of you about places that we can be connected or more engaged. So when things like that come up, please let us know.
Okay. Dr. Barfield, I understand you have a question or comment. Dr. Barfield, are you there? All right, well, hearing nothing, let us move on. Thank you, Michael. You know, now that I'm retired, it's hard for me to introduce myself. I don't have a title to go with. So one of the titles I was thinking about was radical upstreamist. But I decided against that. That was
Just one more question.
Oh, one other question?
From Wanda Barfield.
From who? Belinda. Belinda, are you there? Oh, the technology.
Okay.
Try again, Belinda.
Can you hear me now?
There you go.
Yes, and
Oh, wonderful. Thank you. I was typing away. I did have one other quick question for Michael, if you've got time.
Sure.
Okay. Michael, I'm just wondering, I know you meet with the Title V directors and all on a regular basis, and you hear from them. Since we've made a decision as part of SACIM to make our focal point on equity, are you hearing that from the states? Do they view it as a priority area that should be focused on?
It's a great question, Belinda. Yes, so we did hear a number of states, states depending on where they are and their particular state composition and their political environment talk about it in different ways, but lots of conversations. If it's not around equity, it's around disparity reduction or elimination, and so we heard that frequently when we were doing the listening sessions, for example, at the AMCHIP conference. And certainly if we look across block grant submissions on an annual basis, a lot of interest in states about either addressing equity and calling it that or talking about addressing disparities.
Thank you.
All right, any other questions?
Looks like Dr. Barfield was trying to speak but was not unmuted. Okay.
Oh, wait, hold on.
Hold on, Dr. Barfield. We're going to unmute you so you can talk.
She should be able to.
Okay, Dr. Barfield.
Can you hear me now?
We can, yes.
Great. So the only thing I was going to say is that it was great to hear Paul's comments about, sorry, I'm getting a little bit of feedback, that it was great to hear Paul's comment about immunization, and CDC as an organization is focusing as a priority on vaccine preventable diseases from Dr. Redfield, our director. The other area that I think we need to think about is vitamin K refusal, which, as many of you know, is something is given during birth, and we're seeing increasing cases where parents are refusing that particular shot, and as a result, infants are subject to vitamin K deficiency bleeding. So there is something that we need to think about in terms of communicating to parents and families around these prevention efforts that could reduce the risk of infant death.
Thank you, Dr. Barfield, for raising that. When I was still in Tennessee, we actually had a cluster of vitamin K related bleeding episodes, both some intracranial bleeding and GI bleedings, and actually leaned on you and partners at CDC to come and do an EpiAid to help us explore that. And the root of that was information that had been provided inaccurately to families and hesitancy that resulted from that. So agreed, not only thinking about vaccines for infectious diseases, but thinking about some of these other preventive measures that are so important and in fact life-saving, and how we make sure we continue to promote those.
So one other area for the committee to consider is other partner representatives like the American Academy of Pediatrics. During their recent legislative session, they talked about making vitamin K refusal a priority area to consider.
Thank you.
Good to hear that. All right, thank you, Dr. Warren. Appreciate it. Now let's move on to our the history section of our meeting here over these 2 days. That we're building on the work of a lot of things that have gone before us. Dr. Warren mentioned some of the things in the history of Title V, but certainly the history of SACIM over the last 30 years has done a lot of work, a lot of really good work. And certainly we are building on the efforts of those people who've gone before us. And we need to know, what they did, how they did it, what worked, what didn't work, what obstacles they had, what things they found to move their work. And so that's why when we started this after SACIM, after a hiatus of several years, we needed to look back at some of the history, and particularly the history of SACIM. And that's why I've asked Kay Johnson, who was the chair of this committee prior to my taking over, to tell us what she did during her time as chair of SACIM, but also give us a little perspective from her policy perspective that she does as a regular job. So I've invited Kay to spend some time talking with us before we then go into the history report that Magda Peck put together, again, kind of enhancing that broad view of what brought us here. So, Kay, are you with us?
I am with you. Can you hear me?
Yes, can hear you very well. Thanks for being with us.
My pleasure. And I'm assuming in a moment I'm going to, as we say, have the power to move these slides myself. Well, I'm really very delighted to be with you. I apologize in advance that I am actually in downtown Washington, D.C. with a group of LIN trainees who have been learning about maternal and child health policy and are going to be visiting their congressional delegation, and I'm going to be accompanying them. So I won't be able to be with you later today or tomorrow because I have that other responsibility. But I'm really glad to be with you this morning and to talk to you about this a little bit. And I really just have thought about this in the context of what it meant for us to have a process and recommendations in the time of health policy expansion, because of course you are in a very different time. I want to start by saying while for various reasons I've watched football and done and other sports over the years, SACIM always sounded to me like that was something that happened in football. And I deferred to the term SACIM, and I think people use both, but this is why I refer to the term SACIM, to really see ourselves as leaders, to see ourselves as bringing wisdom. And I know most of you on the committee, and there is a level of cumulative wisdom on this committee that is remarkable, even if I look at past pieces. But I live in the land of the Abenaki, still unrecognized federally, but a lot of this comes from them, and I encourage you to think of yourselves as SACIM. Magda mentioned going back 30 years to 1991. I've intermittently been attending the meetings of the advisory committee since 1991 and was involved in the development of the strategy for it. I think one of the things that's really important to think about, actually in terms of the context of the virtual meetings, is this has created virtual participation opportunity, even if the committee is face-to-face, for partners and families and leaders from communities to listen to what's going on in the conversation around SACIM. I have, and probably I've forgotten someone but I've included there in this little graphic quite a number of people who served on the SACIM previously. I'm not going to read those names. Those are all people who have been friends and colleagues of mine. And I would just say on the federal side with Dr. Peter Van Dyke and Ann Kuntz and Mary Beth Badura, and then with Dr. Liu and Hani Atrash and David bringing longevity to his role. It's also a long history of people caring about these issues, and you're going to hear a little bit more of that from Magda. So during the Obama administration, we set out, first of all, we created, spent a lot of time thinking about the continuum. And not everyone likes this busy diagram, but most of us did. And we used this in our report to saying we were going back, starting preconceptionally with a reproductive life plan and family planning and the woman's immunization and folic acid. You see that. And then going with, this is really around, this is the women's health slide, leading to better infant and child health outcomes, but also better outcomes for that mom. And then if we look at the child side, beginning with the birth, that they were born in a risk-appropriate facility and got NICU care, but then on to Bright Futures and immunization and SIDS-SUID prevention and newborn screening, and continuing to emphasize the health of those women, but also really looking at the opportunities once the child is born. You all may think about a new iteration of this continuum or design it graphically, but I think getting the whole picture in front of you is really important. Our approach during the Obama administration was to build, as you are, on what came before in SACIM. We were also riding the wave of the Affordable Care Act, and we set out a goal, and I as chair was pretty firm on this, that we were only going to make recommendations that were within the HHS purview, things that the Secretary and the agencies of HHS had control over. We stretched a little bit to some other federal agencies like USDA or FDA or others, but FDA is still in it, but figuring out, and HUD was involved outside of HHS, but really, generally, recommendations that the Secretary could take action on. We set out 6 strategic directions, and I'm going to talk about those in a moment. We also called for a stretch goal. And this was based on analysis by epidemiology staff in the Maternal and Child Health Bureau. I urge you to revisit that and how we got to that and what you think the stretch goals are now. We were reaffirming what had happened in the George W. Bush era SACIM. We reviewed and referenced their reports, particularly around the science related to low birth weight, and in fact that report was equally about prematurity, but I think opportunities to learn more in that area, and a report that they had done on the status of Healthy Start. They spent a lot of time reflecting on changes in science and less time probably on policy and programs than we did, but we reflected on what their recommendations were, and we invited the past chair and other members to speak as part of our briefings, as you've done to me today. We set out some principles, and this really started, Dr. Liu was the chair of the Secretary's Advisory Committee in the Obama administration for, I think, 1 or 2 meetings before he went to lead at MCHB, but we started there. The life course perspective, the engagement and empowerment of consumers, thinking about equity and disparities and negative social determinants of health, thinking about the MCH safety net, thinking about systems of care and service integration, thinking about how this needed to be a multi-sectoral public-private collaboration. And we were really concerned about defining actionable strategies, that we were not giving a set of pie-in-the-sky recommendations or ideas. So one of our statements that sort of embodies all of this is about the fact that this requires a multifaceted effort, that it's got to be about practice change, it's got to be about changes in the knowledge, attitudes, and behavior of men and women, but of course also their providers. And then the coverage and access issues, the roles of communities, the issues of equity, and a serious commitment to prevention at all the levels that Dr. Warren described. We really were clear about reaffirming the need for federal investments in the MCH safety net. Some of you may recall that after the creation of the Affordable Care Act, some people thought maybe we didn't need a Title V block grant anymore, or maybe we didn't need to have the Healthy Start sites anymore because everybody was going to have insurance and everything would be fine. Of course, we all know that having insurance doesn't guarantee access, it doesn't guarantee equitable access, and that all of these safety net programs are really vital, and we continue to emphasize them. And this is not everything one could list, but this is the set of things that we emphasize. We were riding the wave. There were Affordable Care Act opportunities. The administration, in the context of health, and the Secretary, First Secretary Sebelius, really focused on the Affordable Care Act. And so we started very early on with a letter to the Secretary just outlining what we thought was in the Affordable Care Act that could relate to infant mortality reduction. And then thanks to the work, a lot of work by Dr. Liu and others at MCHB, but as well as us writing to the Secretary, we did get a response, a public response from the Secretary Sebelius calling for the first national strategy to address infant mortality. I would just say this notion of having a national strategy was already going on with the National Prevention Strategy and the Action Plan to Reduce Racial and Ethnic Health Disparities. There were people impaneled on each of those, and this put us in that impaneled group to advance a national strategy that the Secretary was calling on us to produce that. And in many ways, our report we saw as being that, that national strategy, and hoping that much of it would be embraced and adopted by HHS. So our process steps, I think it's important to reflect on how we did our work. I'm sorry this slide is run together a little. We had working groups, and that's certainly a mechanism available to you, and I'll show you a little more about that in a moment. We used the prioritization process for agenda development. We submitted all of our recommendations at once in a report in 2013, but then we submitted letters roughly every 6 months about each of our strategies in greater detail. We invited and really listened to partners, and particularly making an effort for like core groups like AMCHIP and City Match and ACOG and AAP and ACNM and others, March of Dimes, for them to be in the room or to be on the phone and to make sure that our partners knew when the meetings were so they could get this on their agenda in advance, and actually giving some flexibility and notice and encouraging people to use our public comment period in a very active way to get their ideas on the record. And we engaged key federal agency staff. I'm particularly grateful to Wanda and an array of staff who work with her, but Wendy as a loyal participant, Iris is not here, I think, today, but a loyal participant, National Center for Health Statistics, really loyal in being there, and NICHD staff for really regular attendance, regular contributions, and helping us move forward in our vision. So the working groups we had focused on the national agenda, on equity, on healthcare reform, on healthcare systems, and that one emerged later out of our priorities a little bit, and then on Healthy Start. And that each of these could meet, and they also, as these working groups were impaneled, they were bringing in other partners into their conversations or their meetings. When we got to the point of having virtual meetings, we did manage to have some breakouts. Sometimes 3 groups would be meeting during a breakout period of one of our virtual days, and they were virtually engaging more partners, and I know that MCHB and their contractors can help you do that as well. And it just, you know, as you've done with getting the history and so on, divides up the work and brings things back to the whole body. Being specific, and again, I'm sorry about these, it bothers me when the headlines run over like that, but they're showing up differently today than the last version that I saw. We selected specific priorities. I think you really have to get in the weeds, and I know that you will, and I know with the brain power on this currently impaneled SACIM group, you are going to do that. But I also think you really have to clear a path as you go. It's really easy for a group to get overwhelmed by all of the opportunities and ideas that are out there. We set our our vision and framework that I showed you, about the life course and equity and multi-sectoral and so on. And then we built toward our 6 directions. We made a lot of lists of potential actions and strategies, and we used, there are lots of ways to do this, obviously, but we built matrices, and then we scored them by impact and feasibility, actually did repeated voting really throughout a 4-year period. We were voting on the first 6 strategic directions to get to those, and then within each strategy, we were saying, so what are the priority actions within this strategy? And those were the ideas that went into the letter. So figuring out and sift ideas, how you in a formal way get the consensus of the group and move ideas forward, recognizing that there are ideas that may be a priority for one organization or one individual who serves on the committee, and yet you're really trying to get to some higher level, and this is a tool that we used repeatedly throughout our process. I mentioned that we used our letters. So we had the 2013 recommendations, and then in 2014 and 15, we were sending letters to the Secretary about each of our strategic directions. There are 2 examples of letters that came from me to the Secretary, one to Secretary Sebelius and one to Secretary Burwell, just as examples, and then an example of one of their responses to me. So what we were saying to them in each case is we're building on our core recommendations, but we've delineated a series of related actions for her to consider, and they were timely, they were evidence-informed, and they were building on the administration's priorities. This administration obviously has different priorities, but the current secretary obviously has priorities, and this administration has priorities. And I urge you to try to frame things in that light, even though the opportunity to focus on health may be narrower in this administration. So we also were trying to build on partner priorities, and of course we've heard today from a number of the members about partner priorities, but we were really looking at the AAP Bright Futures as well as perinatal guidelines. We were looking at ACOG in maternal safety and FEMUR, and as it came on, although the Women's Preventive Service Initiative came at the end of this time, but looking there as well. The AMCHIP priorities for state MCH programs, ASCO, much thanks to Paul's leadership and the Healthy Babies Initiative, the city match priorities on local MCH, the March of Dimes Prematurity Campaign, the National Healthy Start Association, PCORI consumer involvement, and then the various agencies within HHS, the others, and then the offices of minority health, adolescent health, and population affairs, looking at the priorities within all of those to help guide and inform what we did. So what did I want, or what did we want that did not get done? Frankly, HHS was busy implementing the Affordable Care Act. It was not always an easy road. Some ways passing the legislation was the easiest part. But getting, from 2010 to 2014 with all of the things that had to be done and the various rollouts of different components of the Affordable Care Act, there was not a lot of attention by the administration to our specific priorities. And I'm going to go through a little bit more of that. So we didn't have the secretary writing us back and saying, oh yeah, I want to do that. But they were well accepted, and I do think that administrative agencies were responding to ideas that we set out. We wanted, but never got, and I just think this is so easy to get done. I'm not sure why we don't have it yet, but we really wanted the National Center for Health Statistics to coordinate on the release of the infant mortality annual and data. Because of the way SACIM is impaneled, that should be possible. It should at a minimum be possible for the National Center for Health Statistics to let the SACIM members know through MCHB, through the Secretariat, that the data are going to be released, when the data are going to be released, and perhaps the high-level ideas that are going to come out in the data. And that would give SACIM an opportunity to be ready to respond for all the members to be ready to respond, for the committee to write to the secretary in response. Every year that I was chair, the infant mortality data came out. I had no idea they were coming. I had no idea what the trend was, and we just couldn't get ready fast enough to hit the news cycle or really to respond in a timely way. It would be really helpful if NCHS could give SACIM a heads up. Again, that can all be done internally, confidentially, as part of a closed government process, and it should be feasible to do that. We didn't get our Preemie Act report submitted, and I'm going to talk in a moment about why. So the Preemie Reauthorization Act, and it's since been reauthorized again, but it directed SACIM to produce a plan for conducting and supporting research, education, and programs on preterm birth through the Department of Health and Human Services. We asked for that responsibility. We encouraged those who were moving the legislation to give that responsibility to SACIM rather than set up another committee. We thought that was perfectly within the purview of SACIM. And then we sent out a letter to the relevant agencies, all of the liaison agencies and those who are represented on the ex officio list, plus a few others. And we asked them, what are your primary activities taken in relationship to preterm birth prevention? What additional activities or projects are planned? Are they formal and budgeted, or are they just ideas, basically? And then what are the major gaps that you've identified related to preterm birth prevention? And could you tell us, you know, how the federal government might help fill these gaps? We asked them to respond to us in writing very briefly, and we wanted them to come and participate in a meeting and share with us those ideas. By the time we got through this part of the process, we lacked a quorum, a full panel. We were not able to have a subsequent meeting and unable to complete and file our report. One was due, others have been due since then. I think there's an opportunity for this SACIM to get this piece done that we left undone. And I think there's an opportunity for you to add in a way to the ask something about equity as a high priority for you. This was the first round. The letters came signed by me and Hania Trash, and they went to each of the, as I said, the ex officios. We can tell you who they went to, and we appreciated the responses, but we just weren't able to report on them. So let's talk a little bit about our recommendations in the light of what got done and what didn't get done. So these are our 6 big ideas. I'm sure you've seen these. Improving the health of women before, during, and after pregnancy, the continuum of safe and high-quality patient-centered care, redeploying effective prevention interventions, increasing equity and reducing disparities, both social determinants and high-risk communities, and initiatives to address poverty. So we had a big bundle there. Investing in data monitoring and surveillance, and then maximizing the potential of interagency public-private multidisciplinary collaboration. So again, this actually, sorry, this one doesn't show up as well, that this is the strategy 1 about women. And we, I think, had progress around, because of the Women's Preventive Service Initiative, progress around number 1 and number 2. And I think the Maternal and Child Health Bureau took that seriously. We were calling for a Bright Futures for Women, and I think ACOG took up that challenge, and with Dr. Conry's leadership has really advanced a lot. We on C have not seen the Medicaid innovation and demonstration projects that we wanted. Based on one aspect of the infant mortality coin, we wanted one, for example, on interconception postpartum care. I think there are still opportunities with this Center for Medicaid and Medicare Innovation. We just got the first one focused on children, and maybe there is an opportunity in this administration to get one focused either on pregnancy or on postpartum interconception. I think it would be a very useful way to proceed to get state Medicaid agencies back involved in the discussion. We did not, I think, have great success with efforts to ensure the mental or behavioral health or social support services for women, although some progress has been made in some states in that area. Clearly, that's something that's left to be done. The continuum of safe and high-quality patient-centered care was complicated. We had a lot of really productive conversations around this. This was a tough one. Really, we were thinking about what was the role of the IM coin to strengthen state capacity. I think a lot was learned in the nationwide rollout of COIN, and we're learning more, certainly, for example, in the preconception and in the social determinants area. I encourage you to learn as a group about what went on and what's still going on. Using Medicaid to drive quality. We aren't there yet. We don't have all of the states required for another few years to report on the quality measures in Medicaid, and I think encouraging that remains important work to be done. Thinking about what AHRQ and CDC are doing around quality improvement and what the states are doing around perinatal quality, really important. The newborn coverage issue continues to be an important one, and I have a grant from the Packard Foundation to investigate that further this year. I'd be happy to talk to you more about that sometime. And thinking about how the Affordable Care Act, community centers, and workforce capacity relates to the health of mothers, children, and families, particularly babies and birth. We did a little investigation of that, but I think there's more work yet there to do. Redeploying key evidence-based, highly effective preventive interventions to a new generation of families. We both had, particularly our representative of the AAP, helping to drive this, but we also had one of the nation's leading breastfeeding advocates, people talking to us about immunizations, and some of you know I served a long time on the National Vaccine Advisory Committee and worked on that issue for a long time. NICHD with their rejuvenation around safe sleep, but the work of COINS and others, and then the smoking cessation issue, particularly given that that Medicaid coverage was extended and during pregnancy at least. So we picked these particular topics. They clearly aren't the only ones. Again, we rated and evaluated what were 5 key preventive interventions. And the reason we thought these 5 were so important is that we believed, and the academic published studies show, that we made progress on all of these. And now we've lost ground on all of these. And so the need to really say, these are demonstrated preventive interventions. We made an impact nationwide in sort of the first round of heavy rollout on these things, and we've lost ground. And so the need to do more is clearly there. Folks at the Bureau, folks at CDC, and elsewhere know this, but thinking about whether you have a role to continue to push such a list is important for you. On our direction around equity and social determinants, communities, and poverty, we really encouraged the convening of an interagency expert panel to set goals for closing infant mortality gaps. We did not get that done. I wonder if there's a way for you to just weave that into your work rather than having a separate panel. With your emphasis on equity, that might be work that you have time to undertake directly. We supported the transformation of Healthy Start. We didn't make a lot of new recommendations because Healthy Start transformation was underway at that time, but we wanted to really support Healthy Start and the transformation activities. We thought that there ought to be an interagency process that was focused on turning the curve of social determinants. The Obama administration was interested in some place-based initiatives. We see Healthy Start as one of those, but I think revisiting this concept around what does it mean to do place-based work to turn the curve on social determinants is really important. And the social determinants of health, the Learning Network, and the full IM coin and the group concurrently convened by AMCHIP could help inform you around what's been going on and opportunities to go forward. We put emphasis on reducing poverty, particularly through income supports. Many of you have heard me talk about the Earned Income Tax Credit and how studies are showing us that the Earned Income Tax Credit gets in many ways the same results we've promised in home visiting, and yet most people in maternal and child health workforce do not know about the EITC, and they have no idea that they could get similar results to home visiting by helping families get the EITC. We just think that everybody's decided we can't solve poverty. You all probably know the National Academy of Sciences has a recent report about cutting poverty in half, and it endorses and advances everything that we said in our report. So I encourage you to keep thinking about it. Investing in adequate data and surveillance and research. This is a list that will be familiar to all of you. We didn't want to see a drop-off in vital statistics. We know there's more to be done in Medicaid perinatal data and wanted to push that, PRAMs, quality measures, the various data systems that you see listed there, and the research that goes on across various aspects of HHS in relationship to the causes and prevention of infant mortality. Setting that potential, unleashing the potential for interagency, public-private, and multidisciplinary collaboration. We have there some of the IM coin leaders from the work done in Regions 4 and 6 that got an HHS-wide award for some of that work. Many of us were involved who aren't in the picture, but that's a pretty good representation of a lot of the leadership from across agencies, and we know it's going to take that. So we were looking at where else in the federal government, and again, trying to build on the national prevention strategy and the equity strategy, thinking about how the state health departments and the state MCH agencies were working in partnership and keep this as a priority, maximizing those public-private partnerships, and then the notion of, again, engaging women. We put that out there. I don't think we gave it much attention in our process, and I understand that you're going to. So what do I think are some quick wins for you? I think preparing and submitting the Preemie Act report could be a quick win. Investigating and reporting on the importance of the Affordable Care Act and Medicaid to the health of women and babies might be a subgroup activity. Building the on-the-record case for the postpartum, fourth trimester interconception care for those at risk. A lot of conversations going on out there. You've got an opportunity to build that on the federal record. Listening to women, inviting consumer voices, and I think just as much as I care about us thinking about women, I don't want us to forget the babies who need immunizations or NICU care or weed prevention or Medicaid enrollment or a variety of other things that, of course, our babies need. Advice to you, I still encourage you to primarily make recommendations within the HHS purview. What does the Secretary have control over? Looking for windows of opportunity in this administration. They're not going to be as obvious as they certainly were for us with the Affordable Care Act, momentum around health policy generally. The W. Bush SACIM really leaned into the data and science. They were highly investigative, and I think there's a big opportunity for you to do that as well in this time. And continuing to leverage the Affordable Care Act and Medicaid. We know that it's not being implemented well for pregnant women and families and non-pregnant women and before, during, and beyond pregnancy, as it might be in every state, and I think continuing to leverage and investigate there has value. And obviously you're going to be focusing on equity, on social determinants of health, and I know on primary prevention. So let me stop there. I don't know, Dr. Ellinger, do you want to do questions?
Yes,
I know you're running a little behind.
Thank you for that great overview, and certainly stimulated a lot of thoughts in my mind about things that we could do or how we could do it, and I'm sure it has done the same for other members of SACIM. So let's open it up for any questions that people have or comments from SACIM members.
I would just say thanks, Paul, for putting the mom's CMMI model out there. I tend to think of it as not big enough, but I shouldn't dismiss it. Thank you.
May I make a comment? Make a comment?
Yep, sure.
Thanks, great. Hi, everyone. This is Tiffany Mcnair. It's great to be with you all. I'm in the room here today. Just wanted to thank you, Kay, for that presentation. It was really helpful for me just to hear more about the history and some of the strategic aims. I also did want to piggyback on that piece since I did, before coming to this position, did just come from the Innovation Center at CMS and actually led the development of the MOM model that you just, I think someone just described, the maternal opioid misuse model. I think that there are a number of opportunities to think about there in terms of leveraging the work at that center. I'd also say, if you haven't already done so, I assume that we all have, but think about lessons learned from the Strong Start initiative as well, which did publish its final evaluation report last year, and that was the one that was focused on looking at innovative models of prenatal care for women. And so I think that there are definite opportunities there. Like you mentioned as well, the Integrated Care for Kids model, or INC model, that's looking at kind of intersections between physical and behavioral health for children. I think there are similar pathways being created as well around maternal health. So there are ways that we can kind of think about that within the committee.
Thank you. And I know some of us have been thinking about the Strong Start lessons. Thank you for reminding us about how important that would be for SACIM to review.
Kay, your leadership went over a transition in government, your administrations?
No.
No, so you were just...
All in the Obama administration.
Okay. Because I'm wondering about how SACIM in the past has worked with, when there's been a transition from one administration to another. You talked about focusing on HHS, what can be done, but I'm also wondering about, this is a long-term activity. How do you set the frame for ongoing activities when there's been, when there comes a change in administration?
I think it's a really good question, Ed. I think the most important thing, and it's certainly one I know that David and I talked about, but making sure that the outgoing administration signs a nomination package before they go, so that we don't have a break before the next administration gets down to the level of those nominations, because when they come in, they have a lot of nominations work to do, and SACIM doesn't always rise to the top of their list. So I think that's one lesson learned, making sure we have a quorum and we have nominations packages signed, and that we've got continuity from old to new members, and balancing the terms. So there's one, that's kind of a practical thing. But certainly conceptually, I think you're absolutely right, and I think leaning into the science, but also that, while we framed a lot in the context of the Affordable Care Act, as you could see as I went through those recommendations, they're not a lot of data, and they don't all have to do with the ACA. And so, figuring out, what continues to be salient, undone work at HHS is a challenge for all of you. But I think if we had greater continuity in the membership, we would have been running across administration.
One of my concerns or issues is just the visibility of SACIM, particularly within HHS. How do you see SACIM relating to both the MCHB director and then the HRSA administrator and the secretary? How can we enhance that visibility so that our influence can be a little bit broader than it has been in the past?
Again, I think not just doing these reports that take a long time to write, and not just doing scientific reports. So, making recommendations, again, that's one of the reasons I see the Preemie Act as kind of a quick win for you. It's something Congress has charged you to do, and it gets you right away into what are the agencies doing, and bringing that, sort of grounding that investigation around what the agencies are doing. And so that you're into that. I do think there are committees have various levels of success about this. So when I was on the National Vaccine Advisory Committee, the secretary always came once a year, and the assistant secretary came every time the secretary didn't come. We were in the middle of a measles epidemic, and they took this very seriously. And so in some ways, it's a reflection of whether or not the secretary, the ASH, and others have it as a priority. Clearly, we know Dr. Warren has this as a priority. We hope you'll hear from the HRSA administrator. and also that everybody in the ex officio will be invited in some way. I think each of you using your networks and influence to think about that cross-agency collaboration and using your partners to do that, to build visibility. But I say, you know, more letters, more recommendations, more bites of the apple. Be the Marian Wright Edelman, flee on the dog.
Good. All right, question from Jarrett, Paul Jarrett. Paul Jarrett, Paul? Not quite sure why it always takes so long to...
I think it depends on how people are logged in.
Okay.
Your line is open, Paul. Please check your mute button.
Can you hear me?
There we go.
All right, thank you. A question about the committee itself, because Kay, you talked about how you tried to coordinate on the release of infant mortality data, but were unable to. Is a committee like the SACIM, thank you, Kate, do we only have access to public information after release, or does a committee like SACIM as an advisory committee have access to pre-release information or administrative deliberations?
I think it depends on what the administration wants to do. Certainly, again, on the National Vaccine Advisory Committee, and I was also on the advisory committee around vaccine injuries, we had access to confidential data. We had confidential sessions. We had information that was not public. My observation as the chair of SACIM is that what I saw was already public. I think, you know, the easy one, the National Center for Health Statistics and CDC, to use that confidential process. Unless David, you tell us SACIM is under different rules.
Not that I know of, no, ma'am.
Thank you.
Well, that might be something to think about. That might also increase the value of the committee to the administration. The other point I wanted to make, and this, you know, we really still need to see what's going to develop, but there have been comments made that the administration would like to run on health care in the next election process. If that is the case and a plan is being formed, perhaps there is a way for SACIM to develop some advisory capacity as that plan is being formed around maternal and infant health. And I don't, you know, I'm just saying, putting it out, there's a possibility. It could be a way to gain some influence in the outcome of that process.
I think that's a good idea, Paul. Another in a long series of your good ideas, and that on the slide that's still up there about being investigative and thinking about, you know, the positive impacts of the Affordable Care Act and Medicaid on the health of moms, babies, and families may be an angle on that.
Any other questions for Kate? And Kay, I know that you're interested in what happens with SACIM, so I'm hoping that you'll be available for consultation and questions and as we move along.
And absolutely, and I hope to regularly be a listener and definitely available as you move along. As I said, I think all but two of you, and very well, and you know, have worked with you for many years and have a lot of confidence in that you're going to do great work and move things along.
Great. Thank you, Kay. Appreciate it. And thanks for all your good work in the past, and look forward to working with you in the future on reducing infant deaths and improving maternal and child health. All right, let's take the next step. You know, report from the history working group that was led by Magda Peck. You know, this we asked really, let's look back both at what SACIM was doing and has done, and on some of the other issues, bigger issues or longer term issues in maternal and child health. You know, Dr. Warren teed up some of those, but you know, we really need to know history in maternal and child health if we're going to move forward in an effective way. So Magda was generous enough to give a lot of her time to do a lot of interviews and a lot of conversations. So I think she has some really important information about both the importance of what this committee is all about and what opportunities we have going forward. So Magda, I'm going to turn it over to you.
Chad, I'm assuming that everyone can hear me, and then I'm just going to move ahead. I'm also assuming that I'm supposed to move my own slides. I don't know about that.
It's up to you, so I've made your...
All right. Thank you so much for giving me that screen. I appreciate that. And this is a brief report that very much builds on the extraordinary synthesis that was just given by former SACIM lead and Chair Kay Johnson, one of many people with whom I spoke with over the last 3 months of work. I want to acknowledge that this was a charge that was agreed to by the first convened meeting back on December 4th, and specifically to look at what has come before and would complement the report that we anticipated from Kay Johnson. I want to acknowledge the assistance and input from the other members of the Secretary's Advisory Committee listed below, Janelle, Colleen, support from Suzanne, and input from former member Art James to assure continuity. Why do we do this work? Just to reiterate what makes this SACIM, because of that administrative, if you will, hiatus, every member of the current Secretary's Advisory Committee on Infant Mortality is new. We do not have institutional members as members ourselves. And so relying not only on the information and insights of prior Chair Kay Johnson, but being able to look over a 30-year period to say what is relevant, what is possible now. We pledged that we would build on these strong foundations. It's about honing and honoring the work. We have framed this. And like, why are we still dealing with this 30 years later? It's quite remarkable. Great progress noted by Michael Warren earlier, and persistent gaps that have remained. And so this is where we're seeing the third generation of SACIM's work, and therefore, when we want to be effective and strategic, questions that have already started in response to Kay Johnson's presentation, how do we jumpstart it? Because we do not have time, and urgency remains. And last, we recognize that how outcomes are manifesting for women, children, families, and fathers as using infant mortality as an important indicator and proxy. We wanted to recognize the long arc of history as we address social determinants and life course across generations. In doing this work, we took a systematic approach, and I very much appreciated the rational thinking of ranking and priority set in the previous committee's work with the matrices presented by Kay, and inspired by that. We looked at history over the last 30 years. We tried to take into account a lot of what Michael Warren has already presented today, the last 100 years of history, and then look longer back to the structural forces, particularly in the face of racism and oppression, about the legacy of African Americans and First Peoples of this country. And we also looked at it through the lenses of population health, already shown, given that clinical care is essential, but may account for only 20% of how well and how long babies and children live. The methods that we used over the last 3 months was a series of key informant interviews. We did email communications, but we will have no data presented by any individual. We promised folks we would synthesize this and present it in the aggregate. We did a very limited amount of literature review. Again, this is volunteer work in many ways for everyone that's working on SACIM, and so we have day jobs. And so this is something for us to zoom out as adaptive leaders and understand what's come before so that we can move ahead. I do want to acknowledge with gratitude those who have served. Their names are listed here. They are certainly not everyone, but these are the folks both within the SACIM work as well as in the Bureau's Secretariat work that has been able to inform our looking back to look forward. So beyond Kay, thanks to those who are listed here today. We framed our work around 4 guiding questions. It's almost Passover, so we're always inspired by 4 great questions that you ask. And in the words of one of our key informants, the work of SACIM in many ways is to make sure that we are framing very powerful questions and not having folks report the activities of the day, but rather have guiding questions that will shape our work. In this case, looking back in history, these are the 4. And I'm going to reach through and give you just high-level advice, if you will, across some extraordinary individuals that responded about how to do our work well at this time. Question 1 was, as we do this 3rd generation of SACIM work, what do we carry forward? What's most important to do? And we've already heard a wish list that was well informed by Kay Johnson, beyond looking at the immediately past SACIM work. These are the points that I'd like to bring forward from our key informants. The SACIM has gravitas, that this is a bully pulpit, and we should take it seriously no matter what generation we're serving. It is the only advisory body that specifically looks at the health of women, children, families, fathers as manifest in infant mortality. That we base the work on science and not be shutting advocacy to the side, but find that strategic balance. We've already heard about the challenges of the moment, and we've also heard the suggestion, which I will underscore, that we cannot be all things to all folks. We need to be able to fairly quickly and resiliently find our focus and be able to identify what are the clear endpoints by when that we think we can influence. And probably the most important theme we heard from across the folks who've come before us is to navigate wisely and sustain momentum, and this notion of political will that comes from our emeritus mentor, Julie Richmond, and Will Cuddlechuck about which all the data you want will be enhanced to inform the programs and policies you want to shape, but without political will to be able to move ahead and make change happen, we will not be able to muster and sustain the changes that we'd like. There was a call for strategic pragmatism. Be very clear about early wins. We've heard of some of those, including the Preemie Act, Medicaid. You've heard a number of these. I want to also add to the list given by Kay a focus on not just timely data release, but innovation around better data. To not lose focus on the health care that must be sustained and maintained for all with highest quality. Build and stabilize on what works. And if you are going to focus on maternal mortality, go beyond the quality bundles and clinical care to take the upstream work around equity and integrate that into the maternal mortality work. A caution to not forget the importance as a social determinant and outcome in its own right about fathers, fatherhood, and families, and not lose the urgency of the work ahead. As we move upstream, it is the right time, and this is an overwhelming consensus, that to further advance equity, recognizing that short-term work must continue, but we are already at the place where the mindset has mostly already shifted and changed. So move ahead with specific recommendations around equity. One example put forth was around the relationship between housing access, quality, and security, and infant health outcomes. So we heard before about the earned income tax credit. So specific recommendations, not ideology, that are evidence-based, and build on those blueprints that you have heard from Kay and we'll be hearing about a little bit later on. In terms of the second question, which is, all right, how do you do the work? Kay was very helpful just now about that, and some questions are already being raised, but I want to underscore 3 points. This notion about getting folks back to a table, reaching out and getting members who are strong, robust, and engaged, and to find when you do that roll call, Ed Ellinger, next time in the fall around our ex officios, we have folks at the table across Health and Human Services and well as external partners in the room at an on-site meeting and on the phone, so that there is fire, and it's our job to ignite them and to invite them with specificity about not just warming a seat, but what we want them to do and what we need from them to get the agenda done. This knowledge and understanding and priority of equity is something that not everyone shares. So do not leave folks behind who may not have been in their predominantly clinical work in other ways. This is a great opportunity to reframe and re-educate about the equity work. And as was spoken before about engaging the voices of women, there was also strong consideration that we should have that to include organizations that are led by and for people of color, and be wary of history and be wary of the perception or actuality of exploitation of groups. Other things that come up, I won't read all of them: structure the work well, be intentional, consider having an ethics officer in the room as we do our ethics reports, but know your boundaries and make sure that we will be able to do this work right to the edge of what we can do. And last, this notion about not only about making recommendations up to SACIM, point of accountability, which is the Secretary of Health and Human Services, but really think about how can this brain power be a think tank that's useful and used to shape solutions across the administration and outside. So how can we have gravitas and be robust and be a go-to place for innovation and ideas? One last idea was to proactively create a broad set of recommendations on a periodic basis that people will regularly come to rely upon, that is based on the latest science of the day. As we strive for equity, in our third question, what you would be mindful of. And we've heard about this from the wonderful presentation from Dr. James back in the fall as part of our minutes. But at the end of the day, if we connect the dots, it is our job as SACIM to continue to work to change this narrative, particularly in the longer view about the legacy of slavery and the cumulative traumas of American Indians in our nation. So we'll be hearing more about that. But when we think about history, have the courage and the connectivity to go back, to go forward, given the epigenetics of trauma. Last, please recognize that this notion of going upstream is not new. It is public health 100 years ago, and that grounding our work and really learning from history is essential. An example put forth is that maternity issues really drove a lot of the policy solutions 100 years ago. One could even see the right to vote of women and the Shepherd-Towner Act as being some of the early antecedents of how access to care universally can be essential. Learn from history, learn from our timeline. It is something that the Bureau and others have invested in. And finally, what I found uniformly across all of the leaders with whom we had conversations is that folks, like Kay just said, all you need to do is ask. People want to get back and engage. They're just saying, let us know how, and are thanking us and holding this group in high esteem and high expectation that we will be able to leapfrog forward and sustain the work for healthiest babies, healthy mothers, healthy children, fathers, and families. So a very high-level presentation, but it really affirms some cross-cutting themes surfaced by Kay and that we can be mindful of as we strategically move our work forward. And I'd be glad to take some questions.
Thank you, Magda, for both the presentation and the work that you've done, and your working group has done a great job. Questions from members? Either ex officio or regular members for Magda, or comments?
Hello, can you hear me? This is Vijaya.
Hello, Vijaya. Yes, please.
Yeah, I have comments, but I'm wondering how much of this discussion actually feeds into our next section. So I don't want to go too heavy into comments on both Magda's and Kay's presentation.
Actually, that's a good point. Why don't we just start, I mean, the history that was given by Kay and the report given by Magda really do lead into those questions. So I think that should be part of our conversation. And the questions in your agenda, how is current SACIM potentially different than previous groups? You know, what we want the current SACIM to achieve, how can SACIM be successful, whom do we want to influence and why? And then any other questions that really were prompted by those two presentations that we just had. So let's just open up our discussion about what SACIM is all about.
Okay, can I start?
Yes, you can, please.
Okay. Well, first, thank you, Magda. That was excellent. It's clear that you did a lot of work talking to the ex officio members, and I really appreciate their perspective and your summary of it. Just a few things to lay on the table that I hope will factor into our discussion as we go along. A couple of things. So one, the issue of learning from history, I think is so important. So I agree, we have a lot to do to understand what happened in the past to understand where we go in the future. But there's another dimension to that, and that is that when something happens in the past, there are some things you have to undo in the present based on what happened in the past to level the playing field. So a lot of what we see in terms of disparities has to do with things that were set in place in the past. And in order for us to reach that point of equity, we have to acknowledge those things and put in the effort to undo the impacts of those historical events. So it's when I hear people talk about social determinants, I also hear a conflation of social determinants and equity, and they're related, but they're not the same. And I think we really need to grapple with how those things differ and how we need to think about and approach social determinants in a way that leads us to achieving equity. And I think that's something that this committee can clarify for the field in general, in maternal child health and for public health as a whole. Let's see. And another thing, when Kay went through the recommendations that they made in 2013, I think they were all very good recommendations, but something was glaringly missing for me, and that is we had things focused on providers and improvement in practice. We had things focused on changing knowledge, attitudes and behaviors of women and families. We had sort of big policy issues, but we didn't include the MCH agencies with respect to equity. And I think, that's a big player in this game. All of the organizations and agencies and people who work with mothers and children, who make decisions about policy and programs and clinical care, et cetera. And when we think about equity, if they're not there, if they haven't transformed themselves in the way they do business, then they're actually contributing to the inequity because they're perpetuating a system that is entrenched in inequity. And so when we think about recommendations, we also have to think about our Title V agencies and our national organizations and even community-based organizations and how they're structured to always promote equity in the way they do business, in their policies, their practices, their procedures, the way they think. Because if that doesn't happen, then that societal change will never happen, and we'll never really get to addressing the social determinants on a level that's going to actually achieve equity. So I hope we can talk a little bit more about that. And one last thing, and this has to do with the constitution of the panel. So one of the questions is, how is this panel different from some of the prior panels? And unfortunately, it may not be very different. And I think that's problematic. So particularly if we get to the point of prioritizing, because, you know, people select priorities based on their worldview and their where they stand, the context that they understand and have developed their own sense of priorities. And that's why the diversity on the panel is really important, so that we have the broad spectrum of people to actually weigh in on some of those priorities. And I think we're missing some of the younger professionals in the field. And it's important that they be included now, because we have to start creating a pipeline. I mean, this past month, I've lost 2 beloved colleagues in public health who are around my age. And, you know, it just sort of was really sobering that we're not going to be here forever. And we really have to start preparing that next generation of people to be able to step into SACIM and to some of these other organizations, APHA and some of these other places where, you know, this old guard, this group of people around the table now who've been in this game forever, you know, we've got to start mentoring and bringing along some other people, and we need the voices of some of the younger professionals and community people in the MCH to bring along. And I'll leave it there so other people can have time to comment.
Thank you, Vijaya. That's great. Excellent points. Other comments, questions?
Ed, this is Paul. Can you hear me?
Yep, I can hear you, Paul.
Oh, amazing. Well, thank you. And actually, I'm resonating with what Vijaya is saying, and I think part of our generation's responsibility is to bring along the younger generations, but also to challenge them, to be quite clear where we may have made progress, but where we failed. And we have failed in the area of equity, and to really make sure that they take the mantle up across the entire MCH and family area. One thing that I'm wondering in terms of highlighting the historical disparities, I'm wondering, given it's the 400th year anniversary of 1619, when slaves first came to Jamestown, is there somehow we can is there an initiative there we could tie into to start explaining this 400-year history and the intergenerational consequences and how it's gotten to us to where we are today? That's a question I don't know the answer to. And then one other just comment related to both Magda and Kay's excellent presentations. I was very intrigued by Kay talking about the earned income tax credit, which I don't know a lot or have thought a lot about. And then it occurred to me that as ex officios on this committee, we have people from HUD, Department of Education, the Department of Labor, the Department of Interior with IHS, the USDA. And so we, perhaps there's an opportunity for us to really take advantage of that expertise these people are bringing us to see what are these other things like the earned income tax credit that we could be focusing on, and we're not because we tend to come from a health environment.
Thank you. It's interesting that you bring up the points, and Vijaya was talking about the conflation of social determinants of health and equity. And then we're bringing up the other agencies who deal with the social issues that affect health, USDA and economic development. And the social determinants basically affect everybody in one way or another. And it's the inequities in those that cause the problems. And like transportation, if you don't do transportation right, it can lead to, we know it affects health, but it could also lead to gentrification. Or paid maternity leave. If it only goes to people at the higher incomes who are full-time employees and not the part-time employees, it can actually increase the disparity. So we have to, I think, really focus on having equity involved in all of our conversations to make sure that it is not increasing the disparities. And then, so your point, Paul, is I think are really good ones. Get these other agencies involved and make sure that we use this 400-year history that we've learned from as sort of, you know, look, we have to do things differently, and how can we work with you to do it differently? So thanks for bringing that up. Janelle? I hope we can get you on easier this time.
All right.
Good.
Okay, good. You can hear me.
Yes, yes.
Okay.
Okay.
So just a moment, I have to unmute.
Unmute something.
Okay.
Here, okay.
So I'm very excited
So
to
I'm
hear
very excited to hear
everyone
sharing
because I feel like we're
all
on the same
train
of thought.
thought.
And I know Paul brought up the question: is there some sort of initiative that we can date back since slavery? But I think we should go a little bit farther. We should look at the past 530 years since contact to 1491. It seems to me from the work that I did when I was working in the early 2000s and doing my dissertation and the work that I did with reservations and communities, even though I am Native American, I grew up on a reservation, I did not know my community's history until I left the reservation and went to college. And I did not know general Native American history in context of contact, like what happened. And when I learned about contact and what happened to generations of Native people and how contact affected different groups of Native communities throughout the United States and Central and South America, it really impacted my view of selfhood and of health that transformed into health eventually. And I really then was able to connect the dots as far as like historical traumas and intergenerational legacies, and Michael Liu's work on the life course perspective of these different parts that can affect people's lives. But I think we have to look at it even larger. It's not just one individual, it's the whole community. So to kind of address what Paul was asking, if there's some sort of initiative, when I look at all of this information and from the work that I've done previously and conversations I've had with people, similar to hand washing, changing the face of maternal health many years ago and a few hundred years ago, it kind of goes back to just simple kindness. And with that, education, a re-education. And I believe a number of us recognize that what we do now is not going to have immediate effect on infant mortality just yet. There's always that great hope that it will turn around infant mortality in the next 10 years, but there's a better likelihood that it's going to take a while for things to change. And one of the upstream things we can do is definitely work across agencies and possibly look into making a recommendation of interagency working together, so bringing in education. And we don't have a standard education on our country's history. Depending where you are in the country, it's a very different view of history, definitely. So that's something just to consider.
Thank you, Janelle. Yeah, one of the outreach I always do after this last meeting is talk with the tribal leaders and the urban American community about what we're doing, and they keep making the point. You know, our history is really important, and don't forget about us. Don't forget about us in the number, but also don't forget us in the conversation. Other comments?
Ed, this is Paul. Could I ask Janelle, because I completely agree with what you said. The history of the American Indians in this country is largely unknown, including the boarding schools and many other things. And is there well, perhaps not now, but at some point, where's the opportunity there to do that education and how it impacts the health of today? Because I think we need to do that also. The history of the country is, we have a 600-year history there, a 400-year history of African Americans, and we really need to acknowledge it all.
Sure. Can you hear me again?
Sure. Can you hear me again?
Yes.
Yes.
Hello? Okay, perfect. You can.
Go ahead.
Okay, good. I can see. So, and I got a little caught up in what I was saying, and I forgot to give the punchline. And the punchline is PSAs. So if we are not...
Your line is open. Please check your mute button.
Okay, thank you.
Okay, thank you.
So what I forgot to say at the end of all of that was
if
we cannot affect
somewhat of a standard education curriculum
is going to
that
affect
is going to
younger
affect
younger generations in the future,
then
currently what
we can do now, PSAs.
You can have short bursts
You can have short bursts of time where we
bolus into the public consciousness and awareness. Basically just what has happened, the effects of a colonization and appropriation. And I think that is a good start. It will resonate with some people, and it will definitely start conversations, and it will make many other people very uncomfortable, but it gets people talking. And if it comes from the government, it has a little bit more power. Something to think about. So it's something to think about. Definitely. And like the recommendation, many years ago, and I'm forgetting the name of the person, but when trying to address maternal health and pregnancy. There was such a drastic maternal health many years ago that I believe someone very important came up with the idea why don't we start feeding young girls who are going to become mothers a higher fat diet, a richer protein diet when they're in school. That's a similar idea. That why don't we also focus our energies on these young people still in school to kind of lay the future to make the ground fertile for more change.
Thank you. Other questions? One question that was raised in my mind that Vijaya mentioned is that maybe our group is not different. Maybe this panel is not different. I'd like to see if there's anybody who'd like to find some ways that we are. We are at different times. We have different people. We have different opportunities. That I'm hoping that it's different enough that we can make a little bit bigger impact than what I've seen the SACIM make in the past. You know, we've not really turned the needle very well on activities. So I'm hoping that we find different ways that we're different and actually capitalize on those differences.
So Ed, this is Belinda. Can you hear me?
Yes, I can.
I'm wondering some of this, I'm thinking will fall over into our conversation tomorrow from our committee, because I don't think we're probably a whole lot different from some past groups. You know, I may not, because I don't know everyone personally, I may not be totally correct there. I do think we have opportunities to bring some other people in to help ensure that we bring different perspectives to the table. Because we definitely need to have people who don't work in MCH every day, that this is not their focus, but their focus is more broadly on equity. You know, I look at, you know, some of the work around undo racism and, you know, how you have some of those courageous conversations and how you really start thinking about, you know, promoting training and practices to address institutional and structural racism. You know, sometimes you just have to have the dialogue. You've got to start somewhere, and I'm not sure with past SACIM members if those conversations occurred. Did we go down to that level? And I know those are difficult conversations. We're having them in my own state through our own state leadership. But until you start those conversations, I think it gets back a little bit to what Janelle was saying around, you know, it gives us an opportunity to understand each other's history and understand what challenges individuals live with each and every day and how people have gotten to where they are. Until you can go back and see some of the systems that were put in place, then it gives you a better indication of why we are dealing with some of the issues we're dealing with today. Because we've been working on infant mortality for a very long time. And even though we continue to see improvements, we have to make sure our strategies this go-around are truly going to address equity and really address the disparity ratio. Because as much as we talk about, and we definitely want to support things like preconception health and all of the positive things there. If we do it the wrong way, we actually can increase the disparity. The gap can get wider because we're not making sure people have equitable access.
Good, thank you. Yeah, so we are going to be talking about membership tomorrow. So be thinking, and what we're going to be doing is, asking for you to, we'll be talking about categories that we want to have and agencies that may need, or organizations that may need to be represented. I want you to be thinking of individuals. We're not going to be choosing anything, but we're going to, just float some names forward that we can, kind of look at with the process that we do. So between now and tomorrow, think about people that, or categories of people or agencies that you might like to suggest being considered for being on the committee. Other questions, comments about our history? Pardon? Magda? Magda? I hope your line's open, Magda, and take yourself off mute.
I'll try it one more time. How about now?
That's perfect.
Perfect. I wanted to call out attention in this work, and it's something which surfaced in a number of the conversations that we had, and it goes back to the response to question 1 about strategic pragmatism. And one of the tensions is the absolute bedrock commitment, which we'll be talking about this afternoon and then reflected in our work for expanding the who and the voices and the perspectives, is there was a tension called out that, so the equity work is over there, and then there's this strategic work around, say, Medicaid or Preemie Act or Earned Income Tax Credit. I think it is our job to tell a story here about how equity work is connected to the previous versions of its evolution, which include social determinants, how the equity work is, in fact, inherent to the short-term pragmatic work, and that we can be the ones that assure that strategic and concrete ways of bringing an equity frame into this pragmatic work can happen through our recommendations. So I just want to note that, yes, absolutely 400, 600 years of history. Yes, call out equity as bedrock. And the main message that I kept hearing from folks is, go beyond the concept to actually what needs to change currently that will move us in that direction around social policy. To be pragmatic, if you will, about the longer range work of equity. And I just we have the capacity to hold that creative tension. I just don't want the message to be that it's an either or that it's about ideas and not action.
Thank you, Magda. Yeah, my belief is that, and certainly when I was running the state health department, we did not have an office of equity. We built equity into everything that we did, and I think that's what we really have to do, because once you separate it out as a separate entity, then it's somebody else's responsibility, and equity has to be part of everything that we do, and so we will have that conversation this afternoon about how we want to frame how we want to talk about our equity in in SACIM. One of the questions that I put on this thing was, whom do we want to influence and why? That was prompted by Paul Jarris's question really early on when we met in December. Who do we focus on? Is it, and Kay mentioned, we need to focus on the secretary and the HRSA administrator. Is that the only focus we have, or do we have other foci? Do we want to influence others, and how do we do that?
This is Magda again. The historical perspective of this is to recognize that we have a charter. We are obliged to be able to work within the channels of Health and Human Services, and we do report to the Secretary. But history teaches us that what is on the record and what, as Janelle said, comes as a federal voice and the value of SACIM has had a secondary impact and could be potentiated, particularly if the primary channels are not necessarily as robust because of current context. So I would encourage us to explore, as we think about influencing larger consistency, shaping practice, what is norm, if you will, that the think tank idea, the do tank is my preferred language, is, what do we produce and who are we that is an absolute robust body that yields ideas, actions, information, and influence into the policies and practices beyond HHS as well. And we'd be mindful of that. So it's a dual work, and to the degree that we are credible and use our gravitas, we will have secondary impact on organizations, on communities, and community voice.
Yeah, and I want to just, look back at our charter, because that has come up several times. The charter calls for the SACIM to report to the Secretary and advise on HHS activities and programs that are directed at reducing infant mortality and improving the health status of pregnant women and infants. Charter also calls for SACIM to provide advice on how to best coordinate federal, state, and local government programs, as well as private sector resources and activities. It's to represent a public-private partnership at the highest level. So I think that says that we have influence, far beyond just HHS, and our job is to coordinate all of that and facilitate some of those conversations that has to happen. It is part of, as what Paul Jarris often said when he was at ASTO, the public health enterprise. That there's the governmental enterprise, which is federal, state, and local, but also more generic public health, public and private enterprise that has to work together if we're going to actually make changes in our society.
And hi, this is Paul, and this might be a question for Michael, but description of duties, it says, as part of the general duties, committee shall establish bylaws to specify its operational procedures. Are there bylaws? No, I apologize if I haven't read them.
There are not. No, this is David. There aren't any bylaws beyond what's in the charter.
Okay. That is a shall in here.
That's a what?
A shall, not a may.
Okay. God, I hope, because otherwise you're going to be charged with developing those bylaws, Paul, because I don't want to take leadership.
As long as there's money to subcontract it, I'll be there.
All right. Other comments or questions?
Well, it sounds to me like we don't have an independent capacity to be communicating outside of the channel to the Secretary. Is that right, David?
That's correct, yeah.
Okay, but I do agree. Go ahead.
Secretary. So any sort of letters or recommendations or reports will be sent to the Secretary, and in that you can recommend who else the Secretary shares it with, but all those letters and stuff goes to the Secretary.
But I'm thinking also that as members of the committee, as you're in various places and you talk about what's going on with SACIM, you gather input from folks and sort of reflect on some of the conversations that are going on here. There's a way to influence conversations without having a separate report. So I think that there's that sort of that informal methods that we can use.
Right.
All right. Input from anybody else? Anybody else online? All right. All right. Good morning. Good morning. A lot of good information. I think people are probably needing a little break. We've been at this for 3 hours, and I'm assuming that you folks are taking breaks as needed to take care of whatever natural things you have to take care of while I'm stuck here in this thing with all the MSHB folks that are keeping me on task. So we're going to be taking a break right now for lunch, but then we're going to come back, and I hope this all works. I want to have 3 breakout groups to have some discussion by phone, and we have 3 separate numbers that we will have, and then have the groups get together for about a half hour, and I'm going to arbitrarily assign people to groups so that what are the unique opportunities that SACIM has right now. I want that to be Belinda, Colleen, and myself, because that's what I think that's the number right here that we're using here. So Belinda Pettiford, Colleen Malley, and myself. Secondly, who are the partners with whom we want and need to work? I want that to be Paul Jarris, Jean Conroy, and Vijaya Hogan. And then how to best build and leverage the stature of SACIM. I want Magda and Janelle and Paul. Figure they're saying the same time zone for sure. They can work collectively.
Ed, I'm sorry, but did I just hear my name twice?
No, Paul Weiss. Excuse you, Paul okay. Weiss and Janelle Palacio and Magda will be in one. And then Paul Jarris, you're in that. What are the partners? You're with Jean Conroy and Vijaya Hogan.
Okay.
Yeah, we have 2 Pauls, so I'll have to make sure that I use the last name. And David, tell us where that's going to work.
So you'll see, at 1:30 Eastern, just instead of coming back onto this main line, you are welcome just to start to call into the phone number and the passcode that's on the agenda based on the assignment that Dr. Ellinger just gave. And then at 2 o'clock, panel 2 and 3, work group 2 and 3 should hang up and call back into the main line.
So he listed titles, but they correspond to the numbers, right? Group 1, Group 2, Group 3?
Yes. Yeah. Group 1 is what are the unique opportunities that SACIM has right now. Number 2 is who are the partners with whom we want and need to work. Number 3 is how do we best build and leverage the stature of SACIM. Because I want to, get your voices in there to talk about these things, because we know that there are lots of opportunities and there are lots of partners, and we need to leverage the stature of SACIM. And I think those are going to be good foundational things that we can talk about when we get back together again. So thank you all, and we will talk in another hour or so.
And just for your awareness, all 3 of these work groups will be recorded. So if you have a problem with that, you shouldn't, because you're being recorded now. But ex officios and members of the public are welcome to join whichever those 3 is they want.
And then, and you will decide who kind of leads the meeting and who's going to report back, or I guess you can all report back, but we'll have, they're going to be recorded, so we'll take notes from that, but have somebody lead the conversation in those groups. All right, have a good lunch. But, so that I won't have to facilitate all of the conversations.
No problem. I can do it.
Good.
I'll wait a minute for Colleen.
Yep.
Did you have time to grab lunch?
I did. I come from a large family, and I can't say if it's good or bad. One of the things I learned being part of a large family, you got to eat fast, otherwise you don't get any food. So I've learned how to eat fast. That's not always, I don't think that's the best thing, but I can get through lunch pretty quickly.
Okay.
And there's an ACC school in the final game tonight, and it's not UNC.
I know, I'm disappointed it's not Carolina, though I would have been trying to come and stay with you for a day or 2. But no, but I'll be pulling for Virginia tonight.
Yep, so will I. It would have been hard if it would have been Michigan State, because I'm also part of the Big Ten and UVA. Then I would have had to be totally neutral. Now I'll root for UVA.
I know I watched that Virginia game with Auburn, and I was like, oh, my goodness.
Yeah, it was amazing, truly amazing.
It was, but I watched a wonderful women's game yesterday, too.
Oh, I was on the plane. I just got off the plane when it was like Notre Dame was behind by 10 points. I just saw it on my phone. And then all of a sudden, they're tied. And I was like, holy cow, something happened. It must have been really good at the end, or interesting anyway.
It was, they tied it, and then they went ahead, and then they were getting ready to tie it again in the overtime. The young lady that made the winning shot for them last year for them to win the national championship, she missed the free throw. Into overtime.
Oh, that's hard.
Yeah.
Just the opposite of the guy from UVA who had 3 free throws in a row. Like, oh my goodness. Talk about pressure.
And he looked so calm doing it.
I know it. You know, that's why he's a professional.
I'm trying to see if I see any little notes from Colleen. What time is she?
I'm here.
Oh, Colleen, good. Good.
Hello.
All right, Colleen. I'm going to have Belinda sort of, facilitate our conversation here.
Perfect. Okay, Colleen, you got the question that we're all going to talk about. What are our unique opportunities that we have right now at this time? Do you have any thoughts or any suggestions around what are some opportunities we have at SACIM right now? As I learned to call it SACIM and not SACIM. I'm trying.
Okay, I'm just seeing that this is done closed captioning on my screen on this computer. But interesting. Okay, so what are the unique opportunities that SACIM has right now on top of the 100 items that we learned about this morning?
Exactly. Well, I started wondering, do we have any opportunities as additional states are expanding Medicaid to try to connect into some of that and giving more women access? We know healthier women tend to have healthier birth outcomes, and if they have an opportunity to have access to care, is there any way there? I mean, I know quite a few states. My state has not expanded yet, but they're discussing it. Is that any opportunities that we may have?
Yeah, I think you're right. I was also thinking about all of this recent focus on maternal mortality. That sort of, it didn't come out of the blue, but within the last several months, there's been a lot of issues about maternal mortality and the disparities that are there. And I wonder if that's an opportunity to jump on that and get some leverage about infant mortality as it relates to maternal health that we might be able to catch on to.
That's a great idea. And I'm looking at, Dr. Warren talked about this morning the additional $26 million that they're going to try to get out the door. I don't know where they are in the process. I mean, the NOFOs they're working on may have already been finalized and moving on, but I wonder is there a way to get some equity language in there and think through some of those areas.
Yep. Colleen, is there anything in the perinatal care world that's a unique opportunity or new opportunities or opportunities that might be better now than in the past?
Oh, that's right, because you're a neonatologist. Yeah.
Yeah, I mean, I'm always kind of, we have the opportunity to intervene once the baby's born, and then at least in the neonatal world, you get to know the family really well because they're still coming back and visiting the baby if the baby stays hospitalized for a while. And I mean, I feel like there are a lot more, just with my non-scientific personal surveying, it seems like there's a lot more people coming in lately with little prenatal care. I have found that to be the case. And in talking to people, I've not really been able to get at the root of why that is. I mean, oftentimes it's people with other children who they have obviously been seeing medical services for their other children, and it seems like the prenatal care, whether it's just hard to fit in time-wise or the access seems to be the question. I think that would be, but it seems very well covered by everyone that was talking this morning, that obviously that's always a constant driver is for access to care, especially in prenatal services.
That's a great thought. I know one of the areas we've looked at, because our early entry into prenatal care numbers for the last several years have gone in the opposite direction. And one of the things we did find out is that with fewer providers willing to accept presumptive eligibility for Medicaid, that women, it's taking longer for them to get their Medicaid card. And until they get that card in their hand, the provider's not willing to see them without charging them. So it's trying to work through some of those systems issues to try to figure out what's going on there. So trying to improve access to prenatal care. I write that down. Timing and systems issues.
That presumed eligibility, I always consider that sort of a problem, but it sounds like it's really playing out to be that way.
Yeah, I mean, if you get a provider that's willing to accept presumptive eligibility, now the other side, what we've noticed with presumptive eligibility is some providers, they'll accept it, but they don't want it to go into effect on the first visit. They want to hold it to like a more expensive visit, which then still is not helping her get into early prenatal care unless it's a provider that's going to see her anyway and not charge her. You know, like a local health department in our state would not charge her. Hers would be on a sliding fee scale.
Colleen, I was, the whole talk about vitamin K this morning, I hadn't really realized that has become an issue.
Yeah, you know, we have all those issues of like parental refusal for vitamin K or parental refusal for vaccinations, and I think that's getting a lot more press. And we've had like varicella, which is chickenpox outbreaks in the NICU because people have come in who are not vaccinated and then gotten chickenpox. Like I respect people's, you know, the choices they make for their family, but it's starting to have a lot of repercussions on other people's babies as well, I feel like. I think vitamin K kind of goes along. We have a significant, I feel like, portion of people who refuse vitamin K. And then there's other ways to give it, though. That's not a big sticking point for me because you can give it orally. If usually the people that it's the fear of the injection, I guess. It seems more, I guess, super medical for a newborn baby. But you can give it orally. And going back to maternal health, like if a mother has sufficient vitamin K on board, then the baby's usually fine. So that is true, that upstream better nutrition for mom trickles down to vitamin K administration in babies not being as necessary. But I do feel like people they're refusing a vaccination for like measles and mumps and rubella. I mean, it's getting to be so in vogue to refuse vaccination, and then you're having these outbreaks, and it's like, you know, whooping cough, which is pertussis, like it's seeming to come up more and more. And that's not probably, unless in a positive light, we made recommendations just to, you know, get the information out there that vaccines don't cause autism and like all the positives of vaccines. Because if we lived in a situation where like only certain groups could get these vaccinations, obviously people would be really upset. But now they feel like there's more of a luxury to refuse them. Whereas I always think, like, if you lived in a country where you couldn't get a polio vaccine, you would be doing anything you could to get that polio vaccine for your child. But because it's kind of, you feel like the odds are low, I guess, of your children getting it. And I don't really understand why parents wouldn't want. I mean, I understand why they don't want it. They're afraid of big medicine. They're afraid of injecting a newborn baby. I know what their fears are. They're afraid of their child getting autism or a story that they heard on the internet or read on the internet. But I don't know if it's just a matter of getting better information or education out to people that they really can save lives.
Yep. That's a good point, Colleen.
You know, I sometimes think like when we make this division between clinical things helping this situation and public health efforts helping that situation, I think it's really intertwined, because I was thinking even of folic acid, the way folic acid decreases spina bifida by 75, 80%. And then when the public health folks decided to mandate folic acid being in cereal, that really decreased spina bifida because obviously people weren't having to take just a prenatal vitamin. So it's almost like science has to work with the public health. And I don't really
like, I don't like the division into two camps, like, oh, science is over here and public health is over there, because I think the reality is that they work in concert.
Mm-hmm. Exactly, exactly. Colleen, one of the reasons I wanted you to be talking here, because knowing some of the conversations, or at least emails we've had, what do you think about the changes in the rules of Title X that SACIM, I mean, because there are lots of opinions, but is there an opportunity with those changing rules for us to do something as SACIM, change the conversation or get different data collection? Just wondering about, about that.
Can you tell me what Title X is?
Oh, Title X is the federally funded family planning program. So it has been, it goes to the states. It's separate from Title V, the maternal and child health, but it's been around since the 80s, I believe.
70s.
70s, and it's funding family planning. Belinda probably knows more about it than I do.
Well, go on.
Go ahead.
No, you go on.
No, I probably don't know enough of, I'd have to read what it is in entirety, because I think I know like what you're referring to a little bit, but I don't know in full what it, I don't know if I have enough information to comment, and I'd have to read up on Title X first.
Well, I do think in general around family planning, with Title X funding, we were just awarded our new Title X funding. And I do think there's some opportunities, because it looks like when they awarded the Title X funding to all of the sites, the OPA kept some money. They didn't put out all of the money. There's some money that's still they're holding on to for some reason if you add up all of the numbers. And because it's level funded in the president's budget, I think that was a little surprising to everyone. But I think if you look at the issue of pregnancy and tenderness and linking it back to women having access to contraceptive methods, if you can take the abortion conversation out of the mix, because that's where people get caught up in, and it seems to be that's their biggest focus, is that they really have looked at Title X and tried to focus, realizing that Title X funding have never been allowed to be used for abortion services, but it has seemed to have overtaken the narrative.
Yeah.
Oh, so you're talking specifically about using tax money for abortion services? Is that what you're saying? The question is? Or you're saying it's not the truth?
No, the Title X cannot be used for abortions. But it has, in many states, it's gone to Planned Parenthood.
Right.
So that the rules have changed so Planned Parenthoods can't get it, which changes access in many states. But it's all about abortion, even though Title X isn't about abortion. And so
right.
I'm wondering because that conversation I think has to occur somewhere and somehow. And I just don't know if SACIM has a role to play in any of that.
Well, and it's interesting because they did fund some Planned Parenthood sites.
Oh,
so
they did?
All of the sites that they funded, some of them are Planned Parenthood.
Oh.
But that's because they're funding under the current rules. The new rules are supposed to go into effect a little bit later, but they may be tied up in court for a while.
Okay.
But they did end up funding some. And where we were anticipating that they were going to funding for 1 year, they actually ended up funding sites, it looks like, for 3 years.
Okay.
But you're saying it's more for contraception and health things? Is that what you're saying?
Yes.
Or no?
Yes, that is wholly for contraception and family planning and women's health. Some primary care stuff that related to reproductive health is in there.
Yeah, I don't know enough about the breakdown between the federal and the state issues on that, because at least in Illinois, our new governor is basically saying that anyone in the whole Midwest could have an abortion on Illinois' dime. So I don't know. We have Indiana, Wisconsin. He's basically said all you have to do is show up, and so I don't know how that breaks down between federal dollars and I think Ed has alluded to, Belinda, is just that we talked a little bit about I don't know, maybe you're on that email. You might have been on that email. But just recent things of the abortion, like Born Alive Protection Act for survivors of abortion. I don't know. I don't obviously know how anyone else feels on this committee, but I feel like if we're proposing to be interested in infant mortality, that I think that I would like to see us in support of that. But I know that's a touchy subject, and I don't know where everybody else stands on that. But when I think of infant mortality, that seems to be like a common sense position that we could find amongst those two camps of people with abortion, but it seems like even that, which seems like pretty commonsensical, we can't even find agreement on that. So I don't know. I'm not trying to bring up some dramatic event under this committee, but I was just, when I think of infant mortality, that's a piece of it. Obviously, it's kind of a small piece, but it's just kind of like I feel like.
Yeah, because I don't think I was on the email. So can you tell me what?
Okay. I think it was, you probably weren't on the email if you weren't on the committee for history. Because it was just kind of something involving what we were talking with Magda on the history. It was like a subgroup for history. So I was just trying to think of like, what can we do for infant mortality? And I think you have to be reading just then and there about, you know, it's the whole thing of even, well, this is in utero, but when talking about ex utero, can we at least protect infants ex utero at that point? Because that goes, you know, now I think there used to be that if you were on trial for killing a pregnant woman, you'd also be on trial for killing the baby as well, but that's kind of gone away. So if we're then going to say, well, what about ex utero and the baby's out, and they tried to pass some legislation to protect infants born alive from abortive procedures, and then that's always kind of, it seems like to me, like I don't know, like, can we disagree on that, but it seems like not necessarily. But I'm not trying to stir up drama in this committee. Is just, you know, that's where Ed is, I think, bringing up Title 10 with me, because I had brought that up.
Got it. Yeah.
There are some things that we probably should not avoid, but just not get into, because we're probably we could go around and around for a long time and not make any progress. So we don't have enough time.
Yeah.
I have three other issues that I think are opportunities. One is that National Academy of Sciences report on poverty, and how so there's a big focus on if you reduce poverty, you can reduce infant deaths by, I don't know the exact number, but that was one of the reports. The other is there's been a lot of information about incarceration and about housing, a lot of focus on homelessness and incarceration, particularly among African Americans and American Indians. And I'm wondering if that presents some opportunity, since there's, again, focus on some of those two social determinants of health, that we might be able to, you know, have some opportunity to weigh in on those two issues.
No, but to me, I think that makes perfect sense. I mean, and it's a pretty good connection between the two. So yeah, I'll add that to our list.
Yep.
But I also wonder, I think it was Paul Jarvis that brought up, you know, this is the 400th anniversary, I think. Janelle brought up 600 years. Do we need to have some conversations around, you know, some of the historical, you know, some of the history, the things that have been put in place that could be impacting outcomes now?
Mm-hmm. Yeah, those anniversaries are always good things to use. So it's the 400-year thing. I know a lot of people are talking about it. I don't know exactly how we can link into that effectively, but that might be an opportunity.
Well, and it may be as small as reaching out to whoever's working on it to see if they are making a health connection to it.
Yep, good idea. Yeah.
Which anniversary are you talking about?
The 400-year anniversary of the beginning of slavery in this country. So I think a lot of...
Hold on, I just didn't hear the words, sorry.
Oh, I'm sorry. Okay. And then the anniversary, is this 600 years this year for, I know the 400.
No, that would have been 1492. So that was several years ago that they had the anniversary.
So we wouldn't be.
Yeah, we missed that opportunity. But I still think if we did something with the 400, also then bring in the fact that there are others who have been disadvantaged by discrimination in this country. So you can be a little more inclusive.
Okay. And I thought a couple of, I think some of the wording around, there are a couple of states that are really focused on paid parental leave and air forces of that. I think to me that is a connection.
Mm-hmm.
Work around paid parental leave as well as a livable wage.
Yep.
And what about the rural health idea, is that something that we're kind of including in all of this? Is it a breakout point to focus on anything with rural health? Or?
That's a good idea. Yeah, because at the same time we're focusing on inner city and urban rural communities are dealing with very similar issues, maybe from a different perspective.
Yeah, I think they have a huge access problem when you talk about driving for 2 or 3 hours to see a provider. And
excellent. Yep.
especially if they have to see a specialist. So if you have a prenatal issue of any kind and they have to, I can't even imagine an all-day affair like driving 2 or 3 hours to see a provider and then waiting to be seen, and then you wouldn't be home till 3 hours after you arrive. It's crazy. But there is kind of an interesting telemedicine option, I think, is at least in our current technological advances could be offered, because, I mean, there's not a great solution to have a specialist in these tiny, tiny towns. That's not going to work because there's not enough density of need. But I think with modern day telemedicine, kind of like similar to our conference today, but hopefully less glitchy on from my standpoint, because I've had my calls keep getting dropped. But that might be a good way to reach out to those folks.
Are you guys aware of Project Echo?
Yes, we did a whole, that's a great thing.
Yeah, so I know they're doing Project Echo for HIV and for opioid abuse. Could also be, I wonder if it also could be used for, prenatal care and I don't know, even deliveries in rural communities.
Yeah, that's a great program, and there's been a number of imitators out there that, not in a bad way, but kind of offshoot programs that have done similar things. So that helped, I think, a lot.
Yeah, I don't know enough about it or how it works, but it just seems to be like it's an idea that deserves some attention, and I wonder if it deserves attention by SACIM around infant mortality.
Yeah, because I mean, the focus is on rural communities, if I'm remembering correctly. I know we have a program here in North Carolina.
Yep.
Yep. Well, and actually, the Bureau, when they released that, they did release funding, I guess about a year ago, around telehealth for behavioral health. So for pregnant women dealing with mental health or other behavioral health challenges, as well as young children. And so telehealth was the foundation of that.
Oh, okay.
Can we think of anything else? It looks like we've got about 2 minutes before others may start joining us.
Yeah, that's sort of my list of unique opportunities.
I had one small question, because you know how, and I don't know the number of states that have legalized marijuana, but I think Illinois might be moving that direction too, although we haven't yet. We do have a lot of babies, and it's not much of a withdrawal, and obviously it doesn't take the baby out of the family's home or anything like that. But I don't know, like pregnancy and marijuana use is going to be continuing to increase because, especially with the legalization of marijuana, and it's not that harmful for the baby. It's not that great for a developing brain, but I don't know if there, again, like from just a positive educational standpoint, if there could be any recommendation to avoid marijuana use in pregnancy in the same way as cigarette use in pregnancy is to be avoided. But it seems like that's more and more common too, especially as it's not going to have the legality issue anymore.
Excellent idea, since it is moving forward without a whole lot of thought about the health consequences. So just raising the issue might be enough to have people start saying, oh, maybe we better collect some data about cannabis use in developing fetuses. So that's a good idea. I like that one.
Okay, I added it to our list.
Yeah.
So we got a pretty good list here. If y'all want me to go over it quickly, what I wrote down, we included Medicaid expansion, maternal mortality, especially the focus on disparities, maternal health, funding that's coming out of the Bureau, if there's an opportunity to get equity included in it. Access to prenatal care, we're seeing it go in a different direction than we would like. So looking at the systems and the timing of prenatal care. A need to focus on the positive of vaccines, where we're seeing that now some of the outbreaks are impacting other children. So it's not just families making their own decision for their children, but the impact on others. The importance of public health and clinicians or clinical working together. I put Title 10 down here around family planning and the connection to pregnancy intendedness. The National Academy of Science report on poverty, and there may be some things there that we can pull out. Incarceration and the equity issues that are associated there. In many cases also with housing. Maybe connecting to the 400-year anniversary or just years of discrimination and having some dialogue and some connections and trying to find out who's already working on these areas that we may can connect to. There may be good people to come in to do a presentation. Paid parental leave, livable wages. We're seeing several states moving into that area. Rural and urban health challenges, and that's connected also with telemedicine in rural communities, and then the impact of marijuana on birth outcomes. You all think of any area that we missed?
Did you Project ECHO for infant mortality?
Yes, oh, that's right. I got telemedicine and then Project ECHO. Well, I wrote it there. I just didn't say it.
All right, good. Good list. Good list. And I'm sure others will have other things. So we'll take a little break here while we wait for everybody else to call back in. So I'm going to put myself on hold or on mute here, so you won't hear me drinking my coffee. And then we'll come back when everybody else gets back on this call.
Sounds good. Thank you all.
Okay, thank you.
everybody back from lunch and their discussions?
Yes.
Not an overwhelming yes.
Yeah.
I'm here.
That's what I wanted to hear.
Who's that?
This is Belinda. I'm here.
I know Belinda and Colleen were on the call here, so is Jean Conroy?
Yes,
All right.
I'm on.
And Vijaya?
When people brought children, were you prepared for that, or how, or was there a lesson? Vijaya might be a little late, she said.
Okay. So that was Paul Jarris, right?
So we were prepared to have children. So part of that cafe model is to have parents come with their children.
How about Paul Weiss?
But to have a separate space for the children.
It says group 3 is will be joining us soon. They're finishing up their call.
Okay.
A separate room.
All right, we'll wait just
California time.
Have that free time to have a
Are we hearing another conversation?
Yeah, I think
But yeah, but we are quite challenged with that because that may be the ideal situation for the model, but
I'm so glad I didn't do this from my kitchen table. It was short and sweet.
Ed, that made it into the official minutes
I know.
on the screen.
I was saying that I come from a large family, so one of the things you learn in a large family is how to eat quickly. Because if you don't eat quickly, you don't get anything to eat. So a half-hour lunch is very generous.
This is a different computer.
Oh, you know what? No.
Okay. Yeah, this is computer just different. Oh, yeah. Same brand, but it's a different computer. David.
What's that?
This?
Is anybody from that group 3, Magda or Janelle or Paul Weiss, back in touch with us?
It's Janelle.
So they're probably still determining how to leverage the stature of SACIM.
Yep, Paul Weiss.
Location and yeah, so they should be on pretty soon.
I'm on now.
Oh, great.
Yeah, I just was having trouble getting through the operator. We're all set.
Very good. All right. Let's. So before we get started on giving reports back, haven't heard much from Paul Wise or from Colleen Malloy. Paul, do you have any comments from this morning's conversation? Any just sort of assessment that you had or any takeaways just that you've been thinking about?
Well, thanks. I really appreciate all the comments that have been made and agree with the main messages that emerged out of the morning's meetings. The lens through which I'm listening to these is really generated by a long-standing experience working with advisory committees on infant mortality and related issues, and actually issues that we discussed in Group 3, which is what is actually the strategic contribution of SACIM going to be, given the current challenges that we face, but the current challenges given the legacy of prior committees and prior activities in the past. And thinking about this structurally, of how we will need to shape our agenda and commitments to meet and overcome the inherent structural obstacles of any advisory committee, but particularly an advisory committee that's dealing with an issue that has been around for quite a while and that would elude any singular focused solution. So that, I hope, would be part of the discussion that we would have this afternoon to better help us create the agenda that would enhance both the utility value, and stature of the committee over time.
Good. Thanks, Paul. Colleen, did you have any sort of observations or takeaways from this morning's conversation?
I appreciate all the information from this morning, including the history going back and, you know, how far that we've come in terms of infant mortality. When I think there's been a lot of advances in medicine as well as public health outreach programs. So I just appreciate kind of the historical lessons from this morning. And I think there's, you know, everyone has great intentions to do the best thing for the country, including the current administration, I think. So we just all have to, I think, respect each other, and we all have to realize we're on the same side of this and working for the betterment of mothers and children.
Great. All right, so let's get into the reporting back from our little short work groups. And what I would like to do is have somebody from each of the groups just report back on sort of what they talked about and sort of the dot points that they have, and then take a couple of minutes for people to add other things that they, without a whole lot of discussion, add other things that they may want to add. And then when the three groups are done, then open it up for some general discussion about the vision and scope of the work of SACIM. So why don't we start with group number one? What are the unique opportunities that SACIM has right now?
This is Belinda, and I'll be reporting, and our group included Colleen and Ed. So with our focus on the unique opportunities, we had discussions around Medicaid expansion. We know some states have expanded, others are considering it, so we're trying to figure out if there's some connections there and opportunity. As well as maternal mortality, and especially all the work around it, and knowing that disparities is part of it and its connection back to infant mortality. We also included on our list, you know, the additional funding that the Bureau has received, the $26 million around maternal health. Not quite sure where they are with the NOFO, if it's been written or if there's an opportunity to get equity included in that NOFO if it's not going to already be included. We also included access to prenatal care. In many communities, we're seeing those numbers go in the opposite direction. So, you know, looking at some of the systems, some timing issues, but we, you know, it's the importance of getting women into prenatal care earlier. Then we also included the need to focus on the positives of vaccines, you know, where we're seeing families making a decision not to get their children vaccinated. Now we're seeing with the outbreak how it's impacting other children and even those kids that are in the NICU. So we want to make sure that's a critical piece that's included. In a few other areas, the National Academy of Sciences report on poverty, we think there's some opportunities there. The importance of public health and clinical care working together as a team. I think we try to do that frequently, but making sure that it is a priority. Title 10 and, you know, family planning in general around the issue of pregnancy and tenderness. The impact of marijuana on birth outcomes, and, you know, is that also a unique opportunity? Incarceration, especially as an equity issue, and we know some work is going on, but what can be done to make sure that that connection is made to improve birth outcomes, as well as housing and challenges there. We also felt like we needed to potentially reach out to the individuals or the organizations that are working on the 400-year anniversary for slavery, as well as efforts around just years of discrimination in general. What other organizations or entities are working on this area that we can connect to? We also include livable wages. That is a direct connection, as well as paid parental leave. And then we also realize that there's some unique challenges with rural communities and urban communities, and we felt the need to make sure that telemedicine and things like Project ECHO, and that it may be considered an opportunity as another unique opportunity for SACIM at this time.
Good. So from people from the other groups, any other opportunities that you see that weren't mentioned on that list?
Janelle Palacio.
Is that Paul Jarris trying to speak?
No, it wasn't.
Okay, I heard somebody in the background. Any other additional issues we want to put on that list of unique opportunities? All right, if not, then let's go to the partners. Who are the partners that we need to work with? That was Paul, Jairus, Jean, Conroy, and Vijaya Hogan.
Yeah, so this is Paul. And the reason Jean is going to be president of FIGO is because she delegates well. So I got delegated to be the reporter. So a couple things came up. Some really excellent work being done on the clinical side through the Council on Patient Safety and their complementary organization on preventive care, WPSI, I think it's Women's Preventive Services Initiative, which is supposed to be a women's health corollary to Bright Futures. And Diana Ramos actually leads that group, who would be quite an amazing person to work with for the group. Barb Levy also at ACOG staffs those two committees and would be a great resource to us. With some other thoughts, the Federal Reserve possibly, given the community investment banks and the work they've done on health and investing in communities to improve health can help us potentially with some of the social determinants in communities that are more challenged. Bringing in either some national business groups, but National Pacific Business Group on Health. There's a gentleman there, Neil Shaw, who works quite a bit in this area because the employers and large businesses do have a real potential to impact the environment in which women are living in this country. The Alliance for Community Health Plans is an organization that is made up of the Kaisers, Geisingers, Group Health, Puget Sound, and other really integrated health systems that very much take a community approach to things. CC Connolly leads that, and bringing in those very responsible integrated health systems to the discussion could be helpful. Philanthropy is another possibility. The California Endowment and Tony Eiton came up, but there may be others like RWJ who, if we could engage them, could not only inform the Secretary, but help spread the word through their funding. People in the preconception health work area, Dan Frayne is one name that came up, family physician who's working on preconception health and working with clinicians to try to improve preconception health. Now, a couple of these are now going to get a little less defined, but an economist, it's very impressive how the whole field of economics and how they look at disadvantages to certain population, advantages to others. As you'll recall, it was the economists who first identified the declining life expectancy in this country and originated this term of deaths of despair. So having that economist perspective might give us a lot more leverage, or more tools we could leverage for our work. The people in the environmental field, such as the Environmental Working Group, a gentleman named Ken Cook, really to look at different exposures that occur that are affecting birth outcomes. And of course, these exposures are very often unequal in different populations. And then really, along with this theme of intergenerational, try to figure out how we can bring more of that perspective into our work, more of that expertise, whether it's the epigenetic mechanisms or exosome or other things. And Paul Weiss, you may be able to help us quite a bit with this. So Gene had mentioned Agilent Technology. I can't remember the gentleman's name. He's also Johns Hopkins. Gene, I don't know if you have it, Anthony, somebody, but just bringing that. Excuse me?
Before we had the
Okay, but you know, helping us drive that intergenerational concept and work further would be helpful. So let me ask if anyone in our subgroup had anything to add or correct.
Again, you know, I didn't think of saying somebody, but DOHAD, Developmental Origins of Disease, Health and Disease, finding a leader in DOHAD would be a consideration too.
And the one, I'll put the last, there wasn't agreement on this, but it was a point I made in the small group that we want to consider is the whole area of communications and how we reflect our proceedings, because it's important that we do so in a way that can be heard. If we're advising the Secretary of Administration, there are probably ways we can say things that will resonate most and ways we can say things that will not resonate. So being conscious of that. And that might, there may be some expertise we can work with to assist us with that.
All right.
And I think, Ed, I think that's it for now.
All right. Good list. Some things that I hadn't really thought about that you went outside of, at least went outside of the box that my mind is in, so that's good. Anybody else have other things that they would like to add to that list of partners you may want to think about working with?
I have two suggestions. This is Magda. Can you hear me?
I can hear you loud and clear.
Excellent. It's more about leading to the question of what are the multiple agendas and purposes of SACIM that will come into question 3. But one of the consistent feedback that I got during the history process was how SACIM has directly the voices of particularly women, fathers, and communities of color, and not in a way that is not token or exploitative, that has genuine welcoming the power and the partnership of voices of those directly from communities and you know, not about us without us. So I'm not sure I heard that in your report out, and I'm just wondering if that came up, given that even this week there has been last week the Women's Health Summit and the Black Women's Health Agenda, and folks are meeting elsewhere with direct voice, and the question is how do we tap into that? So that's one. And I'll say my second one quickly, and that is, as I met with younger colleagues about SACIM, particularly the young staff at Baby Zones in Berkeley and among others, there is an opportunity for us to, as a parallel agenda, to use the work of SACIM as it becomes more robust in its next generation, to bring a younger generation of emerging leaders along to contribute, to be staffed, and what's the learning opportunity for workforce development in intersectoral work around infant mortality, not just MCH trainees. And I just would like us to be thinking about how younger staff and potentially schools of public health and students and others are at the table using this as their real-time case study and learning about transformational systems change.
Like this, Paul, those are really great points. And the idea of greater outreach to people with life experience is something that came up, but neither Gina or I felt like we knew who the right people would be or the right organizations would be, so that's something we'd like help with. And then I completely agree with you. We've got to get the younger generations involved, not just from our own point of view to, quote, teach them, but also to learn from them. They have very different ways of communicating and thinking that could make our work much more effective.
Yeah, that's part of my agenda, is to get an intern working with our committee here as one of those leaders to help us do our work and to learn from. So good list of activity. Anybody else, anything else that they would like to have on it? Wanda?
Can you hear me?
Yes, I can.
So there was just a recent announcement by the State Department, actually, doing some work on innovation in, or I guess, state impact partnerships to pay for results. And it's actually, the Treasury Department, they're providing $75 million in awards to state and local governments to scale evidence-based interventions for calling it Pay for Success. And the topics that they're interested in looking at are things like reducing teen and unintended pregnancies, improving birth outcomes and early childhood health, reducing rates of asthma, diabetes, and other preventable diseases, improving health and well-being of those with mental, emotional, and behavioral health needs. So I guess in terms of just thinking more broadly about partners, it seems like there are these opportunities to look outside our circle, as Paul had alluded to, where there may be opportunities to really improve health outcomes.
That's amazing. That's health in all policies. Michael.
And an interesting piece on that funding opportunity, half of that funding has to be spent on children's issues, if memory serves me correctly. So there's a potentially very large investment there. It's at Treasury right now. We were consulted to have some input on the release of the funding announcement. Our thought is probably when those are funded.
You remember the date?
They'll have to connect with us for administration and management of those. We'll see, but we're anticipating having a touch point, but potential for a really large investment in children's issues.
So if you could provide the committee with any information that you can about that whole approach, I mean, I had not heard about that, and it seems quite exciting as a intersectoral work on sort of a health in all policies thing.
And who's speaking now? Who just spoke?
That was Michael Warren.
Thank you, Michael.
For everyone's awareness, what you're referring to, the name is CIPRA. It's the Social Impact Partnership to Pay for Results Act.
Okay, CIPRA.
CIPRA, S-I-P-P-R-A.
Is it? I thought it was State Impact Partnerships. Is that the same?
Social Impact Partnership.
Oh, okay. I'm looking at the email that ASTA sent out. Okay.
Excellent. All right. Well, somebody else, Magda?
Yeah, a quickie here. I'm curious, this has to do with rules of the game. One of the pieces of information that I heard, and then we have heard in our current iteration, is there's just not a lot of money to support this work of SACIM. There's not a money to travel us there, and it's limited and structurally. And I know Paul Wise will talk a little bit about the structural implications of raising visibility. But I'm wondering, in the comment, Paul Jarris, that you made about philanthropy, given if we were to frame participation in SACIM as a leadership development opportunity, or some way that it is part of workforce development or as part of larger policy impact around equity, whether or not, and this is to you, Michael Warren, can we, would it be strategic or even feasible to look for foundation money during this next iteration of SACIM to be able to subsidize and braid with and leverage the small amount of federal dollars so as to minimize financial barriers to participation in a real-time way of partners, to literally have folks at the table or have them involved, whether that's future students and future leaders or whether that's consumers. I'm just wondering how we don't let structurally the small budget for this, if we do decide to raise up SACIM, how we could look for some braided funding in the private sector, and is that allowed?
I think it's a great question. I think a couple things. One, happy to reach out and get some better understanding of the lanes on the lines on the road for us. And then two, I think thinking through what specifically we might want to use that funding for. Part of that may be informed by the first part of that question is what are the lines on the road. But they may also, I'll reach out to council and see, my thought maybe they want to know, like, what would we use that money for? So I'm hearing some of that may involve sort of support for people to travel and attend. But also I think I heard events, whether that's maybe underwrite the cost of events sort of more globally. Is that...
Thank you, Mike. I appreciate you looking into that. I think part of the feedback that I got in the history gathering was, don't just bring us to the table. Do not have us warm a seat. How do you create it to be an authentic welcome, and don't structure it that we're there in name only. So it's part of that historical experience and lack of trust, and we want to be very strategic and mindful about what can we deliver. And I want to say that again, what can we deliver? Thank you.
And all of this conversation about partners is something that we'll cycle back to when Belinda leads our conversation about expanding our committee to its full complement. And these are a lot of good ideas, so I'm sure Belinda's been taking notes on some of these ideas that we can talk about tomorrow. So the third group, how to best build and leverage the stature of SACIM.
Thanks. This is Paul Wise. Our group also had Cheryl, Janelle, and Magda. And basically, our feeling was that the stature of SACIM will depend on strategic choices that we will have to make as an advisory committee. That we've all had experiences with a variety of federal and state and local advisory committees. And there are different roles that we can play. But that many advisory committees, particularly dealing with issues that address HHS units, divisions, institutionally, that have really good, smart people working hard on this issue, is that the nature of an advisory committee could, in fact, be purposefully have low expectations. In other words, that there's an inherent tension with an advisory committee that it could put greater expectations or hold accountable groups within HHS, for example, that are working on these issues. And so we will have to make some choices about the kind of committee we would like to be. There are sort of three arenas. One is, do we want to use the committee to elevate the broader issue of infant mortality, maternal well-being, perinatal outcomes generally? And we basically are a committee that's going to try to elevate the importance, the compelling nature of this challenge outside of HHS. The other is to see ourselves holding the various groups more accountable, and particularly for inclusion of infant mortality and its relevant associated issues more directly parts of initiatives that are ongoing within Medicaid, within a variety of different agencies, both within HHS and outside. What are the points of leverage that SACIM can identify and take advantage of to ensure that the infant mortality issues are being addressed adequately within these other initiatives? And I'm glad that the deaths of despair, particularly the paper that came out on falling life expectancy by Angus Deaton and colleagues at Princeton, but that paper was inherently provocative, that it basically put pressure on status quo processes, saying the status quo is inadequate. And if we're going to assign ourselves the role of holding accountable the status quo, the current processes in place, the units that are supposed to be, and in this area are addressing issues of perinatal outcomes, then we ought to be purposeful in defining our agendas and our activities and the voices we want to bring to the table to meet that kind of strategic choice. Alternatively, we could see ourselves and other advisory groups can play this role, have played this role as more like a cheerleader, elevating the issues and a list of issues within HHS and outside, serve as a communicative clearinghouse to ensure that the different groups are talking to each other to facilitate that, and to facilitate new kinds of engagements that cut across silos that wouldn't necessarily happen without a advisory committee like SACIM. So I think the bottom line is that, and we of course would welcome your pushback input and continued discussion on these issues, is that we have to make some strategic choices about the kind of role we want to play and the kind of advisory committee that we want to be, given a full understanding that we are advisory to the Secretary and that there are remarkably talented, hardworking groups already engaged on these issues really across HHS. But we do have to make some choices strategically to ensure that the structure of our committee, our agenda, and our contributions ultimately will address questions of stature and ultimately of strategic contribution. I'll stop there.
Well, that was a great lead into our general question. You know, how do we want this committee? What's the vision of the committee that we see as a group, and what's the scope of our work, and who do we want to influence? So if anybody has some thoughts that they would like to share about what you've heard with the status, partners, the opportunities that we should consider as we sort of frame ourselves. I'm seeing that between now and our next meeting, whenever that is, that we will sort of have a lot more organized approach to come together then to really start the work in full blast, hit the ground running at our next meeting when we all get together. But we'll have, I hope, some work groups between now and then that'll help us frame some of that vision and scope and work that we want to do. But let's start the conversation here for just a little bit.
Could I ask Paul a follow-up question? You mentioned that Angus's paper was provocative. And I'm curious, could you unpack that a little bit? It was basically good economic science and good economic data. And the data and their findings were provocative, but I didn't detect any kind of an agenda in that. Do you see it differently? Or because maybe it's a great example of the type of thing we want to do without crossing over into politics or agendas that aren't science-based.
Thanks so much, Paul. No, the impact of that paper was because it was unexpected, and it functioned as an essential challenge to the status quo processes that most people felt will continue to result in sustained improvements in life expectancy. It was a shock to say we have not only new challenges, but that the groups that are in charge of improving life expectancy are failed. And in that sense, it was provocative. It was analytic and methodologically beautiful for the people who study this. But its impact on public discourse and on the applied groups both within and outside the government and academics as well was a challenge, that this was a problem that has emerged on your watch and that we need to do things differently if we're going to address it. So in that sense, it was a provocation. It was disruptive based on strong analytic evidence, not based on an underlying political agenda.
Yeah, great. Thank you.
Paul Weiss, I'm not familiar with that paper, and I'm hoping that MCHB can get us a copy of the paper and send it out, because it fits with our narrative work, which I think I'd like to be able to see that and put it into that narrative work that we're trying to do. So I think they'll reach out for you because I'm not familiar with the paper.
In the paper, it actually resulted in a book as well. But there have been several papers that Deaton has written on this, but happy to help circulate it to the group.
Great, great.
Thank you.
Other comments?
I think Vijaya just put it in the
All right, Vijaya. Yeah, I don't have a computer. I'm depending on the staff here to tell me when I don't have the computer in front of me. So Vijaya?
I think she put the link to the article in the chat box.
Oh,
Exactly.
Okay. All right, very good.
This is Magda. I would ask Paul Wise if he, just because it's a lot of it reflects our conversation, but would you be willing to put headlines on the sort of the three choices that we're suggesting we would want to, we need to strategically make? If we could just sum that up into 3, A, B, and C, and then I would add a D, which is what are we not willing to do? And I just would encourage us to, part of the strategy of saying what we want is also being able to state what we're unwilling, what our bottom line might be, and that may at some point bring clarity as we discern how to be as strategic in both focal impact and design and structure to get results. Thank you so much.
Hi, this is Paul Wise. The first issue is how do we elevate infant mortality reduction and its related determinants to become more of a compelling issue. It has been marginalized largely by other important issues within HHS, but how do we elevate it as a priority? Second is how do we design, what strategic choices do we make as a committee structurally to ensure that we have high expectations of impact for the committee and then meet them? And third, that we look for the leverage points within active initiatives within HHS and ensure that issues around infant mortality are included and the voices, particularly the non-traditional voices that have stake in infant mortality, be brought into the initiatives and leverage points across HHS as we move forward. Is that okay, Wanda?
Absolutely. Thank you.
Good. I like clarity. That's good. Any other comments? All right, this is all really good foundational stuff for our conversations that we will have tomorrow in particular about how do we organize our work, how do we prioritize our work, how do we move forward and with whom. So that'll be part of our good conversation. Great. Any other thoughts about this before we move on to the next part of our agenda? Anything that wasn't shared or stated in any of the other discussions that we need to put out here?
Ed, just a really minor point. You had mentioned having a young person as an intern. I think it would be important to try to find somebody earlier in their career to be a full committee member, if that's possible. I know that has to go through a vetting process, but really bring the folks we're interested on as full participants.
Yeah.
But there's a big status difference with an intern.
Right. Yeah, it's one of those people in all work sites. Health and all policies. Different ages in all workplaces. Yeah, it is true. You need workers and then members of the committee. We don't want somebody just as a worker bee. You need to be at the voice at the table with the same power as everybody else. Thanks.
The other thing, this is Michael Warren. The other thing I was thinking about is that comment came up earlier. I mean, these are public meetings, and so to the extent that folks have students rotating with them or interns or others, particularly if they're virtual meetings, pulling them along to those meetings would be a great opportunity and really sort of low-tech way to start to engage folks. But if there were additional funding available as we pursue that, to think about supporting trainee or young staff member travel, that may be another venue I'd have as a to-do to check on the intern piece, and thinking about how we continue to bring staff to Dr. Jarris's point, young staff, trainees along, that may be another opportunity.
Right. Good. All right, let's move into the narrative piece, and so give me a couple of seconds here to get the computer in front of me. And it says my battery's running low.
Love closed captioning.
Oh, the plug is coming out in the back.
Oh.
Other end.
The round one.
Another reason we need young people on the committee.
There we go.
And then it's just that little arrow. Right here.
Oh, I got to do that. Okay. I'll get it here yet. All right. So we're going to talk about a little bit about the narrative work that I've been doing over the last couple of years, particularly when I was ASTO president, focusing on how to advance health equity and optimal health for all. And narrative was a big piece of this. And this follows closely and really what Paul Wise was talking about, and the importance of narrative and how do we get at some of the current conditions with the messages that we're giving. And narrative is really important because, as Abraham Lincoln said, public sentiment, or I think narrative, is everything. With public sentiment, nothing can fail. Without it, nothing can succeed. Consequently, he who molds public sentiment goes deeper than he who enacts statutes or pronounces decisions. He makes statutes and decisions possible or impossible to be executed. And that's why I think it's also the comments earlier about need somebody in communications. How do we get the messages out? Not only we have to figure out what to say, but then how to say it. And having different ages and different backgrounds and different sectors involved will really help with that. And I'm going to be using a couple of the slides that Dr. Warren had done previously just to make the point, that our infant mortality has not been improving as rapidly as infant mortality in most other countries, the high-resourced countries. We had been doing much better back in the 70s than most OECD countries. We've improved, but not improved very rapidly compared to the other countries. But the most important thing, at least from my standpoint, and Dr. Warren used this slide, which I stole from him, borrowed from him, is that even though our rates have gone down, our disparities haven't really improved dramatically. And I think it's important to note that we did have some places that back in the 70s, we had some decline, fairly rapid in African American infant mortality, and then it plateaued starting in the 80s. And so something happened there that we should learn from. But obviously, what we are doing is not working. With all of the good medical care that we have and the good public health work that we've done, I believe we have a great medical care system. It has a lot of work to be done with it, obviously, and we have a great public health system. But as good as that work is done, it is not achieving the goals that we have of reducing infant mortality. And in part, it's a math problem. If infant mortality is an average, if we have big disparities and we have increasing populations of colored American Indians who have high rates of infant mortality, it's just a math problem. If we don't reduce those disparities, our average is going to not improve. But really, it's more of a social justice issue than a math issue, and I think we all recognize that. And I used the slide at our first meeting because it pointed out the fact that, in fact, our disparities have increased if you look at comparing African-American rates, black-white ratio from 1935. And I think it's of interest that the disparities went down during World War II. And I think there are a couple of reasons for that. One is that we had this whole sense of belonging. We were all collectively working on an issue. And we note that, and we in Minnesota, we put belonging as one of the health indicators for health, and that we had a sense of belonging. But also, it was during World War II where actually we had government-sponsored maternity care. It was provided, it was national maternity care, it was maternal health insurance basically for all working women in maternity, because we really wanted to make sure that they got good care because they were part of the workforce. And so I think there was a couple of things. There were some of the social factors and some of the medical factors that really improved. And then rates went up, and then they went down again in the 1960s, where again we focused on improving access to care, but we also really took a health and all policies approach with the war on poverty, with food and transportation and housing and education and economic development. And I think it's interesting that the neighborhood health centers came out of the Office of Economic Opportunity, reflecting back to 1913 when the Children's Bureau was in the Department of Labor, the reflection of economic development. And then when we started to get away from some of those policies, that's when our rates started to increase and the disparities started to increase. That line that goes from lower left to upper right really started to increase in the late 70s. And that is where our problem really started to really hit us. And certainly it reflected dramatically in this slide with maternal mortality, where we are one of the few countries that actually maternal mortality rates are going up, particularly among African American women. But it's not, as you all know, it's not because of a lack of financial resources. We're putting a lot of money into health care, and obviously we're not getting the kind of benefit we would like from that. So it's not because of the lack of resources, but it's really about, a couple of things, how we actually use our resources. This slide that shows expenditures of health and human services expenditures in OECD countries, you can see the United States doesn't spend as much as many countries in terms of total health and human services, but it certainly spends a greater percentage of what we do spend on medical care. So as it says, for every dollar spent on health care in OECD countries, $2 is spent on social services. In the United States, for every dollar spent on health care, we spend about 55 cents on social services. And those are the things that really address the context in which people live and work, what we considering the social determinants of health. So it's not the amount of money that we're spending, and actually, as the more money we spend on medical care, if you look at the United States compared to other countries, it's bad for our health. Actually, spending money on medical care is bad for our health if you look at the health care compared to other places. And so, I say this all because it comes down to the narrative that we have in our society about what creates health. The general thought is that if people would be healthy, if they worked hard, made good choices about diet, physical activity, and substance use, and had good medical care. In other words, health is an individual responsibility until they get sick, and then it's the responsibility of the healthcare system. That's the general narrative that people live by, and where we put a lot of our dollars and our resources. And I took Michael Warren's slide and I added the tire log one in the middle because that's the one I actually use, because I use it to make my point better than some of the others. But the general point is the same, that it's really clinical care is 10 to 20%. The social factors, the environmental factors, the behavioral factors are really much greater in terms of its impact on health. And actually the health behaviors, as in most places, are actually influenced by the social conditions in which people live. So we always talk about making healthy choice an easy choice, but really for many people the healthy choice is not a possible choice. So we have to make the healthy choice a possible choice. So I think health behaviors are overrepresented in terms of the determinants of health, because I think they're really influenced by the social and economic factors. So to really advance health equity and reduce disparities and improve the health overall, we need to change how we do our work. And using this definition of public health from the Institute of Medicine, public health is what we do as a society to collectively assure the conditions in which people can be healthy. It's really about focusing on the living conditions. The narrative is about people's behavior and it's about medical care, but really the narrative needs to be about the conditions in which people live. And we know that living conditions impact health. This is a slide that shows, distressed communities throughout the country, and that people in distressed areas die 5 years earlier than people in more prosperous regions, and mortality rates for mental health conditions are higher in distressed areas. But it's not just distressed areas. Even the non-distressed areas have huge disparities. From where I live up in Minnesota, and as I work with the Big Ten schools, some of the greatest disparities in the country related to infant mortality are in, Region 5, which is not one of those distressed areas generally. So disparities and distress it's a national issue. It's not a local issue. And so we know, all of us know, that living conditions really impact health. The problem is we have not been trained to figure out how to change those living conditions. And certain communities don't have the power to change those conditions, and those of us in public health have not been taught the skills to change living conditions. So we need to develop the capacity to act. We need to develop the power to actually change the living conditions. And this is where the narrative comes in. And so when we realized in Minnesota, where I was working on this, and also through ASTO, we need to change the capacity to act. We need to find ways to change living conditions. So we decided that with a theory of change that we had was that we wanted to organize. We wanted to use a sort of a community organizing strategy to organize the narrative, which is align the narrative to build the public understanding and the public will, organize the resources, basically shift resources and invest them in a proper way to create change, and then organize the people so they can impact decision makers and develop relationships and align interests. Those were the three principles of our theory of change, and we put that together in what we call the triple aim of health equity. Implement or expand our understanding about what creates health. That means change the narrative about what creates health. Implement the health and all policies approach with health equity as the goal. This is the whole idea of social determinants and equity are separate things. They're related, but they are separate things. You have to have equity as the goal, health equity as the goal, and a health and all policies approach. And then strengthen the capacity of communities to create their own healthy future. That's basically building democracy, getting the voices of people heard, which we've heard in several of our conversations, getting people at the table with the power to help make change and influence policy, and all built around the whole idea of social cohesion and social justice. And so the question was, when we looked at the narrative, what got us to the point of, what's the narrative that got us to the point where it was all about personal choices in medical care? And I think it comes from this predominant worldview that is basically bootstraps individualism. Pull yourself up by the bootstrap. If you work hard enough, that virtue of work, if you work hard enough. Worldviews are never right or wrong, but that's the dominant worldview. Also, free market solutions. Competition is a good thing to advance, public policy. We're seeing more and more education is for job training. Structural discrimination is a thing of the past. We dealt with that with the Civil Rights Act of '64 and the Voting Rights Act of '65. We rely on science and technology. On the other hand, we have a mistrust of science. Back to all of this vaccine hesitancy. We have this mistrust of science. And then the role of government. The smaller the government, the better. The government is the problem rather than the solution. And so that's the general worldview that has led to a lot of our policies and programs. And that has led to a decreased investment in the commons, the public good. Also decreased investment in the disadvantaged, because if they just worked hard enough, they would succeed. And it has led to competition and polarization. And with that, we have winners and losers. And then it is also that worldview has led to the dominant contemporary narrative that health is an individual responsibility, that competition and consumer choice in healthcare is what we should do, that healthcare should be run like a business, that anyone can choose to be healthy. There are no disparities that are systemic. Medical care will cure me if I get sick. I know what's best for my family, and that health is a private matter, and that government shouldn't play a very little role in health. And again, I think this leads to what we've seen with the individual responsibility, blaming individuals, and then overinvestment in the biomedical model, which has not got us what we want. So I think for us, to expand our understanding of what creates health, we have to have some alternative narratives to work with. I think on the left, that common worldview. I think we also have to have a narrative that talks about interdependence and social cohesion. Certainly the virtue of work, but not just work for pay. Parenting is important work, and we don't support it with paid leave and paid family leave. Volunteering is not good work. We expect people to serve on committees without pay. Volunteering. We need to talk about social responsibility and social justice, and this is one of the things that I'm seeing, particularly with the younger generation coming up, that they're seeing the world in terms of social responsibility and social justice, particularly when we're dealing with things like climate change, which they know, we need to be socially responsible. That education is for enlightenment, not just for job training. That equity is a challenge for the present, particularly historical trauma has to be involved in that. There's a more need for generalists. We need cooperation, collective action, and there's a necessary role for government. Now, I'm certainly biased. I've worked in government all my life at the local and state level, but I do think that there is a necessary role. And so from that, we then would evolve an alternative health narrative, that health is a community responsibility. Health is a right. Well-being is the goal, not economic success. Health equity is a challenge. We need a balanced investment in healthcare and medical care. We need a health and all policies approach, and government protects the public good with the policy system and environmental changes. And so from that narrative frame, from that work that we've been working on with that triple aim of health equity, we really started to look around to see how could we advance that narrative in a way that's understandable. And that's where we came across the work, the WHO framework for advancing health equity. And I think, so I'm putting it here. I'm not going to go through that because I've asked Marilyn Metzler and Joanne Clevens to come and talk about the work that they're doing related to using this World Health Organization framework as a way of expanding our narrative, advancing our narrative, changing our narrative about what creates health. And I like this framework because it shows a place for health care in the context of the broader picture, so that we need good medical care. There's no doubt we need good medical care, and there's a lot of improvements that need to be done with that. And we need to look at some of the socioeconomic and political context in which healthcare exists. So that's the frame that I want to put forward in thinking of narrative. And then I want to now turn it over to Joanne and Marilyn Metzler from CDC. And then we can come back and have a conversation about what I presented and what they presented as we look forward to our next iteration of our conversation. So, Marilyn, are you there?
Yes, I'm here. Thank you.
All right. So could you introduce yourself? And Joanne, I know your bios are in the booklet that we've got, but could you introduce yourself just so everybody knows who you are?
Sure. Joanne, do you want to go first?
I think I'm muted. Do you hear me?
Yep, we can hear
yes,
you.
We can hear you.
Oh, wonderful. Hi, everybody. This is Joanne Clevens. I'm an epidemiologist in the Division of Violence Prevention, and I work mostly on child maltreatment prevention, evaluating interventions that prevent child maltreatment from happening in the first place.
And I'm Marilyn Metzler, and I'm also in the Division of Violence Prevention at CDC. I'm a long-term contractor, but I've been with CDC for 20 years and always working on social determinants and health equity from the beginning, and for the last 10 years in the Division of Violence Prevention. So thank you, everyone, for inviting us to come and talk with you about our work to prevent violence, and specifically we're going to focus on child abuse and neglect, but everything that we're going to talk about today we certainly are applying to other topical areas in the division, including youth violence and sexual assault and intimate partner violence. Let's see, do I have control of the slides here? Let me find out. And I do. Okay, great, thank you. So we're going to, and Ed has already alluded to this, we're going to talk about the WHO framework. It's been an important tool for us over the last 8 or 9 years in the division, and I'll talk about sort of the origins of that and some of the work that we're now doing. And then also, Joanne's going to pick up on, after I introduce the framework and some of the ways we're using it, I'm going to pass the baton to Joanne, and she's going to talk about our more recent work around policy change and some of the partnerships that we're developing to do the work that we're now doing, and then sort of bring it back to what this might mean for your work to prevent inequities and risk for infant mortality and maternal mortality. Joanne's going to also talk about one strategy that we're using specifically around narrative change. There's lots of strategies. We've used multiple ones over the last few years, but the one that we're going to share specifically today is, I guess, what we would refer to as strategic messaging, and lots of examples around that and how we're using it. But I think you'll see that the way we're doing our work is also a very intentional narrative changing strategy. And I also want to mention that we've connected this work over the years with the work with the COIN initiative. I think you were going to be talking about it earlier on the call, both through my participation in one of the work groups and webinars that we did, and also the development of some of the resources that occurred with one of the COIN groups in particular. So you've seen this slide before, and it's an important one for us when we talk about our work to achieve health equity, because we really are focused on the conditions, and it's not that behavior change and clinical interventions aren't important. They are. We're all medical professionals in our roots, many of us. But also, if we address the conditions, we will also likely improve the effectiveness of our behavioral and clinical interventions. When people's basic needs are met, then I think we can expect to see better outcomes from other types of interventions. And I just realized I neglected to say what my role is in the Division of Violence Prevention. I actually sit in the Office of the Director. I'm our Senior Analyst for Health Equity, and I work with all of the groups in the division, so research teams, surveillance, practice, policy, and communication teams. And you may or may not be familiar, but these are a few seminal resources for guiding our work in health equity. The two rightmost resources come out of the WHO Commission on Social Determinants of Health that was convened from 2005 to 2008, and even though that was more than a decade ago now, these are very much still relevant documents, and we use them regularly to inform our work. And the first resource that you see, the basically blue one, is the National Academy of Science, Engineering, and Medicine, which came out in 2016 with this guidance for educating all health professionals on the social determinants of health, the importance of doing that, a framework for doing it. But within this document, the academies also endorsed the WHO framework. So it's incorporated within the approach that they are supporting in this work. And we've more recently also been leaning into using the Academy's document in addition to the WHO documents. So there's the framework, and it is admittedly complex. I think a lot of people have shied away from it because of this complexity. If you read the original white paper on it, it can be, I think, compelling. If you are interested in theoretical frameworks and conceptual frameworks, at its best, it's a systems approach to understanding inequities and how they get created and recreated over time. We primarily use it as a logic model, and you'll see that today. So in trying to make it more accessible, we just unpack it and then we apply it. So in this framework, begins on the furthermost right-hand side, which is the outcomes box. And in public health, that's where we begin our work. We look at the data and we best case scenario, disaggregate it, and then look at where the gaps are and whether or not those gaps are inequitable. And where inequities are found to be, then in this framework you would look next at the most proximal conditions, or what the framework would call the intermediary determinants of health, to see what might be contributing to the gaps that the outcome gaps that you're seeing. So living and working conditions, behavior and biology, psychosocial. As Ed noted, the healthcare system is in there. And once you make a determination that there are what these intermediary determinants are, either creating risk or protection, then for the outcomes of interest, then next taking a step back to see, well, then what groups have access to the conditions for health, or what groups don't have access and therefore have greater risk. And this is really the socioeconomic position that looks at hierarchies of advantage and disadvantage by groupings. Could be social class, race, ethnicity, gender, certainly by other groups. And that generally in the U.S. and I think elsewhere, we understand these hierarchies to be created through access to education, which can confer access to occupation and income. And once you examine where these groups array on these hierarchies of advantage and disadvantage, the framework would then suggest taking a step back to see what are the contexts, the policy contexts, and the cultural contexts that are contributing to the hierarchies of advantage and disadvantage. And those two domains are generally summed up as the structural determinants of health inequities. So that is sort of the flow of how this works as a logic model. One thing to note is that from the socioeconomic position box back to the sociopolitical and economic context box, you'll see an arrow back. And in the theoretical framing of this, it suggests that the groups that have more advantages are more likely to be determining what these policies are. So there's a flow between those two boxes. But this framework also has one other important domain. It's a cross-cutting box, which is about the types of capacity that currently exist and that would need to be developed in order to get a different set of outcomes across this framework. And in the WHO white paper on this, it really they speak directly to what Ed alluded to when he spoke, that you really want to be engaged with people who are experiencing the greatest inequities so that they can be involved in helping to create the conditions for their own health and healthy futures. And that is, in my experience, uniquely different than other logic models or framings like the socio-ecological model or others that we've used over time in public health, in that there's an implied theory of change around really what we need to be doing collectively to get a different set of outcomes. And I don't know if I should stop there if anyone has any questions or needs clarification. Okay, sounds like we're good.
Yeah, I don't hear anybody, so go ahead.
Okay, so there are some limitations to this framework. I'm going to say something about that, and then about the advantages. And the limitations are that there, in the original there were some mixed constructs. There are some groups omitted. It does not account for life course. I think I saw something in the chat box around life course. The importance of acknowledging it, and also historical influences, historical trauma. But you can also use this framework to develop new types of hypotheses and explanatory pathways. You can identify where you're working and where other groups are working, and based on that, you can set reasonable expectations for your outcomes, and we'll show you an example of that from our own work. And then based on that, you can build on your existing approaches with new evidence, new narratives, and importantly, new partners. So we, as I mentioned, will apply the framework so you can get an idea of how we've used it in practice. And in the Division of Violence Prevention, one of the areas that we work in is, we mentioned child abuse and neglect, but that work is part of a big umbrella of work around adverse childhood experiences. I'm guessing most people involved in this discussion are familiar with the ACEs study, where there are these. Is there anyone who isn't familiar with the ACEs study? The 20-year history with Kaiser and CDC partnership around asking adults about their experiences of early trauma along these different conditions, and then the implications of that across the life course. And that work is housed in the division. It's now a center priority. All the divisions in the National Center for Injury Prevention and Control are now incorporating early adversity into their work. And we know that there are at least 50 health outcomes that are now associated with a history of early adversity that has been repeatedly shown to have a gradient effect. So the more early adversity you have, the greater the risk of experiencing not only health outcomes, but also life opportunity impacts. So we now have research showing that once you've experienced 3 or more ACEs in early childhood, you're at greater risk of not completing high school, of being unemployed, and also living in household poverty as an adult, which then has lots of implications for the children who are growing up in households with adults who have had that experience. So increasingly, we are leaning into a 2-generation approach around understanding early adversity and our work to prevent it. And here you just see sort of an array of the outcomes of early adversity, from disease, health risk behaviors, life opportunities, maternal child health, mental health problems, and injury. So we do, for illustrative purposes, we use our child abuse and neglect data because we have the best data. We're working on improving the amount and the quality of ACEs data that we have access to, but we do, for today, we'll use child abuse and neglect data. So as an example, the overall rate of child abuse and neglect is about 17 per 1,000 children are at risk of abuse and neglect, but not all children have the same risk. And we know that by race ethnicity, African American children, for example, have twice the risk about as white children. But by SES, children who are poor have about 5 times the risk of experiencing abuse and neglect as children who are living in not poor households. And the not low SES, those are composite measures, so it's not exactly poverty, but it's reflective of that. So when we first started doing this work, we actually developed this as a chapter we wrote for maybe one of the first primary prevention of child abuse and neglect textbooks, and we used the WHO framework to frame a chapter on the social determinants of health. And we did it as a conceptual frame. And we asked, are these outcomes, is this something about African American parents and parents living with low incomes, or is this something about the conditions in which African American parents and parents with low incomes are trying to raise their children? And in the chapter, we just plugged in the data into the outcomes box and then looked in the next step in the more immediate proximal risk factors. We didn't look at behavior and biology. We had a lot of information about that. We looked more at the living conditions of families, and not surprisingly, saw that poverty, low family income, parental unemployment, residential instability, and high poverty, high violence neighborhoods contributed to inequities and risk for child abuse and neglect. And then we next using this conceptual framework, asked, well, which groups are at risk of living in these conditions, and used governmental data and reports to look at educational outcomes and saw inequities in educational outcomes by race and ethnicity as well as SES, and then the same with occupation, both risk for employment or unemployment, but also the type of job, service sector versus professional, and also income and wealth then, and how these, hierarchies of advantage and disadvantage sort of arrayed in this box that would place some groups at greater risk than others of these conditions that increased risk for abuse and neglect. And then to take a step back into the political and economic context, we looked at high-quality, reputable reports from some governmental, some from other arenas on what were some of the types of policies or contexts that were contributing to or could be contributing to these hierarchies. And we looked at, for example, differential education funding, such that neighborhoods and school districts that have a greater number of poor or students of color, concentrations of students of color, get on average between $1,200 and $1,500 less per student per year within those jurisdictions. Differential mortgage lending, there's evidence that even not the recession withstanding, which is about when we wrote this chapter, but on any given day in America, African Americans are more likely to get a higher interest mortgage rate than whites, even when they're within the same income groups. And hiring practices, there's multiple studies now that show that employers in the U.S. are more likely to hire a white male with a felony record than an African American male with no felony record, with everything else being comparable on their resumes. And within the justice system, we know that there's a much greater risk of African American males, even though they use illegal drugs at about the same rates that white males use. Some studies suggest maybe even less. Sorry, I just had to re-enter my password here. They're more likely to be arrested, convicted, and go to jail or prison longer than white males for the same types of charges. So, and we looked at multiple other studies, whether it was access to transportation, food, housing security of other types, and saw, similar patterns that helped us to then look at, why African Americans and families living with low incomes might be at greater risk for child abuse and neglect. After we did this, we stopped and did an assessment of our own portfolio work in the Division of Violence Prevention. This was about in 2012. And the small print on this, not important. It was important work. Everything you see here is important work, but it was mostly in the behavior and biological risk factor domain and in the health services, developing ICD-9 codes for abusive head trauma, parenting programs that were shown to be effective, developing those, developing interventions with therapists who were working with families at risk. That was all really important work, but what we showed is that we didn't have much going on across the rest of the framework, and given that, if we were only working primarily in the intermediary determinants, could we really expect to see closing of the gaps and the inequities in risk? And you can see the key is a little skewed down there, but this was across our, our surveillance work, our research, and our practice work. And in the practice, the cross-cutting box, we didn't have a lot at the time. I am going to now pass to Joanne, even though I'm, Joanne, just let me know when you would like your slides advanced. And Joanne's going to, as I mentioned, talk, where some of that work has gone in the last 6-7 years, as well as very specifically around narrative.
Thank you, Marilyn. So let's go to the next slide, please. Over a decade ago, we decided to stop trying to raise awareness around preventing child abuse and neglect because we learned from some research that every time we said we needed to prevent child abuse and neglect, we were making people think automatically of, oh no, it's not my problem, it's about those people, we just have to report and fix them. And the research also showed that it would be more effective if we talked about child development instead of child abuse and neglect. So we changed our message and came up with this one about assuring safe, stable, nurturing relationships and environments for all children. Including environments allowed us to think about the conditions as well as the relationships. And this really resonated in the division, and it became our vision and our strategic direction. In 2012, we wrote a document that we called the framework, and I don't want you to confuse it with the WHO framework, but this one was the Essentials for Childhood framework, to suggest ways that cities and communities and states could assure safe, stable, nurturing relationships and environments for all children. And then in 2013, we funded 5 state health departments to implement the Essentials for Childhood framework. If we could go to the next one, please. As part of the evaluation of that Essentials for Childhood effort, we identified indicators for each one of the boxes here in the WHO framework that we have been tracking since 2013 for the 50 states to be able to show that if we see any kind of movement in that first box, do we see movement in the intermediary determinants, and then do we see a reduction in the inequities in child abuse and neglect? But one of the questions that we had from the beginning, in 2012 anyway, was what to put in that first box. So the next slide, please. We did a policy scan by interviewing policy experts, and we asked them specifically the question about what policy should we be looking at to address the social determinants of child maltreatment. And we define that as the conditions that children are born into, they grow and play and learn. And they came up with over 50 different policies that we kind of organized in these 7 policy buckets. So it was reduce poverty, deconcentrate poverty, increase residential stability, increase access and continuity to affordable, high-quality child care, access and continuity to high-quality pre-K, and facilitating children's access to health care and parents' access to health care, including mental health care. Could we go to the next one, please? We then searched the literature to see if we could identify empirical evidence for some of these policies. And in that literature review, we came across several articles that also looked at impacts of these policies on, for example, infant mortality and risk factors for infant mortality. So, for example, a $1 increase in the minimum wage is associated with a 2% decrease in teen births and preterm births and in low birth weight, and a 4% decrease in infant mortality. The Earned Income Tax Credit also has several studies showing impact on risk factors and for infant mortality and directly on infant mortality. So again, it reduces teen births, low birth weight, preterm births, and infant mortality. And an increase of 10 weeks in paid family leave is associated with a 10% decrease in infant mortality. So many of these policies that we found that had impacts on child maltreatment also have impacts on infant mortality. Could we go to the next slide, please? Some of the policies at the time, we didn't have evidence of their impact on child maltreatment, but we also considered important that it had impacts on risk factors for child maltreatment. So these are some of those policies. Again, tax credits, housing vouchers, and several family-friendly work policies. The next one, please. And And because of that literature search and some work that we did internally to build the evidence for these policies, we were able to include several of these policies in what CDC calls our technical package. And technical packages are just a set of strategies that are based on the best available evidence. And policies, the policy section is the first section in our technical package. And it includes several policies to reduce poverty and policies to increase family-friendly work. Could we go to the next one, please? In the technical package, then, we have, as I mentioned, several policies around macroeconomics and social policies and public policies, but we also included in the technical package programs that modify behavior or improve the health system. And then we have something in that cross-cutting box. So could we go to the next slide, please? We're talking in the technical package about public engagement and education campaigns, but it's really about changing the narrative. So could we go to the next one? In changing the narrative around adverse childhood experiences, we engaged with a consultant that helped us do some strategic messaging. So could we go to the next one? We defined narrative as the stories we tell about why problems occur and who's responsible for solving them. And as I mentioned at the beginning, the dominant narrative around child abuse and neglect is it's about those parents. Just report and fix them. There's also a dominant narrative around ACEs, the folks that do ACEs kind of work. They keep on telling us to say, instead of what's wrong with you, say what happened to you, and that we be trauma-informed. In both of these cases, these are reactive narratives. There's nothing about prevention here. And so we have a lot of work to do to change the narrative, change the way people think about the problem and the things that we could do to prevent the problem. Next one, please. So what we've learned is that science recommends that we start with shared values. If you've had a chance to read Dan Kahneman's book on thinking fast and slow, you'll know that the majority of us react with our fast-thinking brain, and it's more of like a gut reaction, and then it really takes some effort to engage our slow-thinking brain, our rational thinking brain. So that's why language really matters, because we react with that fast-thinking brain. And so some of the values that were suggested to us are prosperity, connectedness, and ingenuity. So the message that was crafted was, our nation's future depends on how well we foster the healthy development of our youngest generation. Assuring safe, stable, nurturing relationships and environments is essential for our state's future prosperity. Could we go to the next one, please? So after engaging in that shared value, we go and tell the story of the problem. And we try to connect the dots between the causes and the outcome. So the message that was crafted for us was, we now know that early experiences literally build the architecture of the developing brain, and that safe, stable, nurturing relationships and environments are key to building a solid foundation for future growth. We also know that not all children have access to the kinds of experiences that will most benefit their development. Some children experience adversity that's so severe and persistent it produces toxic levels of stress that harm the brain's developing architecture. The next slide, please. Next, we explain how we, as a collective, not as individuals, as a collective, as a society, can solve the problem. So, for example, we can prevent toxic stress by providing the kinds of experiences and you can just plug in whatever issue, whatever solution you're working on, early care or early education or work settings, that will both help parents and provide sturdy foundations for children's development. And sometimes the next bullet doesn't really resonate with people. There are a lot of people that don't believe in the research, but sometimes it does help. So you can say the research shows, and then again, the solution that you're working on can prevent or alleviate the conditions known to produce toxic stress. And then the next slide, please. And then finally, we've been told that we need to have an ask. We need to explain to our audience what they can do to be part of the solution. As government, we don't really we can't really ask the public to do very much, but we can ask them to visit our website. We can ask them to share this information. We can ask them to educate their leaders on what works in prevention. Next slide, please. So here's another example, and this one is focused on the Earned Income Tax Credit. So we start with our values. The future of our nation depends on ensuring that the pathways to opportunity are open and accessible for everyone. When we allow any community to struggle, that derails progress for all of us. So here we're evoking the values of opportunities and connectedness. And now the story. Right now, many communities face barriers to the resources that strengthen opportunities, such as good-paying jobs, affordable housing, and quality child care. When we don't address the needs of our communities, we can perpetuate hardship instead of strengthening opportunity. And then the solution. The Earned Income Tax Credit helps low-income families increase their income while supporting work. And you'll notice that I haven't even mentioned toxic stress or adverse childhood experience or anything here, because that's not the way we're going to engage the public. Could we go to the next example, please? This example is on livable wages. So the value is, in our nation, we have a long tradition of working together to solve tough problems. And if we hope to have a prosperous future, we need to apply innovative thinking to current challenges in the well-being of our workforce. So here, we're invoking the value of prosperity as well as ingenuity. And the causal story says, right now, many jobs don't pay enough for workers to afford basic needs. Cost of groceries, housing, other basics have gone up, but wages haven't. And that hurts working people and slows down the economy. So the solution is a livable wage helps not just individuals and families, but also our communities and economy. When people have more money to spend, it'll boost Main Street and help our communities thrive. And this message has been tested in a randomized controlled trial, and it shows that it persuades folks on the opposite side of the aisle. So I think that's where I am. Oh, no, one more thing that I want to tell you. We started tracking the policies in that first box for the 5 funded states as well as states that haven't been engaged. And what we saw were changes in several of the policies that strengthen economic supports for families. So, for example, several states increased their minimum wage. California eliminated the family cap on TANF and increased funding for affordable housing. And at least 2 states passed an Earned Income Tax Credit. They also improved their early quality child care and education. So California increased the percent of children enrolled. Colorado did as well. North Carolina increased the child care subsidies and number of pre-K slots. And Washington increased the percent of children enrolled in pre-K and implemented a full-day kindergarten program. One of the important things about this is that when we compare to the states that haven't been engaged at all in anything to do with ACEs or building resilient communities or mobilizing action for resilience or any kinds of those efforts, the funded states in Essentials had 27 times more policies that were consistent with our technical package compared to the not engaged states. Next slide, please. Okay, back to you.
Okay. So I'll just say a couple things and we'll wrap up and open it up for discussion. Where's our work now? So we have developed technical packages. You see a graphic of them there for all of our outcomes that we work on in the division, sexual violence, youth violence, intimate partner violence, suicide. All of them follow basically the same format. They begin with policy approaches in the front of the document and then also include comprehensive strategies across clinical interventions and behavioral interventions. And again, they're based on the available evidence at the time that they were developed. We're also doing a lot more policy analysis work in the division. Joanne's leading teams of early and mid-career researchers and others on looking at different policy and policies and their relationship to our outcomes of interest. And we're also working on new narratives and different types of trainings around narratives. So one that we're working on actively right now is around youth violence. And what are the stories we tell about youth who are at risk of being involved in, violent behavior in their neighborhoods, and what is the story that we want to lift up instead. And this is also informing our funding announcements. We've had 3 recent funding initiatives that really are reflecting this work. So the new round of Essentials for Childhood, we're now funding 7 states after the first 5 years with 5 states. And one of their aims in this funding announcement is economic supports for families. So in the first 5 years, we saw that they moved in that direction, but now they're actually, it's part of the funding announcement. And the same thing with intimate partner violence. One of the strategies that they are asked to work on is economic support for families at risk for intimate partner violence. We've also recently funded 3 communities to work on the primary prevention of ACEs, so all the early adversity work, policy work, narrative change, and its relationship to opioid use and misuse. And then we continue to find new ways to use the WHO framework. We're also currently involved in doing an updated assessment of that slide from 2012 to show how the work has changed, you know, a visual showing of how the work has changed. We're working much more now across the framework, but the bulk of the work is more looking at the policies and structural determinants at this point. And it's also really informed the way we work together in the Division of Violence Prevention. And just to show you, this is a fairly well known in the ACEs world, the pyramid of, you know, early adversity at the bottom, disrupted neurodevelopment, and all the sequelae that can happen from there. But this adapted version was just released, I think, a week or so ago, where precursors to early adversity are the social conditions, the local context, and also historical trauma and generational embodiment of that trauma. And when this was released on the CDC Instagram account, within the first couple of days, there were more than 8,000 shares of it. So it definitely resonated. And what we're learning is it really does help to have a conceptual framework. It has helped us to organize, and the work that we're doing, it's helped us to really take a good look at if where we're working a match for what is driving the problem. And that it is really important to be explicit about what we mean when we are talking about bringing an equity lens. It definitely matters to be changing the narrative, because without changing the story, it's hard to get support for the types of changes that you're hoping to see. And that you can use the best available evidence to learn while doing. So we are working with the evidence we have and continuously building the evidence base. Probably one of the greatest benefits, in addition to changing the outcomes, is the energy that it really brings to staff who work on this. And again, especially the early and mid-career staff. And we just also believe this is the right thing to be doing for children and families and communities. And that, now we can open it up for discussion and questions. And again, thank you for having us.
Well, Marilyn and Joanne, thank you very much. Appreciated that. I do have, just in my use of at MDH as a state health official, when we started doing narrative work, it actually, by just raising the question about what narrative is your policy proposal taking, or what narrative is advancing, or what is your program doing in terms of looking at the narrative, it actually changed the work of the people in the agency. It put it into a broader, and it started moving things more upstream. They started to recognize what that one slide pointed out, is that we do all of our work in this whole area of individual care and working on individual conditions and the context, but we do very little work moving upstream. And we've recognized, given the data, that has not changed the needle very much. And so by just asking the question of what narrative is your message conveying, it changed people's behavior. So I find it very powerful. So that's why I wanted Marilyn and Joanne to outline this for us. It seems complex, but it is very helpful once you get an understanding and put it into practice, as they pointed out. So are there any questions or comments or feedback? Vijaya. Vijaya, are you there? you unmuted? And I know Vijaya was an author of an article, co-author in an article that's being used as a basis for some of this work, I think, which is in our booklet here.
Can you hear me now?
Pardon?
Shows she's
Can you hear
talking.
me?
All right.
Like it's on the.
Yeah, Vijaya, you need to unmute yourself somehow.
Okay, can you hear me now?
I'm not, this is Marilyn, and maybe she's having a little difficulty. I was instructed to hit *6 to mute myself when I first called in, but I didn't have the directions on how to unmute myself if I had done *6. So I don't know if that might be.
Yeah.
Okay, she would press *6 all to mute and to unmute, but honestly, I do not see her dialed in, so she just may be on the web.
Yeah, well, showing her microphone on the computer, so it may be that it's muted on her computer. Yeah, it's, okay, she just muted. So yeah, so Vijaya, you just muted your microphone, so if you try to undo what you just did, hopefully that will work. It's showing as that she muted herself. There we go.
All right, try it now, Vijaya.
Can you hear me now? Hello?
Maybe that her microphone isn't on.
Yeah. All right, while we're working on that, any other comments?
This is a little frustrating.
I will, sorry.
Jay, is that you?
No, can you hear me now?
Somebody tried.
Can you hear me now?
Sound like a male voice. Paul, one of the Pauls?
Yeah, I was just going to say, I think that updated slide is brilliant. This is a really the clearest portrayal I've seen of all the way from historical trauma through early death. So congratulations, that is an amazing slide. I'm going to steal that from you.
Yeah, I like seeing that. We put together, sort of a tree that had a roots and the trunk was the ACEs, and then the diseases of disconnection and despair were at the leaf area, but it was adverse societal conditions were the roots. And it's basically that generational embodiment of historical trauma and the social conditions. I think that's one of the opportunities we have with this committee is that people are starting to understand more of those first two blocks on this slide.
Information slowly and clearly. With spelling, please state your name.
I was also, Paul, again, happy to see that it did look at social conditions and local context. I remember one friend who's an American Indian who grew up on the reservation just talked about the death that was around her almost constantly. And whether it was neighbors or relatives or friends, and that occurred in the social context outside of the home she grew up in.
With spelling,
and I think this acknowledges that environmental trauma also.
Good. Any other comments? You see any use for this in our committee? Would this be helpful in terms of any kind of framing?
This is Belinda. I would agree. I think it would be very helpful. I especially like, the whole conversation around changing the narrative, but also about being explicit about what we mean when we say equity. When we say we're doing it with an equity lens, what do we mean by that to make sure we're all on the same page?
And we'll talk about that in the next little section when we talk about our equity frame.
City and state, followed by the pound sign. Thank you.
We haven't been able to get Vijaya back on, huh?
They can hear her, but somehow we can't.
Hear me now?
Hold on.
Hello?
Hello.
Who is that?
This is Vijaya. Can you hear me?
Vijaya, can you hear me?
Very good. All right, Vijaya, we've been waiting for you.
Sorry.
I'm not sure why the
I'm not sure why the computer doesn't work, and I had trouble getting it on the phone. So I'm going to talk fast, so I don't take up all the time trying to get on. I just wanted to thank Marilyn and Joanne for really compelling presentation, and I agree with Paul. I really like that last slide with the addition of the generational embodiment historical trauma piece, because I think that's really critical to get at generation of disparity. The WHO framework I really like, and I was really excited when it came out several years ago, because I thought it was one of the most comprehensive frameworks out there. Excuse me. But I don't see it as an equity framework. I see it as one dimension of an equity framework, and that you still need these other dimensions of things to add to it to really get at equity. There are a couple of reasons why I say that. One, because if you look at something like socioeconomic position, improving that alone is not going to confer immunity from inequities. So if you look, for example, at birth outcomes, the gap is wider for well-educated and presumably higher income Black versus white women than it is for lower income Black versus white women. There's still something else above and beyond that particular social determinant. On the other side, when we think about addressing social determinants, one of the things that we tend to do, and I say this from experience with the Build Health initiative that Kellogg was one of the multi-funder sponsors of, and Build was designed to develop these place-based, upstream-focused interventions on social determinants in order to achieve better health and health equity. The way people conceptualize addressing social determinants was mostly temporary fixes. So they did things to support women's access to primary care, so they'd address the social conditions that facilitated their ability to get into care. And maybe they were really kind of progressive, they would facilitate access to some of the recommendations that they got in care. So they facilitate access to food or maybe to child care, something like that. But this only lasted during the course of the pregnancy, and then after it disappeared, and women would find themselves right back in the conditions that they started in. It was kind of like smoking cessation. So you could provide education and support to stop smoking for one person, and then the next person, and then the next person, or you could actually change the environmental conditions that help the whole population stop smoking. And as public health, I think we've leaned more towards the individual approach, even when we're trying to address social determinants. So I think we have to be careful how we translate this model to get to the outcomes that we're trying to get, because there's not a direct line from one to the other. I think there's some other information that people need to have to get to that point. One other example that I could use is from a study that my colleagues and I did in Brazil, where they have a national health service. But if you juxtapose that onto the life context of domestic workers who are sort of the lowest of the low in terms of the working group, in terms of how much they're oppressed in the workplace, how little benefits they have, how little pay they have, etc.
that National Health Service doesn't help them because because of their context, they don't have the ability to access it in the way that it's structured. So, and domestic work, just as an aside, is one of the avenues for Black women to have paid work. Most of the domestic workers in the country are women of African descent. So it's not just about the policy. So evidence-based policy is one piece of the puzzle. The other piece is how those policies are implemented in the context, juxtaposed with the context that generational embodiment and historical trauma presents. Because if you harken back to that equity equality diagram, everybody, white women, Black women, Native American women, Latino women, they're all going to exist in that social condition, local context, part of this triangle that you're showing here. But the bottom of that pyramid is going to differ for all of those groups, and for some of those groups, it's a very unique context, and that has to be factored into the approaches that we choose to implement, how we choose to implement the policy. Defining those policies is important, but defining how to implement those policies so that it addresses that bottom of the pyramid is also equally important. And I think we can't forget that, or we're going to end up 6 years from now still looking back and not seeing the progress that we hope to see. I'm done.
Thank you. Marilyn, or Joanne, any comments related to that?
This is Marilyn, and I definitely appreciate what you're saying, Vijaya, and I, this model was primarily developed from maybe a more European lens, where class and socioeconomic status is 10 years ago was more the lens through which the world was viewed. I think we know now that that has changed. And in our own work, as we've do more policy analyses and all of that, really understanding the differential impact of policies. And I agree with you, it's not just the policy, it's definitely the context, the cultural, historical influences, ongoing trauma, how to, when we are looking towards policy solutions, how to understand sort of the differential effect of those policies on different groups. That's really important work, and I think it's the next generation of this for us. We currently have internally a racism and violence work group that is helping us to think through some of this, but I definitely appreciate your thoughts. So thank you for that. Joanna, I don't know if you have anything else to add.
No, not really. I appreciate the fact that we haven't really thought about what we would do to address historical trauma, and that's just work that needs to be in our future. Yeah.
Mm-hmm. Yeah, and I hope you take it in the spirit of appreciation, because I wasn't wanting to be critical of the work that you're doing or the way you're conceptualizing it, because I think it's very advanced from where we've been in the past, and I really appreciate that. But I still think we need to push the envelope a little bit further.
Ms. Marilyn, I definitely do not take it as criticism. I take it as a charge. So thank you for the charge.
Marilyn, in an earlier iteration of that framework, wasn't racism explicitly stated?
It was, but that was sort of one of the mixed constructs. It was in the socioeconomic box, but it was really a placeholder for race and ethnicity. Racism would play out across the framework. right? You would see it at each of those domains, including in the opportunity to participate in the solutions. And there have been criticisms that the explicit incorporation of racism was not part of the original white paper. Sometimes when we teach this, we incorporate that more and we'll spend more time. But what we've done consistently when we're not doing that is to try to show the differential impact of some of these policies that, again, as we've shown it, contribute to socioeconomic position of groups without telling the fuller story of historical trauma and embodiment. But I think that I'm actually excited about this conversation because I think we have enough experience now with this framework and have, even though it's not our public-facing framework, we've certainly worked with all of our partners and taught the framework and they're using it in their own work. But it's so complex you can't always include it in your documents and all of that. But we've used it so much internally that it really has changed the way we understand risk for violence in our division, the types of work that we can be doing to try to prevent violence. Now I feel like we could build on that and do some of this. I think what will be harder work to really unpack how generational trauma is influencing these inequities in risk.
Janelle, do you have something?
Thank you. Thank you very much, ladies, for the presentation. This is exactly the work that you presented is exactly the information and things that I had wanted to try to communicate to the world when I was doing my dissertation, because I worked with historical trauma framework. And one of the issues that I had with it definitely, and it comes out in your presentation, is that excuse me, it's my baby that's now going to talk. One of the issues I had with this was that this is a very uncomfortable topic to talk about, and that's reflective of this nation's history, and changing norms is really, really challenging. So changing the norm of just talking about adverse childhood experiences and child abuse, the fact that you had to repackage child abuse, change the narrative so that it was more palatable for agencies and the community, the public at large, to just digest and to view it, is really reflective of this, the dominant kind of Western cultural society and modern time that we live in. And possibly something to think about are ways to circle back and kind of look at how transformations can be done where we can become comfortable in talking about abuse, violence, and understanding the situation and context for which that arises. Thank you very much for this presentation.
Thank you.
Janelle, I'm fascinated by your comment because part of they changed the conversation, one, to make it more palatable, but also because the previous approach doesn't seem to be working. So I mean, there's two parts to that. The more palatable actually made it more effective. So that we have to be aware of both of those. The palatable, basically the bottom line is how do we make change in our society? Interesting.
Hi, this is Diane Rosinski from the Office of Minority Health. Can I add something?
Sure.
The notion of reframing the narrative, we find this in our promotion of the elimination of health disparities. When you talk about health disparities, there are segments of the population that just turn off and tune out because they don't want to hear it, they don't think it applies to them, or some other explanation. And in fact, if you do exactly what's been proposed here, which is start out by these shared values, and move forward from that, because then when you do that, then it is a conversation that you are talking about. We are all talking about our children, and I think that is very powerful, because then it really does become something that the listener, the participant, owns as well. And we find that in health disparities strategic messaging as well.
Thank you. Thank you.
And I think we have even accumulating evidence around that. So Joanne didn't mention it, but one of the wins, if you will, in the first generation of the Essentials for Childhood work with the funded states is by sitting at the table together, public health with their child protective services, which aren't always on the same page within states, but they work together through this initiative. The California Department of Child Protective Services now sees addressing poverty as within their mission. Now, I know that's not taking, that's keeping us within the framing of the framework that we presented here around poverty and socioeconomic, but that's a whole different place for a child protective services agency to normally see its work, that's more towards primary prevention. And there's soon to be, you'll hear more about it, but multiple agencies, HHS agencies, are now coming together around this new narrative of let's create the conditions for families and children to thrive, rather than, do the previously explicit, mission of that. I mean, they're still going to work on their missions, but they're starting to see the value of framing it and working across agencies. So there will be more about that coming out. I think even in this month. April is Child Abuse and Neglect Prevention Month.
So Marla, here's a question, for this committee that we just meet virtually once a year and in person once a year, and we do have some work groups figure out, how do we sort of call each other or check each other on the narrative that we're using and change the narrative that we use? How would you see it working in a committee like this?
Ed, this is Magda. Am I heard?
Yes.
Thank you. Well, it's a question I was raising my hand to ask as a baseline. And the baseline question to the Bureau of Maternal Health and to the Health and Belinda with her experience at Healthy Start, and given the origin of this committee was with the establishment of Healthy Start, I'm wondering, in the most recent round, how did the guidance and how did the Bureau reflect this particular framework? What was the narrative that's currently being used to solicit the Healthy Start applications? What are the narratives that came out of the applications themselves, especially those that are funded? Folks know that I was in Milwaukee for 5 years, and Milwaukee has had a Healthy Start grant. Returning to the city after a hiatus, I'm just curious if we can, instead of thinking about only where are we going with that, if there's any way to cross-check this updated frame and narrative with what is the current way of doing business with the Bureau or in CDC, and what is the narrative and how are communities using these frames to respond. And even with the block grant needs assessments that will be coming out, I'm trying to use that strategic pragmatism right now to ask, what's the current practice and how is this maturation of what we've been trying to work on in equity, how is this being incorporated either from the field to us or from the guidance out to communities? Anybody know what the baseline? Just looking to see what's the current reality of connecting this conceptual framework to current investment in infant mortality, specifically Healthy Start.
This is David. I don't know if you want me to chime in a little bit. This is Belinda.
Yeah, please do.
I would say I think the challenge with Healthy Start is a couple of things. I think the narrative, the guidance, actually, the focus is still on perinatal disparities or improving equity, but I think the language is perinatal disparities. I think the challenge is that each site is required to serve so many individuals, and when you're having to serve that many individuals, I think most of the work that is provided is focused on the case management arm of it. I think with case management, there's opportunities to look at issues around transportation, try to connect families to housing, and things of that nature. I'm not sure if it still gives you as much, I shouldn't say leeway, but I don't think there's a stronger focus as improving the system as it is in helping the families navigate the system. And this is Belinda, and I'm a former Healthy Start project director. We have a Healthy Start site, and I'm not engaged in it day to day. I think there's some opportunities through the community action networks, to the local CAN groups, that they can look at systems. But anytime, I think it's still some of the challenges is around the funding level as to how much you can do to serve so many people. That's one person's perspective, and David will definitely have a broader perspective than I would implementing it in one state.
Right.
Interesting. Well, this is sort of behind one of the questions that I asked Michael Warren earlier on. Has anybody evaluated Title V pre and post block grant? Because when I got into Title V working on maternity and infant care projects, we had a target area, not target population, so that everybody, it's sort of like the Best Baby Zone kind of thing, where you actually worked with everybody in that community about going upstream and changing the condition. Yes, you did provide some services, but it was more about changing conditions. And what seems to have happened from after that is that it's got more to the service delivery, certainly providing service in the context of the community, but not changing the community. And I think that's where a lot of the work needs to go if we're going to actually, make improvement in infant mortality or any of these other factors.
Mm-hmm. And to be clear, this is Magda. I'm really asking about going to the generational embodiment and historical trauma. How has that beyond narrative begun across all of the ex officios that are present throughout Health and Human Services? Anybody incorporated this language or this narrative in current work? And if not there, then who? Because I just want to get a baseline that's beyond taking a narrative and a frame, how to actually influence investments and metrics and impact and accountability. Thank you.
All right. Any other comments?
This is Paul Wise.
Yes.
Is this a point where we could discuss some of the material that you presented, particularly in the context of the second presentation, or will we be discussing your presentation subsequently?
No, you can do it here. That sort of my lead into this with the narrative piece that I had. Yeah, this is a place to do it.
Okay, great. Thank you. Just to raise a couple of cautions in how we frame this narrative. I appreciate fully and agree with the framework that was just presented as being discussed. But two cautions. One is I worry a lot in the policy conversation to elevate social causation by diminishing clinical capability. In other words, suggesting that most of our problems in health are social in origin and our medical system really doesn't offer much. I think that is actually counterproductive at a time when we're trying very hard to provide high-quality health care to all those in need. That it actually is heard in ways that diminish arguments for the equitable provision of critical health services. And it's also, I feel, not necessary because we can address the social forces at work here, recognizing that those same social forces can operate in neonatal intensive care units as well as in the lives of young women. The fastest way to increase infant mortality now is to permit social differences in access to neonatal intensive care, the highest high-tech area of modern medicine. But we're seeing that in certain parts of the country because of the deregionalization of neonatal intensive care based on the ability to pay. That if you're poor, you don't get great care. If you have good insurance, you do. You get transferred and you get great NICU care. Because NICU care, as was mentioned earlier, is extremely efficacious in saving lives. It's potentially a catastrophic impact on disparities in infant mortality. So I would just caution us about how we frame the importance of social forces, but not in any way diminish perceptions of efficacy of clinical capability. The second is the use of the pie graphs that attempt to sort of portion out the factors in sort of our health status in the world or health in general, life expectancy or other kinds of indicators. Because, first of all, these things are so interactive. Really carefully at these studies, the way that these things are done, it's fine for certain kinds of conversations, but it's not adequate for the kind of conversation that we're going to want to have. And it's particularly not true in the perinatal world because these relationships are not linear. The availability of high-risk obstetrics for a woman who has a high-risk condition is life or death. It's just 0-1. And these pie graphs that try to suggest that our problem is not really medical care, but it's social forces, I think can have counterproductive effects, and we don't really need to do that. I'm in this business. I've been in it for my whole professional life because of concerns of social justice. But my concern is that by diminishing clinical capability is to diminish claims to social justice, and that we find ways to create a powerful, compelling new narrative that focuses our policies and discourse on social forces, but do it in a way that in no way would diminish the respect for the requirements of equitable access to whatever clinical capability we have. I'll stop there.
Points well taken. I think at least from my perspective, the general sense, given the general belief that medical care is the most important thing in people's minds for creating health, if everybody had health care, had access to good health care, things would be fine. I think it's to make that point, health care is really, really important, and there's a lot of work that needs to be done on it, but it is not the only thing, as you're well aware. And I think our job to change the narrative is at least let people know that there are other factors in addition to good health care that are really important. So I don't want to diminish the importance of good health care, equitably provided and distributed.
Thanks, Ed.
And this is Marilyn, and I think there's a parallel that we often are faced with addressing when we talk about working, on the structural and social conditions, is that sometimes it's interpreted as that we don't have any confidence in behavioral intervention, and that is not the case. That we want, that we're saying that. In fact, we think that you can improve the effectiveness of behavioral intervention if you're also addressing the context of people's lives. So the example we often use is that some parents will do well and may need and benefit from parenting programs. In fact, a lot of us who are around children, because especially now with what we know about the importance of development, but that families will do better in those interventions if they're not also worried about where their next meal is coming from, or their child's next meal, or where they're, sleeping tonight. And I think we could say the same thing for the effectiveness of clinical interventions. If the stressors on people's lives were alleviated, then we could improve the effectiveness of our clinical interventions that are important. So they're not, none of these things are unlinked.
They're all interactive.
And I think, as Paul Jarvis, I think we are unlinked. We often present these pie charts as if, well, there's healthcare over here, we're 10 to 20%, and then there's all the other stuff that's social and structural. When in fact, if we step back from the pie chart, structural and social determinants affect every component of the pie chart, including the clinical. And as you were saying, Paul, depending on where you live, you have access to good health care or you don't. Or that health care may be culturally competent and inviting, or it may not be. You may have access to some procedures and not others because of implicit bias. Likewise, genetics, through epigenetics, is impacted by social and structural determinants. The behavior is determined by the environment you live in and what behaviors are optional. So maybe behind that pie chart is, the social and structural determinants impact the entire thing. And that way we're putting the clinical on the same playing field as everything else. We're saying, yes, we need good clinical care, we need good availability, access, cultural competence, equal treatment within the healthcare system, just as we do in every other system out there.
Any other comments? Well, this has been, anybody else on the line? Yeah. Okay. This has been very helpful, a good framing. I just point out the fact that the very last addition to your briefing book is Emerging Narrative Frames for African American Infant Mortality Project that we did in Minnesota. Just to give you an example of some of the narrative frames, it was a group pulled together with the African American community in Minnesota and really worked at it from a narrative perspective. So you can just sort of see some of the frames that are coming out of that, just as an example. So thank you much. All right. Marilyn and Joanne, thank you. Really appreciate I hope you got something out of it. I certainly did here on this end.
Definitely. And I don't think we really answered your question about how this particular group can move this work forward, but if we can be of any help, we would welcome that, and we would have as much to learn from your efforts. Moving this into your arenas as we're learning from our own, and just to reinforce the point that these are not completely separate efforts, because the conditions of pregnancy that women are living in during their pregnancy and during the time of birth, which I think the Paula Braveman paper that we included, the PRAMS data, shows these are the same conditions that then increase risk for early adversity for the children once they're born. So this is just a continuum, a life course continuum between our two topic areas here. So anything that we could do to support your efforts, we will also benefit from. So thank you for this.
And I'd also like any input you could have from your work with COIN, if what you've learned from the interaction of that infant mortality reduction project at HRSA, would love to hear that at some point in time.
Sure.
All right, group, let's move into our little talk about setting the equity frame for the work of SACIM. It's come up in all of our conversations, and we brought it up at the end of our last meeting, and I drafted shortly after the meeting, sort of a framing that you may or may not have, and I don't think I put it in the booklet, but it just said, I said, the trajectory of infant mortality in the United States for the last century has demonstrated that overall improvements in infant mortality rates have not been equitably shared by all populations within the country. However, it is our belief that a reduction and ultimate elimination of disparities in infant mortality rates would benefit every infant born in this country. Because of that, every project, so this is really sort of the meat of it, because of that, every project, activity, or policy recommendation made by SACIM will be crafted through an equity framework and evaluated by its impact on reducing health disparities among all infants and mothers. I'm thinking about, I did that really briefly afterwards, and I'm thinking about maybe changing that for conversation, sort of because of that, before any project, activity, or policy recommendation is moved forward, the question, quote, what impact will this project, activity, or policy have on equity, end quote, and then the evaluation of any project, activity, or policy will include its impact on reducing health disparity among all infants and mothers. So that was sort of the, given some of the feedback I got that might reframe that. One of the other questions was, what is health equity? And I've been using what CDC has put together. Health equity is achieved when every person has the opportunity to attain his, her, their full potential, health potential, and no one is disadvantaged from achieving this potential because of social or economic position or other socially determined circumstances. And that's the health equity. And I assume equity is the same thing. It's just that equity is achieved when every person has the opportunity to attain his, her, their full potential, and no one is disadvantaged from achieving their potential because, taking the health out of it, because health is part of, health equity is part of overall equity. So I wanted to make sure that we were all sort of on the same page, that we're all agreeing that equity is different terms of use, sort of the North Star or the centering component or the lens or the framework that we do. I don't want us, as I said earlier, don't want us to have a separate equity focus. I want equity to be part of everything we do so that everything we do gets evaluated. We ask the question, what impact will this have on equity? And then we evaluate it with an equity piece of that. So I'm wondering about any thoughts that people have about that sort of frame.
This is Vijaya. Vijaya. Can you hear me?
Yes, I can.
Okay. So I agree. I think it's important to have that as the overarching frame that we look at everything through. But I don't think it's as easy as just saying that we're going to use an equity frame or we're going to look at an equity frame. I think there has to be a method for how you do that. And I think that's a little bit less developed than the sort of theoretical frameworks that lead us to want to address social determinants or to even address equity to begin with. And so we have to put in some thought about how to translate that from a framework to an action. And I think that's where the real hard work is going to be for this committee. And that's where, it's going to create the translation for people in the field to actually take action in a true equity frame. Because, I've worked in philanthropy the last 4 years or so, and I've run into so many people who say, yeah, we use an equity frame. And then when I dig deeper and ask them, well, what exactly does that frame entail? Either they don't know, they can't articulate it, or it's something like, well, we do the same for everybody, but we target populations of color or something to that effect, or, we focus on diversity, small things, small actions that, may be part of the process, but they're not an equity frame per se. So I just think we need to put some careful thought into how that gets operationalized.
I agree, and that might be one of the tasks that we have over the next several months, to get a group together to sort of how do we translate that and put it into action, so with some ways to move things. So that might be a work group that we may want to consider. Other thoughts?
Well, this is Paul here. I still really like this World Health Organization goodness and fairness concept. The idea that, for each thing we do, each initiative, we look at the goodness. How does this impact the overall maternal mortality, infant mortality? And then necessarily, we also ask, and how does this impact the fairness? How does this impact the disparities and work toward creating equity? Because I think both approaches are necessary. There may be innovations that improves everybody's infant mortality, which is very valid. It doesn't unfortunately necessarily change the equity balance, and there'll be other things we can do that will impact specifically the disparities and improve the outcomes for babies of color in this country. But I think both are important, and from my point of view, it's important to look at them side by side and always have both those goals in mind. No, but I really welcome feedback on that.
Yeah, I'm thinking personally about that because I'm trying to think of examples. I know health is not a zero-sum game, so that if you reduce the disparities, even the people at the top get better. I also know that there are some innovations that that may benefit the majority of folks and improve their health, but actually increase disparities. So, like I say, paid leave. So it's goodness for on average, it's good for the entire population because the largest number of people benefit from it, but it increases the disparities. So where's the...
Well, then that doesn't meet the criteria of goodness.
Okay,
you have to look at both side by side, is what I'm saying.
Yeah. All right, so that wouldn't be good because it's not fair.
But you don't throw the baby out with the bathwater. So that's why I was talking about having an evidence base of what works to improve the rates is one thing, but knowing how to implement it in ways that impacts every population, particularly those that experience the most disparities, is the trick. And that's the thing that we haven't yet mastered. And we have to.
Well, and I think in many ways we undermine what we're trying to do, where we'll come out with a, quote, evidence-based model and then insist it's implemented with fidelity across all populations. That doesn't work. People live in different conditions.
Yeah. This is Diane Rosinski from the Office of Minority Health again. And one of the things that we have done, and we have done this with some of our research and demonstration projects, not necessarily around infant mortality, but on other topics. And I like the way that it can work is that there are evidence-based practices that have been found to be effective again, and and to insist that they are implemented with fidelity ignores cultural and linguistic differences within communities. So one of the ways that we try to address that is to ask specifically, what are you going to do? So it's the and. It is, what will you do specifically to modify, to tailor the intervention to your to the community you are trying to serve. So again, when and in general, in campaigns in general, communication and public health campaigns, the rich get richer, and we divert resources to those who have already. So to have the intentionality of what needs to change in terms of taking into account some of the cultural, linguistic, socioeconomic, all again from the social determinants of health. What are those modifications that need to be made in the program, and then to be open about testing some of those ideas, because again, if we keep on doing the same old, we're going to get the same old.
Well, I think it's a challenge to all of us because our very structure leads to that the rich get richer. So, I mean, I think the worst example is communities putting prevention to work. That whole initiative where communities had to be, quote, shovel ready. And therefore, those communities with the resources who could write the best grants got those grants. And other things, wonderful programs, like some of the group prenatal programs, the Nurse-Family Partnership. In that case, those are put in place with an adherence to the fidelity to the model, which, you know, I mean, take some of the group prenatal care models. How do you do those in rural environments? How do you do those on a reservation when there's a lower population? So I think whether it's a funder or a policy leader, we're going to have to be a little bit more tolerant of the ability to allow a program to be implemented in the best possible way in certain communities as opposed to the perfect way that it was developed in an academic environment, including having mechanisms where not only those who can afford the grant writers and modelers get the grants.
Again, this is Diane. I'm sorry, this is Diane Rosinski again. One of the things that SAMHSA has done has for their grant programs is they have essentially a disparities impact statement that for the programs that they are funding, they ask very specifically for the work that you're going to be doing, how is this going to affect disparities within your community or within the community you're serving? And that really does compel the participants in the grant to think very, very clearly about what they're going to do to address disparities and how their program is designed to affect change.
So Diane, is that new for them, or do they have some outcomes they can share from having gone down that road?
I think they've been doing this for a while. Let me communicate back with SAMHSA and try to get some good examples for the group. Ed, this is Magda.
Yes.
I want to hearken back to two things from earlier today. One, in the history presentation, I had significant input from Art James and others that we might want to take into consideration as we frame this lens and commitment about understanding and striving for equity. And one of the underlying tensions that will need to be clear and addressed is it equity or health equity? Is it where does racial equity fit into this? I think that we owe it to ourselves and our work to bring clarity in our striving for equity and try to help navigate the tensions around, particularly around the relationship of health to broader equity, and particularly the unique focus and particularly with historical trauma around racism and racial equity. So I just encourage us to be thinking about that, being clear. And then the second that I want to harken back is what Paul Wise reported out from the small conversation about how to elevate the visibility and effectiveness and stature, I think is the word, of SACIM. And with Paul, what you said was it's baked into the structure that it's been low expectations have been perhaps met. That it's about structure, and structure is a way to be systemic about what outcomes are reached or not. So towards that end, I would wonder about the appetite of this group of SACIM members in this iteration to look at ourselves and our own structure, and this will be a prelude to the conversation with Belinda tomorrow, about how are we doing our work that is not rhetorical but is grounded as we strive for equity in terms of our capacity, our composition, our calling each other in and out, and having the welcome and powerful and voices of others besides ourselves as we figure this out. So 2 comments to build on from before with humility.
Thank you for that.
Hi, this is Colleen. I just wanted to chime in. I lost you, but I'm back. So I agree with what Paul said. I do think you need to have, I think North Star, I'm not super supportive of that terminology. It seems a little bit too, you're going to end up excluding people, which is exactly what you don't want to do, right? So if you have a great emphasis on equity, I think there's going to be some things that help infant mortality in general that you're not going to want to lose if you are solely focused on equity. And so I think you can have some things that would have more of an equity focus, and then there's other things that, because let's be honest, mothers and babies have more in common across different racial lines than not. So there are some things that are going to help infant mortality across the board, and I'd hate to lose out on those just if we were solely focused on only equity. While equity can be a great component of this, and we can definitely champion it, I think North Star is a little bit too, like one goal. And I think the goal still has to be the betterment of infant mortality. And so I think Paul probably said it better than I did, but I do support kind of efforts to improve infant mortality as well as the equitable percentages that we've all learned about regarding infant mortality and maternal health. I don't know if that's it.
Any other questions or comments? Not questions, I guess. Comments. Thoughts?
This is Belinda. I don't think focusing on equity won't help the majority. I mean, I think it helps everyone when you focus on equity. So I do think you have to make a concerted effort when you're going to focus on equity. So I understand what you're saying, Colleen, but I don't think it's hurting the majority to focus on equity.
No, I don't. I focus on equity is fantastic. I don't think that's hurting the majority either, but I don't want it to be to the exclusion of things that would help everyone. So I think that focusing on equity is completely makes sense in light of what we're all talking about, but I just don't want it to be to the exclusion of other potential things like folic acid, for example. I mean, there's certain things that just help everyone, and so I think that that's, prenatal care, like there's certain things that do help everyone. So, if we're talking about bringing everyone to the table, that kind of has to be bringing everyone to the table, right? Like, I think Paul said it better than I did. It's just to have kind of a focus on, like, both things seems appropriate to me, but hold on. It's iPad. Okay, back. But I do see things medically, so it's kind of I have a different approach, and, when you take an anatomy class, you realize we're more similar than not, and when you take a public health course, you're more focused on all the differences amongst us, but I do think that it's definitely important, and I'm glad we're focusing on it and making everyone kind of attempting to get to an even playing field, but there's going to be some interventions that would kind of help everyone, and I don't want to lose out on those either, I guess.
Yeah, this is Wendy. Can you guys hear me?
Yes, we can.
All right, thank you. Sorry, I guess we're going to start every sentence with that. This is Wendy from the Administration for Children and Families. I just want to add a nuance to that, which is, I mean, everything that we're going to bring to the table, I think, is going to be good for everybody. What it's nice to do is sort of add that space to say, okay, we've got this thing that's good for everybody. How can we make it be equally good for everybody, right? So where do we need to present it differently? Where do we need the intervention to vary? Where do we need to refine so that it's equally good for everybody, right? So it's, yes, we're bringing to the table the stuff that's good for everybody, but we're making sure we pause and go, okay, what needs to be added? Or how do we need to phrase this differently or voice it differently, or what pathway might be different to get it to be equally impactful for everybody. So I think it's sort of both points of view in that.
Yeah, this is Vijaya. I agree. I think they're not exclusive of each other. One is, if you will, a higher octave of the other. And another way to think about it is sort of like universal design, where you have things like curb cuts and certain types of doorknobs to accommodate people with disabilities, to allow access for everybody. So that's a special intervention for that group, but yet nobody suffers because of it, and everybody can benefit from it. Because if I have a broken arm, it helps me, or if I'm pushing a shopping cart or a baby carriage, the curb cuts help me as well. So there's a way to conceptualize the way we implement these things so that they accommodate those who are the most disadvantaged, doesn't hurt anybody else, and yet other people can benefit from it as well. In the paper that Marilyn included, it's the one I think it is, from California, they showed that even among white women who are middle class, they also experience disadvantages at some point during their pregnancy. And so anything that we put into place is going to benefit anybody at any particular time when they have a need. So I think it shouldn't be conceptualized as an either-or situation.
Yeah, I agree. No, I like that you said they're not mutually exclusive. I don't think they are. I think I agree with that.
So this is Paul Wise. The difference in impact on absolute rates versus disparate rates is actually a complex analysis. It's more than just equitable provision of whatever new efficacy exists. It also can relate to the differential distribution of causation. And it may be, Ed, that we may want to, if we feel this is important, to take this on as a task to bring some clarity around the epidemiologic difference between disparity creation and absolute declines, but formatted for extremely pragmatic and applied use. To just bring some clarity to how to think about this and to build interventions and policies that can address both, but in an informed way. So,
Paul Weiss, I'm going to ask a favor of you. Could you, in all of your experience, sort of help tee that up a little bit for us?
Sure. For example, one of the major clinical interventions that had an effect on certainly neonatal mortality was the introduction of surfactant to reduce mortality from respiratory distress syndrome. And we, with colleagues in St. Louis, did a study looking at what the impact was not only on neonatal mortality, but on the disparities, long-standing disparities in neonatal mortality. What we found was that the provision of surfactant was generally equitable. In other words, it was introduced to all the hospitals serving all the patients in St. Louis about the same, not completely. So some of the disparities widened because the richer kids got surfactant before the poorer kids, African-American kids, particularly in St. Louis. But the main disparity impact was that the gestational ages for which surfactant was most effective tended to account for a larger portion of the white neonatal mortality rate than the African-American neonatal mortality rate. It was kids born 30 weeks to 35 weeks. For white kids was a larger portion of the neonatal mortality rate than African-American neonatal mortality, which had a much larger contribution of kids in the 25 to 29 week range. and particularly with the surfactant early on, is that it was far more effective in reducing mortality in the white gestational ages of record. It was equally effective for African Americans and for white neonates in any given gestational age. It was just that the mortality rates for the white neonatal mortality rate was accounted for more heavily by the gestational age groups where surfactant was most efficacious. So it wasn't only the implementation, but it was actually differences in the causal patterns. And we looked at things like Back to Sleep campaign, very low tech, but its introduction was basically far better implemented in well-educated suburban communities than it was in poor and minority communities early on. So you saw a widening of SIDS rates with the introduction of something that reduced the absolute rates overall. We've also looked at interventions that have eradicated disparities, mostly immunizations. But the best way to eliminate disparities is to eliminate the thing once and for all. So we looked at diphtheria, we've looked at other kinds of sentinel cases, and it's complicated, but it's not so complicated that we couldn't come up with some generic insights that might be helpful for programs and policies and for clinicians to understand what an equity impact statement would actually look like and how to act upon what that analysis would imply. I'll stop there.
Interesting.
So this is Paul Jarris. I just want to say that this is an incredible conversation, and I think it can demonstrate the value of having what could be perceived as being an uncomfortable conversation, but sticking through it. Because I think, at least I'll speak for myself, I'm at learning, my level of resolution here is really increasing here in what everyone's saying. And I'm wondering, Paul, Weiss, and Vijaya, and others who are talking about this, maybe there is not necessarily a framework, but a way we can develop to start looking at some of these issues that's a little more sophisticated than at least the way I've been doing in the past, because as you've said, there are new innovations, there are old innovations, and for each of those there's different susceptibilities in the populations, there's different efficacy in different populations, but they're also implemented differently in different populations, and really understanding where the issue there is will be important in terms of improving both health and health equity moving forward. So again, I'm wondering if we come to some kind of a framework or a way of looking at these that would be helpful, both for addressing prior things that have been introduced that have not been implemented effectively and equitably, but also new things that come down.
Yeah, I think I share, Paul Jarris, I share your belief. This is a good conversation. We need to have more of it, and we need to find some way to move it forward in a effective way. You need a framework for talking about this framing. So I think that might be one of the issues we want to talk about tomorrow as we move forward about what the next parts of our work are.
I hate to
close off the conversation, but I'm running out of gas, and we're getting close to the 5 o'clock hour here. And it's probably, I don't know if Jean is still on us. It's probably 11 o'clock at night now in Paris.
Sounds like she's still on.
She's in the bistro. Let's sort of go around. Anything that you particularly want to highlight from today that really struck you in evaluating very briefly what happened today? Jean?
This is the operator. Jean's line is actually the one. This is the operator. Jean's line is actually the one playing the music.
Okay. Vijaya?
Yeah, I think what struck me was the notion that it could be 30 to 50 years before we achieve equity. I mean, that is really jolting to me. But then I look back on my career in public health, and 20 years ago, we were talking about similar things and trying to get people to understand social determinants and, the notion of equity and what we needed to do to achieve equity. And it's been such a slow process that, we have got to find a way to facilitate translation of these theories into practice so that people on the ground can start implementing things that will begin to show some results and that we can build on over time so that it's not another 20 years of no progress. I can't stomach that. I honestly can't.
Paul Jarris. Thanks. Paul Jarris.
Yeah, I really appreciate today.
Yeah, I really appreciate today. I thought I learned a lot.
Value the contributions everyone's made.
Value the contributions everyone's made.
And I think we've raised some really important questions.
And I think we've raised some really important questions about going forward as an advisory committee, what our role is, how we're going to structure our work. And I actually feel really good about where we got to on this issue of how do we meaningfully frame an equity framework in a way that's going to truly affect our work, because I can't remember, maybe it was you, Vijaya, who said how you hear that from everybody, but what does it actually mean they're doing? And if we can get to a place where it means that we are actually doing something important and different, that also can help other people do the same and potentially be helpful to the Secretary. So I thank everyone for today and for being included.
Colleen.
Yes.
What's your takeaway evaluation? What's your takeaway evaluation?
No, my takeaway is that I think everyone is the same goal.
Has honestly the same goals. Like, I think that we're all trying to make it fair for everyone. And I feel like maybe I'm naive, but I feel like there has been a lot of progress made. I mean, obviously, starting for a very unequal footing.
I appreciate all the data on this.
I appreciate all the data on the statistics.
My work you might be a little different just because
a lot of my colleagues are African American. I just feel like I know so many people that have accomplished so much that I guess I'm appreciative of the statistics that say that there's a significant portion of people that are still stuck, I guess, for lack of a better word. And my only comment, I guess, is there's going to be some diseases. I feel like cystic fibrosis is more common than white people. And I actually don't even really love talking about people and racial differences, but you have to do it. So say cystic fibrosis is more common than white people. Say there's some intervention that could help with cystic fibrosis and then I have better outcomes. And then I take to say, oh, we can't pursue that because it's helping white people instead of African American people. I mean, I just don't think about humans this way, so I realize that we have to achieve equity, so I understand that. So that's my only thing. Like, I'm all for equity, I'm all for pushing it forward and making things for equal people. I just don't want it to be the exclusion of something that potentially could be a great intervention that we say, well, that doesn't have equity, so we can't do that. Or, I know what I can think of right now, just in 5 minutes of thinking is like saying it's a disease that affects Caucasians more than African American people, but I look at the people around us. Nobody's really accomplished African American. That's how I view the world, because that's how medicine is. Like, there's a lot of doctors and pharmacists and nurses. It's like, I'm surrounded by really accomplished African American people, so I guess I've forgotten that there's no significant proportion that didn't get out, so I'm all for helping them get out of their circumstances and to be in an equal footing as everybody else. I think it's been a great conversation. I'm a very, like, I don't know if it's rose-colored glasses or I'm more like, I try to always look for the positive. So I want to get everyone moving forward. And I understand that equity means helping a certain group move forward faster than others. I understand that. I just feel like if there's something that we could do to help someone, I'd hate to have us not do that because it might not move one group faster than the other group. And that's the interesting thing that you get about the SIP and being an anti-politics. So, like, I think that is, the way you look at that data can kind of be, you have to look at it with an understanding of premature infants, and that would be that many gestational age African American babies are actually healthier than Caucasians from a lung standpoint. So I have to look at that, like, how is it that, so if you have a 31-week baby who's Caucasian, the odds that African needs surfactant is a lot higher than an African American baby who needs surfactant, simply because they don't need it and their lungs are healthier without it. So I have to look at the data that you quoted because there's so many nuances to that the fact that African American baby didn't get the surfactant might very well mean they don't need it. So if you look at the anti-toxic, this is well published data, like African American girls do far better from a lung maturity standpoint than like a white male would be at 5. So, and Hispanics are kind of in between. So that data about the surfactant has a lot of nuances buried within it. It might, someone might say, oh, that might be a racist approach to giving surfactant. It might actually be that the African American babies didn't qualify by due to respiratory distress and fraction of increased oxygen being administered to the baby. So I guess there's ethnicity involved in the field that I work in, obviously. So it's like, I guess that data is very interesting to me because I have to like read through a bunch of quotes to see is that really, is it racism that they didn't get the factor, or do they just not need it because they typically are healthier? So if they're 25 weeks, everybody should get it. But if you go up to 31, 32 weeks, most African American babies don't need it. They come out screaming and they're fantastic.
There's room for more evaluation in that, so thank you.
Yeah, and I just hope that, like, all my African American friends here don't misinterpret anything I'm saying. Like, I really am, like, in full support of everything that you guys have accomplished and are trying to accomplish here. I just always, there's like, when I hear certain buzzwords like North Scott, it's like that little bell in my head. Maybe that might, we got to pull back a little bit from like this Star Wellness. I don't know, but I consider all these friends and colleagues, and I don't mean anything, sometimes I play devil's advocate a little bit, I guess, but I'm hoping that nobody misconstrues anything I'm saying.
All right, we got to go move on here. All right, Janelle. All right, we got to go move on here. Janelle.
That leapt out at me a little bit. Because, this is maybe more a little bit for Colleen, maybe to understand possibly that surfactant issue within history, and this is controversial. But some would say if you look at the results of that study and you look at the results of that study within the surfactant study in African American babies in the context of history and epigenetics, that African American people possibly have had as a whole genetically have been far more under stress, so possibly have changed their genetics. And maybe that the survival comes out when they're very controversial, and that's very controversial, and that could be one take, one reading of that the results of that study. But that just might be somewhat helpful to kind of understand how history and epigenetics might have been a part of that study. So what I take away today is that the reframing issue, how to get everyone sort of invested in a combined goal that everyone can see that affects them. Instead of, and that was done with the presentation on abuse in children. Basically, instead of talking about violence and abuse directly using those terms, let's reframe it a little bit differently so that we can all connect to it and find solutions together. So that was really helpful today.
Great, thank you.
Thank you for a long
and persevering day, especially for those who are able to survive with technology. All the more reason to advocate time together, especially if we're going to take on such juicy and challenging issues. So one is thanks for the day. Second, I am aware that there is a series of tensions that surface today, and particularly around the urgency of doing something and the long arc of what is likely for significant change to happen. So I encourage us to continue to name these dilemmas and tensions and not succumb to them. So I just want to put that out there for as we evaluate by tomorrow, and that we have the capacity to be able to not turn down the heat with those tensions, to turn it up a little bit, and to be disruptive so that we don't succumb to the low expectations of prior SACIM. And then last, I think that this particular conversation to be continued tomorrow is the second beat of the waltz of our first 9 months together. So if I zoom out, our one day in December was sort of an on your mark. Today and tomorrow, we better get set so that we know how we're going to structure this work strategically and how we're going to be very clear and deliberate. So by the time we are going by the fall, we are doing so with eyes wide open and in alignment strategically. So I just want to put in perspective how hard this work is, and that being ready to do it is our most important work today and tomorrow. Thank you.
Yes, this is Belinda. I have enjoyed all of the discussions. Belinda. I have enjoyed all of the discussions. I think it's important for us to hear all of the various viewpoints. I do think it is critical for us to get a framework, and I don't know, Vijaya, if it helps Stephen look back at some of the work that you did with the 12-point work with Milk Coddle-Church and Michael Lou and others at some point. I don't know. But I do think reframing or changing the narrative is going to be critical for us moving forward, because I think we have to think through how to get the message out and that people will be actively engaged and see themselves in it. And I really appreciate you, Ed, keeping us on task and focused today. Thank you.
All right.
Hi, this is Paul. First little thing, I'm sorry I posted ruckus with the surfactant stuff, but we did consider the African-American low birth weight girl issue. I'm happy to send the paper and you can take a look for critical. I've just been really impressed with the expertise that's been gathered in this committee and the experience and how well we could work together. My hope is that we make choices that will enhance the utility of this committee, particularly at a historical moment when both medical care and social investment are going to be the focus of broad and intense public discussion. So thank you very much for everybody, and I feel very good about the ability of this committee to make a contribution. I also want to apologize that I will not be able to join you tomorrow. My daughter will be having our second grandkid, and so I will not be able to be on the call since I'm going to be attending to childbearing within my own family. So thanks very much, and I look forward to working with you all. Yeah, thank you. Congratulations.
For the elective delivery.
Congratulations.
Yeah.
Good luck. So we'll miss you tomorrow.
Congratulations. Good luck. So we'll miss you tomorrow.
Thanks to everybody today. This was a great discussion.
Thanks to everybody today. This was a great discussion. I've learned a lot. If anybody wants to send me an email with any suggestions or thoughts, feel free to do that tonight, or any times of helping to frame things. And then we'll get back together again tomorrow. I just want to close with a quotation from Ilka Chase, who's a writer who wrote Imperfect. and she was talking about democracy, so I'll change it a little bit about to say infant mortality is not an easy form of activity because it is never final. It is living, changing organism, a continuous shifting, adjusting a balance between individual freedom, equity, community needs, and the general order. It is a complex issue that we're dealing with lots of moving pieces. They're all interactive. And we really struggled with some of those today, and I hope we continue to struggle with them. But I hope we were able to struggle and put them into some form that will help to move this committee forward and help move our country forward as we address infant mortality with the frame of equity. So thank you all, and I'll turn it over to David to send us away.
So thank you, Alan. This was exciting. We weren't sure how this was going to go, a full day of being online, but I appreciate your dedication and commitment and your active participation. We will start right on time at 10 o'clock Eastern tomorrow. It's the same login information, both phone and webinar. And if anything comes up overnight, I'm also available. Just send me a quick email. Otherwise, I will see you all, or hear from you all tomorrow morning. So thanks very much. We're adjourned.
Thank you all.
That does conclude today's conference. All participants may disconnect. Thank you for your participation.